Good morning, everyone, and welcome to today's New York City Council hearing for the Executive Budget Fiscal Year 2025 hearing for the Committees on Finance, Health, Mental Health, Disabilities, and Addictions. At this time, we ask that you silence all cell phones and electronic devices to minimize disruptions throughout the hearing. If you have testimony you wish to submit for the record, you may do so via email at testimony@council.nyc.gov. Once again, that is testimony@council.nyc.gov. At any time throughout the hearing, do not approach the dais. We thank you for your kind cooperation. Chairs, we are ready to begin.
Thank you, Sergeant. Okay, good morning and welcome to the sixth day of FY25 executive budget hearings. I'm Councilmember Justin Brannan, and I chair the Committee on Finance. Today's hearings will begin with the Department of Health and Mental Health, followed by New York City Health and Hospitals. And I'm pleased to be joined today by my colleagues, Councilmember Lynn Schulman, Chair of the Committee on Health, and Councilmember Linda Lee, Chair of the Committee on Mental Health, Disabilities, and Addiction. Been joined this morning by Councilmembers Williams, Hanif, Narcisse, and Moya on Zoom. I want to welcome Commissioner Dr. Vasan and your team. Thank you for joining us today to answer our questions. Just to set the table, on April 24th, 2024, the administration released the Executive Financial Plan for FY24 to 28 with a proposed FY25 budget of $111.6 billion. DOH-MH proposed FY25 budget of $2.15 billion represents 1.8% of the administration's proposed FY25 budget in the executive plan. The total budget increased by $88.2 million, or 4.3%, from the initial $2.10 billion originally budgeted in the FY25 preliminary plan. This increase results from several actions, mostly from a rollover of $22.2 million in federal funding from FY24 to reflect unspent COVID relief funds. As of March 2024, DOH-MH has 412 vacancies relative to their budgeted headcount in FY24 and 216 in public health and 196 in mental hygiene. In the Council's preliminary budget response, we called on the Mayor to add $10 million to DOH-MH public health budget for maternal and child health services, including the Nurse-Family Partnership, cancer screening, and a pilot to help New Yorkers fighting diabetes to access glucometers for citywide, for free citywide, and $43.1 million to the mental hygiene budget for supportive housing and mental health support programs. The DOH-MH budget does not include a single dollar towards any of these proposals from the Council, even though the Council's response identified $1.63 billion in unrecognized resources that accounts for risks and costs from under-budgeting, while still making investments in key programs such as these. Prioritizing these investments doesn't just relieve economic uncertainty of everyday New Yorkers, generating a stronger city and accelerating our economic recovery, but in this particular case, it can actually save lives. My questions today will largely focus on utilization of city funds, the medical debt relief program, and funds from the opioid settlements. I now want to turn to my co-chairs for this hearing, Councilmember Schulman, followed by Councilmember Lee for their opening statements, and I will just note that we've been joined by Councilmembers Carr and Farias. Councilmember Schulman.
Thank you, Chair Brannan. Good morning and welcome to the City Council's hearing on the fiscal 2025 executive budget for the New York City Department of Health and Mental Hygiene, jointly with the Committee on Finance. I'm Councilmember Lynn Schulman, Chair of the Committee on Health. I would like to thank the Finance Chair, Justin Brannan, as well as my fellow Chair, Councilmember Lee, for holding this joint hearing. I would also like to thank everyone who has joined us today. The DOH-MH fiscal 2025 budget in the executive plan totals $2.5 billion and includes $1.3 billion for public health services, which represents approximately 1.2% of the city's budget. The budget is $44.3 million less than the fiscal 2024 adopted budget and includes $461.3 million for personal services and $830.6 million for other than personal services. Of this amount, for other than personal services, $299.2 million is for the contract budget. While there were no pegs in the executive plan, we must recognize that the pegs in the November and preliminary plans are still impacting DOH-MH's budget. Multiple contracts related to HIV/AIDS services and care have been decreased or eliminated due to the contract reduction savings. We find it very concerning that these contracts have been reduced or eliminated because the services that these organizations provide are vital to the city. The council would like to clarify the decision-making process that went into reducing these contracts, and we would like to understand whether DOHMH plans to reinstate this funding in the future. In the beginning of April 2024, the council released its budget response to the mayor's preliminary financial plan. In the response, we focused on several critical public health programs. The council urged the administration to include additional baseline funding for the Maternal and Child Health Services Initiative and the Nurse Family Partnership. We also requested additional funding for Healthy NYC Learning Collaboratives and funds for a new pilot program to provide free glucometers and cancer screenings that would be free at cost for New Yorkers. Unfortunately, despite their critical importance to the health of New Yorkers, these programs were not funded in the executive plan. The committee would like to understand why these programs were not included in the executive plan and to discuss the option for these programs' inclusion in future plans. In addition, the committee would like to gain a better understanding of budgetary actions taken in the executive plan related to the citywide diabetes reduction plan, the public health laboratory, and the medical debt relief program to better understand their budgetary implications and any strategies DOHMH has to efficiently utilize city dollars while providing critical services that New Yorkers deserve. Before we begin, I would like to thank the committee staff, Danielle Heifetz, Florentine Cabor, Christopher Pepe, Sarah Sucha, and Manor Butt for their support. Lastly, I would like to also thank my Chief of Staff, Jonathan Boucher, my Legislative and Budget Director, Kevin McAleer, along with my Legislative Fellow, Andrew Davis. I will now turn it over to Chair Lee for her opening remarks.
Good morning, everyone. Happy belated Mother's Day for all those celebrating and all the amazing women. So today we're here, I'm Councilmember Linda Lee, to discuss the 2025 executive budget for mental health and our services, and just wanted to thank Finance Chair Justin Brannan and Health Chair Lynn Schulman for co-chairing this hearing with me. And also thank you to Commissioner Vassan and everyone from DOHMH who came here today to testify. DOHMH's executive budget for mental health services is $756.8 million, which is $11.6 million less than at adoption. The budget includes $63.1 million for personnel services and $693.7 million for other than personnel services. Of this amount, for other than personnel services, $301 million is for contract budgets. The Council's response to the preliminary budget requested a total of $43.1 million in increased funding in the fiscal 2025 budget for DOHMH, including $19.6 million for 1515 supportive housing. As we heard from many stakeholders at the preliminary budget hearing, the 1515 supportive housing is falling short of its goal to create 15,000 new units of supportive housing by 2030. Additional funding would allow 1515 supportive housing to expand, ultimately helping more New Yorkers with mental health needs get connected with housing. And we will look forward to hearing from the agency on their efforts in this important program. And as we know, housing is one of the most important social determinants of health. So we hope to and look forward to hearing on your response to that. And finally, we would like to revisit the topics of clubhouses, trauma recovery centers, forensic assertive community treatment teams to ensure that the administration is investing in these critical programs for New Yorkers that greatly rely on them. And at the preliminary plan hearing, we heard from DOHMH, and I know that you testified that you support clubhouse RFPs, expansion of a lot of these programs, and we know how important this is for community-based services. And many community-based organizations and stakeholders have reached out, both in the public testimony and after the hearing, to express concerns that they had with the clubhouse RFP. And as you may know, this is a major topic for mental health services in the city, and it's important to make sure that we listen and consider the feedback of community-based organizations that are actually doing the work on the ground. And I'm looking forward to a conversation that will move New Yorkers closer to services to meet them where they are. I'd like to thank my committee staff, Danielle Heifetz, Florentine Cabor, Sarah Sucher, and Christy Dwyer for all their work. And I would also like to thank my staff, Amanda Vasquez and John Wani, as well as the rest of my team for their support. And with that, I will now pass it back to Chair Brannan.
Thank you, Chair Lee. Before we get started, I also want to just take a quick minute to thank the entire Finance Division works very, very hard this time of year behind the scenes, preparing for these hearings, especially, of course, Florentine and Danielle Heifetz for today's hearing, Committee Counsel Mike Toomey, my senior advisor John Yedden, all the analysts who make these hearings work. As a reminder, for this year's executive budget joint hearings, we're taking public testimony on an agency's budget the same day, meaning after testimony is concluded today, instead of holding one long day at the end. So if you wish to speak on the DOHMH or the Health and Hospitals FY25 executive budgets today, make sure you fill out a witness slip with the Sergeant at Arms. I will now turn it over to Committee Counsel Mike Toomey to swear in our witnesses, and we can begin. Quickly, we've also been joined by Council Members Moramato, Ariola, Lewis, and Abreu.
Good morning. Can you raise your hands, please? Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to councilmember questions? Dr. Ashwin Vasan. Aaron Anderson.
Yes, I do.
Thank you. You may begin.
Good morning. Good morning. Speaker Adams, Chairs Brannan, Schulman, Lee, and members of the Finance, Health, Mental Health, Disabilities, and Addiction Committees. I'm Dr. Ashwin Vasan, Commissioner of the New York City Department of Health and Mental Hygiene, otherwise known as the Health Department. I'm joined today by our Chief Financial Officer, Aaron Anderson, and members of my senior leadership team. Thank you for the opportunity to testify on the department's executive budget for fiscal year 2025. I'm very excited to be here in May, which is Mental Health Awareness Month. The Health Department kicked off the month by amplifying mental health care services to New Yorkers struggling with mental health or substance use issues through our social media channels, including information on how to reach 988 via phone or text, or by visiting nyc.gov/988 for 24/7 support. We also promoted our services that support young people, elevating messages about NYC Teen Space, which provides free, confidential, and ongoing support from a licensed therapist, which can be found at talkspace.com/NYC. I want to thank the City Council for being a critical partner in getting this information out to your communities. This week, we will be sharing more information and data on NYC Teen Space from the first 6 months. I'm very proud to say that the program in its first 6 months is already a success. I can share with you today that Teen Space has connected with thousands of young people in exactly the communities we were hoping to reach. Additionally, I'm excited to share that the Health Department will be releasing our first State of Mental Health report later in the month. This report will provide a broad overview of the mental health of New Yorkers leading up to and following the COVID-19 pandemic. These data are essential to understanding access and use of mental health services and to informing our policy efforts to promote the mental health and well-being of all New Yorkers. Two additional areas that I want to highlight are the department's work on social media use and our signature initiative, Healthy NYC. Earlier this year, I issued a Health Commissioner's advisory identifying unfettered access to and use of social media as a public health hazard. This followed months of work, including Social Media Action Plan and New York City's Social Media and Youth Mental Health Summit. Additionally, the city filed a lawsuit to hold TikTok, Instagram, Facebook, Snapchat, and YouTube accountable for their platforms' damaging impact on the mental health of young people in our city. We are committed to ensuring youth well-being in the digital age by bolstering our tools available to protect our children. However, we need robust state and federal intervention to establish standardized regulations, provide adequate resources and enforcement power, and foster collaboration across jurisdictions. We've also been busy implementing Healthy NYC, our ambitious initiative to improve and extend the lifespan of New Yorkers by addressing the leading causes of death and premature death in New York City. To achieve this, we have set targets to reduce mortality from the leading issues killing New Yorkers, things like chronic and diet-related diseases such as diabetes and heart disease, screenable cancers, mental health including overdoses and suicides, Black maternal health, COVID-19, and violence. Healthy NYC centers health equity in its approach. We must address the Black maternal mortality crisis, racial disparities in chronic disease, and the disproportionate burden of violence in Black and brown communities in order to improve the health and well-being of all New Yorkers. We are hard at work preparing a citywide campaign and learning collaborative, as well as engaging in economic and population health modeling that will help shift funding to prevention activities with higher returns on investment that will deliver on reducing mortality, extending life, and reducing inequities. This requires a whole-of-government approach, as well as working with local and community partners, hospital systems, and many other stakeholders throughout our city. We're only able to do this important work and strive for more thanks to continued support from the administration and from City Council. Lastly, I'm pleased to introduce two new members of the department's senior leadership team, Dr. Jean Wright, who joins us as the new Executive Deputy Commissioner for Mental Hygiene. Dr. Wright is a behavioral health expert who specializes in severe mental health issues, substance use and dependence, co-occurring disorders, and forensic psychology. He is joining us from the Department of Behavioral Health and Intellectual Disability Services in Philadelphia. I'm also pleased to welcome Simone Hawkins, who will be serving as the department's Chief Equity Officer and the Deputy Commissioner for the Center for Health Equity and Community Wellness. She will oversee and advance the department's work, increasing our understanding of health inequities and capacity for action to help end health disparities, with the focus on ending racial inequities. Before I discuss the executive budget, I'd like to take a moment to discuss both state and federal fiscal considerations which have evolved since our preliminary budget hearing in March. State and federal dollars make up nearly half of the health department's budget, and we have been closely monitoring the actions of our state and federal partners with great interest. Let's start with the state. The New York State fiscal year 2025 enacted budget includes investments in the mental health and well-being of children and families that align with the city's goals. We are pleased to see important initiatives to support child and family health in the final budget agreement, including paid prenatal leave for medical appointments, paid breaks for the purposes of expressing breast milk, continuous Medicaid enrollment for children from birth to age 6, and the establishment of a statewide doula standing order. We are very glad to see the state increased early intervention in-person provider reimbursement rates by 5%, with an additional 4% increase for rural areas and underserved communities. We look forward to learning more about the state's administrative actions to implement this provision. Children in underserved areas of New York City, primarily communities of color, are experiencing delays in in-person services that are crucial for their development. This budget is a first step in reducing these inequities. We have pushed for this change to incentive equitable early intervention service, so we are very pleased with this news. We're also glad to see an additional $3 million in funding for school-based health centers and a one-year extension of the temporary carve-out for school-based health centers from Medicaid managed care. I'm thankful a funding crisis for these critical resources has been averted for yet another year. However, we still need a permanent carve-out, and I hope the Council will join us in our continued advocacy for this. Unfortunately, we are disappointed to see that language that would implement the Stop Addictive Feeds Exploitation for Kids Act, or SAFE Act, was not included in the final budget. As I mentioned earlier, it's vital that the federal and state government take action to regulate unfettered access to social media for our children. I want to thank the Governor, Attorney General, Senator Gennardis, Assemblymember Rosick for their support and dedication to this issue, and I encourage the New York State Legislature to pass this legislation before the end of session. While the budget demonstrates a strong commitment to public health and health equity, we are once again disappointed with the lack of reinstatement of the city's Article 6 funding. 5 years ago, as you know, New York State cut Article 6 public health funding to New York City from a 36% match on the dollar to 20%. This cut was to New York City only. If parity was restored for this funding, we project the city would receive an additional $90 million of support for critical public health services. These are funds that can be used to address rising rates of vaccine-preventable diseases, sexually transmitted infections, and TB, as well as the growing crisis of overdoses and Black maternal health inequities. Moreover, New York City is home to the largest portion of Medicaid recipients, people of color, and low-income individuals in the state. This exclusion exacerbates health inequities and ultimately adversely impacts the well-being of all New York City residents. New York State has an obligation to support the health of all New Yorkers, not just some. This means that New York City must be funded at the same rate as every other county in the state. Turning to the federal government, I thank President Biden, Leaders Schumer and Jeffries, and the New York congressional delegation, and Health and Human Services Secretary Becerra for their consistent support and dedication in fighting for public health. We're pleased to see that the final omnibus spending bill passed by Congress and signed into law by the President did not include severe House proposed cuts to the Department of Health and Human Services. However, we're very concerned about the consistent attacks on public health funding. As I hope we've learned from the pandemic, investments in our public health infrastructure strengthen our ability to respond effectively to emergencies, prevent future outbreaks, manage chronic disease, and ensure equitable access to health care. We urge Congress to recognize that public health is a bipartisan, critical area of work that saves lives. And although we were spared significant budget cuts, we have seen concerning policy shifts in areas that were once widely supported, including the global fight against HIV/AIDS, PEPFAR, and emergency preparedness, PAPA, to name a few. We also see concerning shifts in access to reproductive care across the country as a result of the Supreme Court's decision to give states the authority to strip people's access to reproductive health care. This is causing chaos and harm for people in need of essential medical care. The political battles resulting in short-term and delayed reauthorizations to enact de facto bans on medical procedures contributes to uncertainty among local governments, healthcare providers, and millions of people served by these programs. Politics should never interfere with access to healthcare. We work best as a city and as a nation when we work together. This is proven by recent bipartisan, bicameral discussions and proposals to prioritize the health and safety of our kids online. Congressional hearings in both houses have addressed the dire need to protect children and teens from the harms of big tech companies, including excessive data collection, targeted advertising, and addicting algorithms. We are encouraged by the recent introduction of the Kids Online Safety Act, KOSA, bipartisan companion bill in the House as well. It's critical for Congress to come together to prioritize the passage of KOSA sooner rather than later. Children are particularly vulnerable to online risks such as cyberbullying, exposure to age-inappropriate content, addictive feeds, and mental health issues such as anxiety, depression, and low self-esteem that can result. While social media and technology competency offer children socialization and skill development benefits, unfettered access has shown to be detrimental to children's health and well-being. We're proud of New York City's efforts to hold social media companies accountable, but we cannot do it alone. We need our state and federal partners to give us tools for action. KOSA would do just that. We urge our federal and state colleagues to continue their work to pass KOSA and the Safe for Kids Act as soon as possible. Now, I'll take a few moments to speak to our executive budget. The Health Department has approximately 7,000 employees with an operating budget of about $2 billion for fiscal year 2025, of which approximately $1 billion is city tax levy, and the remaining $1 billion from federal, state, and private dollars. We're glad that, due to early actions we took to identify savings to help balance the city's budget, we are able to forego a peg in the FY25 executive plan. We are also grateful for several initiatives that I want to highlight as a result of this plan. The executive budget added approximately $97 million over 3 years to the department's budget. These include $18 million over 3 years for the Medical Debt Relief Initiative, the largest municipal medical debt relief program of its kind in the country. We announced this initiative earlier this year and are extremely excited to see it come to fruition. Medical debt is a huge burden on individuals and families that contributes to financial strain, undue stress, avoidance of medical care. Additionally, Black and Latino communities face a disproportionate risk and burden of medical debt. This compounds existing unjust financial burdens and barriers to economic mobility and healthcare access. By alleviating this debt, the city is taking an important step towards ensuring all residents have equal opportunities to access critical health care and achieve better health outcomes. An important measure we are taking to retain frontline workers in the healthcare system and combat financial stress on the system is adding $25.6 million over 3 years for cost of living adjustments for human service providers. These individuals provide essential healthcare services for our most vulnerable populations and play an important role in safeguarding the health of our city. However, they are not immune to rising costs and inflation. By providing these much-needed adjustments, we are demonstrating our unwavering commitment to human service workers, who are overwhelmingly comprised of women, and particularly women of color. These adjustments will not only promote equity, but ensure resilience in our healthcare workforce. I know that the City Council was a key partner in ensuring that this funding was included in the executive budget, and I'm grateful for your advocacy. The executive budget also includes an additional $5.6 million in FY25 and $9.1 million in FY26 to pay for overdose prevention programming. This comes from the opioid settlement funds. The department will be using this funding to expand substance use prevention, harm reduction, treatment, and recovery services. More details will be released soon. So as I wrap up, I want to thank the staff of the Health Department for their steadfast commitment to the health of this city. I'm confident that we have the team to make this city healthier. I thank Mayor Adams for the resources dedicated to the department in this executive budget and for his continued commitment to public health. Thank you to the Speaker, chairs, and members of the committees for your partnership and dedication to protecting and promoting the health and well-being of all New Yorkers. Thanks again for the opportunity to testify, and I'm happy to take your questions.
Thank you, Doctor. We've also been joined by council members Ayala, De La Rosa, and Salam. You mentioned in your testimony that the DOH-MH budget is primarily funded through city funding, so it's about $1 billion, or 49% of DOH-MH budget is city funding. The remaining $1 billion is from federal, state, and private dollars. Which public health projects are funded with city funding exclusively?
It's a complicated question. So yeah, it's about half and half, and it's not symmetrically spread out across issue areas. We have some, and we'll get into this further with some of the more specific questions, but some entire areas are almost entirely federally funded, federally and state funded, and other areas almost get nothing. So we're happy to get back to you with more of a breakdown, but it's spread very asymmetrically across our.
Yeah. I think that's part of.
Which makes it really challenging.
I think that's part of our concern, is that there's little transparency as to which projects are funded with city funding versus other funding. So could you commit to getting us a full breakdown?
Yeah, we're happy to do that. Thank
Okay.
you.
In the executive plan, city funding has decreased in 11 programs. Which projects or services which were reduced are expected to be replaced with other sources of funding?
So, as you know, we went through this PEG exercise over the last several budget cycles. None of us wanted to do that, but we think it was an important, it was requested of us as an important step to balance the city's budget, and we're very grateful that we don't have to do it again in this budget. I want to say, of the $75 million that we were asked to, that was requested of us to cut, 80% of that was found through efficiencies that do not impact direct services to New Yorkers. So efficiencies might include, as you said, finding other revenue sources like programming, previously funded city dollars towards state and federal sources, finding new sources of reimbursement, and other forms of administrative efficiencies that New Yorkers won't see and won't impact direct services. So 80% of our cuts were actually on that back end.
So what are
only
those?
20%.
What do those
affected
administrative service efficiencies look like? What is that in real?
Yeah, so it could be as simple as saving money on overhead, things like paper and supplies and office supplies and printing and things like this. It can also be, you know, we did take some vacancy reductions in areas of work that, for instance, were launched during COVID. Our budget was inflated to over $3 billion during COVID, with awash with federal funding, and all of that's disappeared or disappearing. And so programs were launched during that time that never truly got off the ground, or programs were launched that got off the ground that then funding has expired. So some of that was headcount reduction, vacancy reduction, I should say, for programs that never really got off the ground or that we struggled to recruit for. For instance, staffing, clinical staffing that we really struggle to recruit for because the city's salaries don't keep pace with the labor market in the private healthcare systems and the for-profit healthcare system. So these are just some examples.
So as of March 2024, there were 216 vacancies in public health positions and 196 vacancies in mental health positions. Are you currently in the process of filling those vacancies?
Yeah, we're very pleased to say that, when I became commissioner 2.5 years ago, we had something on the order of a 30+% vacancy rate, and we've managed to reduce that down to something on the order of 10%. And we're still active in trying to fill every vacancy that we have.
Could you tell us which vacancies you're prioritizing filling?
Well, they're all priorities, but we do certainly try to fill our frontline services work staffing first. We know that that's the work of the city that people experience, so we want to make sure that those are staff lines that are filled. So often those are the ones that we struggle to fill.
So those are the ones you see the highest vacancy rates in too?
It's not really consistent across the board. It really depends on the program and depends on the corresponding labor market that we're up against. For instance, healthcare. Often our jobs are up against healthcare jobs. And so we have lost and do lose people to healthcare systems that can just pay considerably more. Even our own public safety net system can pay just considerably more than a city agency can.
So when you eliminated some of those vacant positions for the PEGs, which positions did you eliminate?
Well, ones that have been vacant for a long time that we have really struggled to recruit for, those are ones that we tend to focus on. We tend to focus on programs or areas of work that never truly got off the ground. For instance, big commitments that were made during COVID to expand this or to launch this that never truly got staffed up for all of the reasons during COVID and turnover and so forth.
One of the things we're dealing with across the city is a large amount of programs that were propped up with temporary federal dollars. We have a lot of permanent programs that were funded with temporary money. Are there programs that were propped up during COVID and funded with COVID money that now you're struggling to sustain?
COVID has been such an inflection point for our agency and our city that two things are true. There are programs that were launched during COVID that have proven to be really quite critical to the future of our department and our city that we're now actively looking at finding permanent funding for, either through new revenue streams from state or feds, or through new commitments of our own budget, either internal redirections of agency budget or new requests from OMB to OMB. So there are definitely programs that fall into that category. Some of our community health work that was dramatically expanded during COVID. Wastewater surveillance, which is largely federally funded, but at some point we are going to have to find our own budget for this. So there's more and more contact tracing. I mean, these are areas and disease investigators. We've seen federal cuts come down the line through CDC that we now have to pick up. We can't not have a workforce of contact tracers and disease investigators. So we're working on ways to pick that up over this fiscal year and the next one in particular.
I want to talk about the opioid settlement funding. It's increased in DOH, MH, and OCM, the medical examiners' overall budgets. DOH, MH FY25 executive budget includes $15.4 million in FY24, $24.2 million in '25, and $27.7 million baseline starting in FY26. Can you provide us with a breakdown of the usage of the opioid settlement funds and how much funding is allocated to each of these program areas?
Yeah, we'll have more details to release very soon, but the second tranche of the opioid settlement dollars is reflected in the executive budget. There's an additional $5.6 million in FY25 and $9.1 million in FY26. That's on top of the first tranche that we received.
And is that being used for new programs or to enhance?
In some cases, it's expansion of existing programs to citywide current overdose prevention initiatives like our non-fatal overdose response programming, harm reduction services at syringe service providers, and expansion of treatment and recovery services. We've taken a bit of a policy, we've broadened our aperture and our policy aperture to really emphasize that treatment is a part of a portfolio of interventions that we need to invest in. And treatment rates in our city through, not simply because of the city's actions, the state runs most of the treatment in the city, but treatment rates have gone down in New York City, and we're working hard to make sure that those are increased.
How does DOH-MH collaborate with OCME on the usage of the opioid settlement funding? So I see the agency budget showed a baseline transfer of $2.2 million to OCME in '24 and $3.1 in FY25 in the out years. Could you talk about why that funding was moved from DOH-MH to OCME's budget?
OCME has launched a program, I believe it's called the DIG program. It's been written about, which brings social workers and mental health support to the families and victims who have lost a loved one to an overdose, partly based on data that shows that families often have multiple people in first or second degree relatives that face substance use issues, and that their risk of overdose subsequent to losing a loved one increases. So OCME launched that program, and from a fiscal perspective, I think we still administer their budget.
So is it correct, DOHMH has 3 full-time positions under the opioid settlement funds, OCME has 11?
We can get back to you on the head count. I'm not sure that that's accurate. Aaron,
Okay.
do you have thoughts?
Yeah, Councilmember, yes, the 3 is correct, and I think we're still finalizing discussions around.
And what
the
do those
exact
3
amounts
people
for
do?
OCME and DOHMH. Sorry,
What do those 3 people do?
I think we'll have to get back to you on the specifics.
This is the OCME program you're referring to, Councilmember?
Yeah, well, no, yes, well, I'm talking about, there's 3 positions that are DOHMH positions that are funded from the opioid money.
At DOHMH?
Yeah.
Okay, well, yeah, we'll get back to you on the details. Thanks.
Okay, I don't want to take up too much time because we have a busy day here. So, but I do want to ask about asylum seekers. As it stands today, what specific services does DOHMH provide for asylum seekers?
Yeah, we're very grateful for the asylum seeker response, and frankly, our role in it is much more constrained and narrow than some of the other more expansive agencies that are taking on the bulk of the funding and the activities. Our role is fourfold. Number one, we focus on insurance coverage. So most asylum seekers who have an active asylum case are actually eligible for Medicaid under state and federal law, and getting them enrolled into Medicaid is essential. Number two, we're focused on communicable disease surveillance, in particular around vaccine preventable diseases, and ensuring that we are getting people vaccinated in both their intake and as well as throughout the many, many DHS and H&H shelter systems throughout the city. Number three, things like tuberculosis and other communicable disease management is really essential. And number four is mental health services, especially trauma work. We bring our staff on site on demand to address issues of mental health crisis and trauma in this population.
Is there overlap between the services DOHMH and H&H provides?
There shouldn't be, so we have a very narrow purview, and so we are brought in to address active disease prevention. We collect all the disease surveillance data, and we respond when we do see an increase in cases, just as one example. There should not be any redundancy in services.
Okay, the medical debt relief program. Executive plan includes $6 million for FY 25 to 27 for the undue medical debt program, formerly known as RIP medical debt. When is this program scheduled to begin?
Thanks, Councilmember. We are very excited about this program, as you are, I know, and we're very grateful that it was fully funded in the executive budget over the next 3 years. We have $6 million appropriated over this year and the next 2 fiscal years after this one. We are currently in the process of finalizing the contract with RIP Medical Debt, and then the program will start. There's absolutely nothing that's being asked of New Yorkers. There's no enrollment. There's no sign up. They will just start getting letters.
What's the guidelines for eligibility?
We'll get back to you on the specifics, but it's a couple of things. It's the percentage of your income that represents the percentage of your income that your debt load represents, and it's also where you are against the federal poverty line. I can get you the exact cutoffs.
Are there any limits to the type of medical debt that can be relieved?
Can you say more? What kind of limits?
I guess I'm trying to, it's going to be proactive that DOHMH is going to sort of figure out this criteria and then proactively reach out to these folks?
Correct. RIP Medical Debt, DOHMH are working directly with our hospital systems across the city to identify their eligible fraction of people who carry debt at that institution, and then to send them letters. I don't believe there are any exclusions on the type of debt, but I can certainly get back to you with details.
And the plan is to spend $18 million to eliminate about $2 billion of medical debt, right?
Correct.
Okay. I want to ask one question that's personal to me. The mobile eye care pilot, it's originally funded in FY 23. Every year it gets rolled over, and they tell me they're going to do it next year. hoping this is the year that we actually do it. The funding has been rolled over again, this time into FY25. Could you tell me why the program's implementation has been so delayed?
Well, good news, and I understand your question. I know how important this is to you. The good news is that we've identified a vendor, and we've been working with the vendor to develop a scope and a budget. All of this was put on pause during the PEG and the OTPS freeze, which explains why it had to carry over. If it wasn't for that process, it would have been done, would have been started this year.
When's the program anticipated to begin?
We're still awaiting approval from our oversight partners, including OMB, but we're working hard to get it done.
Okay, last question from me is about the impact of the contract reductions on some of the mental health programs. Included in these reductions was in funding for contracts for support and connection centers. As you know, there's currently only 2 locations. There's one in Harlem, there's one in the South Bronx, which will close as a result of this contract reduction. I think it's a $3.4 million reduction. What's the rationale for closing this center, and how many individuals are served at each of those sites in East Harlem and the South Bronx?
We can get back to you on the number of people served, but therein lies part of the problem, is that the reduction that we put into place is for a site that really has really struggled to enroll people. And if you might recall the history of this, this started early in the last administration as first was called NYPD diversion centers, and then the model evolved over time, and then was launched late in the last administration. The good news is this: the state has now come through with a very similar model called crisis stabilization centers, and they're actually actively putting new money into it, and we're exploring now changing the designations of these programs to be eligible for those state fundings. The state funding, the site that will close is certainly one that really struggled to get off the ground.
Why do you think that is?
You know, I think there's been quite a bit of confusion around the model and where it fits into the complicated crisis management system and crisis stabilization system that we have as a city and frankly as a country. No one's really figured this out in terms of our crisis stabilization system. And so I think this was a good faith effort to build up a new model that would offer alternatives to law enforcement officials to bring people elsewhere other than central booking or an emergency room when they see someone with mental health needs. And so I think that was a very good faith attempt to build something up. I think what we found is that through the buildup of other programs, changes in policies, and also, frankly, just issues with staffing and rollout of these programs themselves, that they haven't been used as consistently as we.
But in your estimation, they were both set up to succeed?
I think with any model, this was a new model that was created by this city. Again, as I said, it was conceived early in the last administration, and then through a lot of discussions between agencies, even with council, because I know there was testimony about diversion centers. This changed over time. There was real issues with siting that took forever, I think, in the last administration. And so I think it was a good faith attempt to build something new and to offer alternatives, because no one wants to see, and law enforcement is saying the same thing, they don't want to be in the position of being mental health workers, and so we're trying to offer as many solutions as we can.
And when's the Bronx site slated to close?
We're working with them on this transition right now.
Okay, that's going to be all from me. We've joined by council members Menon, Osei, and Powers. I'm now going to hand it over to Chair Schulman. Thank you, Doc.
Thank you.
Thank you. So the November and preliminary plans included funding reductions of $4.9 million in fiscal 2024 and $9.3 million in fiscal 2025 that significantly impacted programs including HIV/AIDS-related services. We've been informed by several community-based organizations that some of their contracts with DOHMH for critical services and treatment have been either reduced or totally eliminated. Can you tell us what contracts were eliminated and what was reduced and why?
Yeah, I think you're referring specifically to HIV? Or
Yeah, HIV, yes.
Yeah.
Yes.
Look, I think stepping back for just a moment, these are really hard this was a really hard process to go through. Certainly nobody wants to be in the position, no commissioner wants to be in the position of cutting contracts to key community partners. We're very grateful that we're in a position now where there are no more of these cuts, and I think it's because of the steps we took, as all city agencies took, to balance our budget, and so we're grateful that we don't have to do that again. As I said, of the $75 million PEG target that we had, 80% of that target was fulfilled through kind of back-end efficiencies, things that New Yorkers don't see, but that does leave some very hard choices that we had to make on programs. So how did we go about this?
Well, first I asked which programs and how much money we're talking about.
Yeah, we can, I'll get to that, but I
Okay.
want to, you asked also
Go
about
ahead.
approach. We have a very asymmetric budget. We have programs that get an extraordinary amount of city tax levy dollars and others that don't. And HIV falls into this category of programs that are extraordinarily well-funded through mostly federal dollars. We get almost $200 million in funding for HIV because of this city's commitment to ending the epidemic and our agency's commitment to ending the epidemic. It's a very well-funded program. But there is a small amount of city tax levy dollars here. What we didn't want to do as we went through these cuts is to put the burden only on the programs that have city budget. We didn't think that would be right or fair to those programs either, because make no mistake, of that 20% that we had to cut that wasn't back office or efficiencies, we tried to spread that out across our agency. And so that means no programs were left untouched, and that includes HIV. As regrettable as that is, that it includes HIV. Number two is, as I mentioned, HIV is really well funded. So there are plenty of programs that we also cut that get a lot less money overall, but HIV is very well funded. And number three, we really did try to minimize direct service impact. And so let me be clear about direct service impact. In the main, these grants are not for direct one-on-one client services around diagnosis, treatment, management, and follow-up of HIV. But there are a lot of work on training and education and community outreach that are important. But we did try to take the programs that were preserved all fell into the former category: direct HIV diagnosis, prevention, treatment, case management services, and we tried to preserve all of those because those are New Yorkers who are actively getting city support today. But as I said, these were really challenging decisions, and we knew that they would be challenging and received with this, with concern.
Okay, so I'm going to ask again, how much money are we talking about?
I'll kick it to Aaron.
Thank you, Councilmember. The total envelope of reductions for HIV was $5.3 million.
Okay. And so my understanding is that some of these programs involved education, particularly of older adults, which is a huge issue because HIV is going up, increasing amongst older adults. It also is going to affect jobs at these agencies, one of which is Gay Men's Health Crisis. There are others. So I just want to point that out for the record. During the preliminary budget hearing, you testified that the program to eliminate the gap will not impact services and operations at DOHMH. Were these calculations part of the PEGs during either the November plan or the preliminary plan?
Thanks for the question. Yeah, as I said, we made every effort to minimize the impact on direct services, which I think we've done in the main, but we weren't able to spare all of our programs, and there were some really tough choices that we had to make, and these were a part of the overall PEG process in the last two cycles to reach our $75 million PEG target as an agency.
So why did DOHMH choose to make these types of reductions instead of finding spending efficiencies that would not affect services?
Yeah, I think we did as much as we could. 80% of our $75 million was spending efficiencies that don't affect direct programs. We couldn't find 100% of the efficiencies that way, and if we were to, reverse these cuts, another direct service program would have to face the pain of this cut. And so we had some very, very painful choices to make.
When will the contract reductions go into effect?
We're working through that now, but they are intended to start for FY25.
Okay. when you say that, do you mean that some of it may be this year, or you just think it's?
No, FY25, so
Okay,
July
all
1.
right. How much notice were the organizations provided for these contract reductions?
We notified them all last month and have been in discussions with them since.
Do you believe that indirect services such as outreach and education are crucial in providing awareness on HIV and AIDS?
I do.
Were contracts within any DOHMH-run programs or initiatives reduced or eliminated as part of the executive plan?
Could you repeat the question, Councilmember?
Were contracts within any DOHMH-run programs or initiatives reduced or eliminated as part of the executive plan?
We are very grateful that we didn't have to take an additional contract reduction peg in this executive plan, but these represent pegs that were taken in the January and November plans.
Okay, so now I want to talk a little bit about diabetes. On April 10th, DOHMH published its citywide diabetes reduction plan as part of Local Law 52 of 2023. The plan outlines different strategies that would work together to lower the rate of new type 2 diabetes cases and the mortality rate due to diabetes-related complications. What practical services will DOHMH provide as part of the plan?
Thanks for the question. And diabetes is a big priority for us. It's a part of our Healthy NYC goals, as you know, to reduce cardiometabolic disease by 5% by 2030. And the complex thing about diabetes is that it sort of fits into all aspects of our society, right? From the way that we move, to the way that we eat, to the way that we educate ourselves, to, of course, the way that we access health care. And so DOHMH's work specifically is done in partnership with a whole host of other agencies, particularly healthcare. That takes on a lot of the work of managing people with diabetes. We focus at the agency mostly on prevention, both primary prevention of diabetes, meaning preventing people from getting diabetes in the first place, and then secondary prevention of terrible outcomes from diabetes, like kidney failure, eye disease, and so forth, heart disease, and so forth. So we do that in 4 principal ways, and we're excited to report that out as a part of the update on the diabetes plan and the local law. Number 1 is expansion of community health workers, place-based community health workers in the neighborhoods and the zip codes that are disproportionately impacted by diabetes. So those community health workers are out there doing coaching, they're doing lifestyle management, they're doing education on physical activity, they're helping people make smarter, easier, more accessible nutritional choices, so on and so forth. Number 2 is really saturating the same neighborhoods that experience the burden of diabetes with evidence-based self-management and other interventions. Those include things like a year-long national diabetes prevention program run with CDC funding. We're the largest NDPP program in the country. 6-week diabetes self-management program, practice facilitation with primary care providers, and calls, telephonic diabetes self-management calls through our NYC Care partnership with H&H. Number 3, it includes supporting safety net providers with support to address health inequities, and particularly the structural drivers of diabetes control, diet, exercise, economic security, housing, and so forth. And lastly, and probably one of the biggest areas we focus on, is really upstream nutrition security. So things like our work on education campaigns on healthy diets, plant-based diets, on nutrition security through our Green Market program, through our Health Bucks program, and most recently through our Groceries to Go program, which delivers fresh foods to recipients of NYC Care who would otherwise be uninsured without NYC Care in our city. So that's where we focus on heavily, is on the upstream prevention.
Will DOHMH rely more on education and outreach, or testing and physical services? I mean, I know you outlined, but I'm just asking it.
Sure. No, it's a partnership, but I think we are best suited as an agency to really focus on what happens in the community before someone hits the health system, but then partnering very closely with health systems to make sure that the link is as seamless as possible. We have a lot of work to do on this issue. Diabetes is extraordinarily hard
I know, that's why I'm,
and embedded into American society, New York City, and that's why we've set out a goal of 5% reduction, which doesn't feel very big, but when you look back at historical data over the last several decades, we haven't budged on diabetes, and in fact, it's increasing. So we've got a lot of work to do in this.
and you're working with a bunch of community-based organizations, I would assume.
Correct.
Can you, I know you don't have it now, but can you provide us with the list of who you work with?
Yeah, absolutely, and you know,
And if
to-
we can, and if we want to add to it, we can make a suggestion to you.
Absolutely, we're always open to that. And but it just relates to the Councilmember Brannon's other question around, you know, emergency funding and how do we transition. We built an extraordinary community health worker program during COVID called Public Health Corps, which is funded entirely federally, and it was focused mainly on vaccine uptake and distributing PPE and testing. And now we're working hard to transition that into more of a chronic disease mode, focused on things like diabetes, mental health, but that then provides a place-based workforce that can leap into action the next time we have a health emergency. So these are the kinds of choices that we're making right now.
Do you have a concrete timeline, including dates for when DOHMH plans to provide training and on-board organizations around all of this?
We can happily get back to you with specifics.
Please, because that was one of the premises of doing that. So what metrics do you have to ensure that the plan is effective?
So a lot of the metrics we have currently are around the number of people we're touching. So through our community health worker programs, through our self-management and education programs, our peer-based programs. So we're happy to follow up with specifics on the number of people we're touching in each of those programs.
What would be success? Well, how would you describe success? Your definition.
That's a great question. I mean, ultimately, I tend to look at what we're doing as a city and whether we're making a difference on the overall numbers of disease. Who's living and dying from diabetes? How are we doing on modifying risk? And are we actually seeing changes in the numbers? It's bigger than any one agency can certainly take ownership of, but that's why we laid out a goal in Healthy NYC, because it's going to have to require that we all align behind this. For instance, you know, the work that H&H is doing and others are doing to advance plant-based meals. Well, New York City is the largest purchaser, the second largest purchaser of food in the country behind the U.S. military. So when we put in nutrition changes in our system, it sends a huge signal to other parts of our city to start putting in plant-based meals. And we've seen that time and again with some of the food standards that the health department has advanced in the past. So I wish I had a clear answer, but my goal is to reduce diabetes deaths by 5% by 2030, and I hope we can get there through concerted action.
Do you have data on this on the website? And if you do, I'm sorry, I'm sorry I'm asking, but you do or you don't?
Data on?
Do you have data on diabetes on the on the DOHMH
Yes, I
website?
believe we do, yeah.
Is it broken down by borough?
I believe it is, but we can get back to you to confirm that.
Because I want to take a look at this. When we had the hearing for the bill, there were a lot of people from the Bronx an inordinate amount of people from the Bronx
Yes.
that testified. So that's, I want to make sure that we're doing services in places that need, that are prioritized.
I mean, that's why our work is centered. There isn't like a siloed diabetes program at the agency. It's actually embedded in our health equity division, because folks getting diabetes and having worse outcomes from diabetes predominantly live in Black and brown communities in our city and in the same zip codes that suffered the most from COVID. And so it's this cumulative structural neglect and disinvestment and frankly racial inequity that is driving this. And so that's why we made the explicit choice to do it that way.
So many New Yorkers have issues accessing and affording vital diabetes management products, including glucometers. And as you know, glucometers can cost between $1,500 and $4,000 annually and include the cost of test strips as well as the meter. Does DOHMH provide free or low-cost glucometers to New Yorkers?
So glucometers are and should be entirely reimbursable through healthcare and through healthcare systems, which is why currently DOHMH doesn't purchase them on their own. In fact, there's absolutely no reason that anyone accessing healthcare should not get a glucometer that's paid for by Medicaid, by Medicare, or by employer-based insurance. And if they are, that's a that's falling through the cracks in the system. That's not a policy position. So we're working closely with our partners in managed care, in Medicaid, in Medicare, and otherwise to ensure that no one's falling through the cracks, rather than DOHMH purchasing a bunch of glucometers ourselves.
Would you consider getting some free glucometers?
If they were given to us free, we'd definitely consider it. But we're
You
actually
would
very happy
provide.
We're actually very happy to discuss this further with you and learn more.
Is the usage of glucometers part of Healthy NYC's goal to reduce the prevalence of diabetes in New York City?
It is in targeted settings. Not every diabetic needs a glucometer in order
Understood.
to manage their diabetes. So yeah, certainly it's a part of targeted clinical care.
Do you believe that, an additional question to that, do you believe that low-income New Yorkers can benefit from access to free glucometers, especially since diabetes is prevalent among low-income neighborhoods?
Yeah, particularly those who are insulin-dependent diabetics. People who take insulin regularly need glucometers in order to manage, often need glucometers to manage their diabetes. And so, like I said, we would expect, and in fact, per federal and state rules, they should be getting access to reimbursed, they should be getting zero-cost glucometers through Medicaid, Medicare, and their insurance.
Okay, I want to talk about maternal health now. Give me a second. Maternal health is a pressing issue in the city, and Black women are 4 times more likely to die from a pregnancy-associated cause than white women. The Family and Child Health Program area includes maternal and child health, which fiscal 2025 budget is $45.4 million, representing $8.9 million less than at adoption. City funds have decreased by $7.5 million specifically. Which specific programs funding has decreased?
I'll kick it to Aaron for more details.
Thank you, Councilmember. So some of the decrease there is attributable to programs being moved from one division to another. Other pieces of it is it's really across the board, a number of different programs being reduced through PEG efficiencies. The largest piece of that was the Power of Two, which is a new family home visiting service that was reduced as part of the January-November PEG.
How did you calculate the reduction, and what was the reason for the reduction?
I mean, there were really a number of, with respect to that vendor specifically,
Yeah.
that one was, there were some performance issues with that contract.
Maternal mortality is one of the main drivers of mortality in Healthy NYC. Your department aims to reduce maternal deaths by 10% by 2030. That's a pretty big goal. Healthy NYC will focus on connecting families with healthcare and social support. What steps will you take to increase access to healthcare and support?
Yeah, so thank you for the question. Yes, it's an important and ambitious goal. Maternal mortality has actually reduced significantly in our city since 2001, but the inequities are stark. Black women up to 4 times more likely to both die in childbirth or in the post-childbirth period, or to have significant complications, severe maternal morbidity. And so we are focused on connecting with women or birthing people at every stage in the process, from their initial notification of a pregnancy all the way to up to a year after birth. And that includes a whole host of interventions. Our citywide doula initiative is one that we're very proud of. We've expanded access to doulas citywide. We've served over 1,600 families, well beyond our target in that process. And ensuring that they're getting access to this evidence-based life-improving service, life-saving service. We are expanding access to things like diabetes treatment and chronic disease treatment in the prenatal period, because we know that those increase risk of poor outcome in the labor and delivery and postpartum period. And increasingly, we are expanding access to mental health services, especially in the postpartum period, which we are finding is a rising cause of maternal morbidity and mortality, whether it be through overdoses, sadly, and through other forms of mental health crises. And so our new family home visiting program, our newborn home visiting program, our nurse-family partnership, each of those home visiting programs, all of which have different rules, different funding, but the larger frame of this is that mental health services is becoming a huge piece of their remit, including overdose prevention.
As of the preliminary plan, the budget for doulas was $6 million. Has that budget changed, or it's the same?
I don't believe it's changed. Aaron, can you confirm?
I'll get back to you momentarily.
Okay, please. Do you see a higher demand for doula services? I assume.
We do, especially in targeted neighborhoods. The challenge, and we're very also proud of this, is that doulas often work as independent contractors. And so imagine as a single person or a group of one or two providers that you have to interact with the city. It's really hard for contracting, for payment. And so we've taken a lot of effort to make sure that we're paying people faster, getting them paid on time, improving our rates there. It's not something we're a huge bureaucracy. It's not something that we're always good at, but we're getting a lot better on this front. And in part because we know that it's important that we get resources into these individual providers.
The Maternal and Child Health Services Initiative provides support for expectant mothers during pregnancy and postnatal. The current budget for this initiative is $3.7 million, and in the budget response, the council called on the administration to allocate an additional $500,000 for the initiative. Will we see increased funding for that?
We'll have to get back to you on the specific numbers, but like I said, there's no shortage of commitment in this space, and we're committed to expanding our doula services, and we've exceeded our targets on that front.
So then I presume you believe that the Maternal and Child Health Services Initiative's work is aligned with Healthy NYC?
100%.
Okay.
100%.
The Emergency Preparedness and Response Program area includes funding for the preparation of surveillance systems and response plans in case of a bioterrorist attack in the city. DOHMH operates a surveillance system to detect possible biological agents, you alluded to it earlier, and works with healthcare providers to monitor clusters of diseases and responses to potential health concerns. What direct services are provided under this program area?
I believe you're referring to BioWatch.
Well, emergency, it's listed as emergency preparedness. in
Got
the
it.
budget.
Okay, understood. Yeah, I mean, it's a huge array of services that involve our work with over 100,000 providers through our health alert networks, through our messaging, but also through everyday disease surveillance, both for routine communicable diseases as well as for biothreats. And so we administer a federally funded BioWatch program that surveils for bioterrorist threats throughout our city and have been since 9/11 in partnership with other city agencies.
The fiscal 2025 budget includes nearly $29 million, which is $5 million for emergency preparedness, which is $5 million more than in fiscal 2024 at adoption. Why is the 2025 budget greater than the adopted fiscal 2024? And by the way, it's one of the few areas that's gone up in terms of increase of funding just across the board.
Yeah, I'm not sure on the accounting piece of this, but one thing is clear that coming out of COVID, we've made a priority of investing in we need to be prepared for anything that comes our way as a city and as a health department. One of the areas we've made some investments in is data, improving our data apparatus, making sure that New Yorkers are getting actionable, real-time data. So that might explain some of it. I'll kick it to Aaron for more specifics.
Yeah, I think I'll have to get back to you on the specifics on that one, Councilmember.
Okay. There's a lot of specifics you guys have to get back to us on. You do realize that, right?
Yep.
Okay. What is the difference between emergency preparedness and response and emergency management? I want to see, is there an overlap there?
We work very closely with the Office of Emergency Management. We bring very specific health expertise to bear. So we focus on health threats. We focus on health threats, and we focus on the health impacts of other threats. So if it's extreme weather, if it's a fire, if it's a flood, that's led by another agency, coordinated by OEM or the NYC Emergency Management, but we bring our specific health expertise to bear. But if it is a health threat, if it is a very specific, like COVID or another communicable disease or other health threat, we bring our very specific expertise, which is why we have an Office of Emergency Preparedness distinct from.
So the funding, so what you do versus what they do doesn't really overlap. I'm trying to figure out
Not
if there's
really,
money
and it's
that
a lot of it
overlaps.
is federally funded. So a lot of this is CDC money that comes through because it's the way that the federal government maintains our health emergency preparedness apparatus throughout the country.
Okay, Mpox cases are currently increasing, and as of April 11th, there have been 149 people that tested positive, and it looks like it's, as we approach the summer months, it's starting to go up. What is the current budget for Mpox-specific services?
Let me get back to you on budget, but we see the same increase that you're commenting on. Important to know that the majority of those cases are people who are unvaccinated or under-vaccinated, which is why we issued a health alert a few weeks ago about the rising cases for providers, and we are very much pushing the vaccine, especially as we enter into June and into Pride Month, working very closely with our community partners as well, who were essential to combating the 2022 outbreak. We are nowhere near where we were in 2022, but we're still watching this very carefully, and vaccination is a key piece of
Do you have the funding for the vaccines, to give the vaccine?
So, like most emergency responses, it's not run through us anymore. It's commercialized through our healthcare system. So, a lot of it is around working with providers to ensure that they have the vaccine, that they're purchasing it, and that insurance is covering it.
H&H provides vaccines, I assume? I mean, I know that you,
I believe they do, yes, but
but DOHMH does not.
we do in select sites under select
Okay.
programs at our sexual health clinics, but that isn't the bulk of the vaccine.
When you're putting out the educational materials, I think it would be helpful to know exactly where people can get
Yes.
the Mpox.
They can go to vaccinefinder.nyc.gov
Okay.
and
But I want to
find the
make
site.
sure that that
Yep.
is, especially as we're approaching Pride Month, that that's out there.
100%.
in the
We agree with
community, and we'll help to amplify that as well. During the height of the COVID-19 pandemic, many people were unable to get necessary screenings for cancer, including breast and prostate cancer. One part of Healthy NYC is reducing the prevalence of screenable cancers by 20% by 2030. In our budget response, we asked the administration to baseline $3 million starting in fiscal 2025 to operate a cancer screening day and provide free cancer screenings. Does DOHMH provide no-cost cancer screenings?
Directly, no, but we work very closely with our provider networks and employers as well on organizing cancer screening. We're very much looking forward to discussing the council's plan with you and with OMB to learn more about what you have in mind with this initiative.
We're looking to do a cancer screening day as part of Healthy NYC in the future. So we should talk about that.
Yeah, glad to.
During the preliminary plan hearing, we discussed the Healthy NYC program, and as you know, the program aims to increase the life expectancy of New Yorkers to 83. Actually, a doctor told me it was 82.6. That's a separate issue. By 2030. And we would like additional clarity, I know, on there, on the budget. Do you have a budget for Healthy NYC? Can you give us some specifics?
Yeah, so Healthy NYC in many ways is not, again, its own kind of siloed program.
Right.
It lives, many parts of it live throughout our agency as a North Star and as a strategic plan for our work. So for instance, the maternal health work lives in our Division of Family and Child Health and our Division of Health Equity. Our mental health work on suicides and overdoses lives in our mental hygiene division. And then our data apparatus lives in our Center for Population Health Data Science. So the funding that we've put into those divisions reflect Healthy NYC priorities. But specifically, and we're grateful for your advocacy on this front, we are looking to fund things like citywide learning collaboratives to bring together stakeholders, not just from city government, but from community, private, public, philanthropic sectors to start to design what's the city's roadmap and what can we do to play a part in reaching these Healthy NYC goals. So we've issued an RFP for that just a few weeks ago, and we should be kicking that off in the next fiscal year.
Okay, no, it sounds great. I mean, the council wants to help as much as possible. We'd like the administration to help pick up the costs, obviously, but we will help wherever we can. And Chair, I'm done with my questions. Thank you very much for indulging. Thank you.
Councilmember Shulman, sorry, I just wanted to get back to you on your question about emergency funding. So the $5 million you mentioned is a couple things. Asylum seeker funding was added for about $3.7 million.
Okay,
But also, I mean, this is good news, right? The FEP baseline, so this is the Public Hospital Emergency Preparedness Program. The baseline actually increased by almost $2 million, so.
Okay. All right, thank you very much.
Sure.
it's important, today is numbers day, right? So it's, the more numbers and clarity we have from you, the easier it is for us to fight on your behalf. So I don't know how much was shared to you beforehand, but saying that we don't have numbers today, today's the day we need to have the numbers. Okay? Thank you. Chair Lee.
Thank you. I don't know if it's my role to say this, but just wanted to recognize that we've been joined by Tiffany Caban on Zoom. Councilmember Caban. Okay, so quick question on a couple things responding to your testimony. Actually, it's interesting you brought up 988 because I was just talking to a nonprofit organization last week who does have contracts with you all and does social services in Brooklyn, and they had no idea about 988, which I was very surprised at. And so I was like, how do you not know about 988? Because they do mental health services and in different communities that speak various different languages. And so my question is, I know you kind of touched upon it, but what efforts have been made? How many dollars have gone into specifically educating folks in the community about 988, as well as, because this is something I think that is a tool we're not using enough, that I think is great, that's available out there, because it really is supposed to be a place where people experiencing mental health crises call versus 911. And then also, if you could speak with how the training has been going together along with the folks at 911 that are answering the call centers.
Right. Yeah. Good questions. We launched a very big and ambitious 988 television, print, subway, name it campaign last year, and have been running that throughout. But the subject to budget, and especially at a time when we're talking about sort of budget contraction, that we've had to make some choices about how wide and how far we can go. We continue to promote it through our channels, but importantly, it's important that others take it up. It's not our hotline, right? It's the city's hotline. And you're absolutely right. This is a massive culture shift. Mm-hmm. We need people to feel like 988 is there for them in the same way they feel like 911 is there for them. And only through experience and culture shift will that happen. And that also links to your second question around training. That's a big part of our work, is working directly with EMS, working with dispatchers to understand when to use 988, what resources are available on the other end of 988, when to use it. And so we're in constant both dialogue and also training with folks at FDNY, EMS, 911 dispatchers and PD to ensure that we're doing that. We have a lot of work to do. This is a huge generational culture shift.
And can you just specifically outline more how many dollars from the DOHMH budget have been outlined for the training purposes? And also, if you could go into which languages, because as we know, there have been incidences recently with Win Rosario and other folks in the community that speak other languages, or their families speak other languages. So how are we making sure that these services are being known to the Korean community, the Bangladesh community, the Sikh community?
Yeah, language access is a massive part of mental health services, and also, it's also not always that you translate it like for like, right? Because in other cultures, my own home culture as well, you don't use these language of depression, anxiety. Those words don't exist. So a challenge for us. But the basic 988 and other materials are all translated into multiple languages. We can get back to, we during COVID and with the additional COVID resources, we were translating everything we do into 30 languages. And we're not able to maintain that level right now, but we'd get at least 18 languages, I believe, and we're working to include more. As far as the budget numbers, I will ask Aaron to respond.
Yeah, thanks, Commissioner. Chair member. So we did, the media campaign was $2.5 million, and that was for 988. We do ongoing promotion through our partners, through social media, and all of those materials are available in 13 languages, at least.
13 languages.
And do you know if that's going to be a year-over-year cost that gets included? Because as you know, with the culture shift, it's going to take a while. So are we able to ensure that money gets put back into the budget every single year?
Well, we're exploring that right now, and all of our media campaigns were on hold during the PEG and the OTPS freeze, and we're grateful now that that's over and we can restart this effort. But absolutely, it's part of our thinking.
Okay. And then just really quickly, because I know that in your testimony, you also had commented on the executive budget for the opioid overdose prevention programming. And so just out of curiosity, because I know that after the last hearing we had asking about the opioid settlement funds, I know that you all had a report that came out shortly after that. And I think it's a great start, but just wondering, I know that you said that there's more details to be released soon. So just wondering, because I know that there was a whole bunch of zip codes listed in there, but what was not in there is the percentage of funding that went to each of those zip codes,
Yeah.
because we want to make sure that it's going to the most needed places, and then also which groups are in charge of delivering those services.
Right. So, yeah, great questions. More details to come is only because we're planning to make a more detailed announcement in the coming weeks. So you'll be hearing very specifically from us. The numbers in the executive budget reflect what's been committed at the health department. But of course, there are commitments happening at H&H, at OCME as well, at DHS as well. So a lot of that work is programmed across city agencies. The 4 key areas of work, as you know, are substance use prevention, harm reduction, treatment and recovery services. And a lot of the programs, we're not trying to reinvent the wheel here. We're trying to invest in things that we know work,
Right.
Even against political and other headwinds, things like overdose prevention. We're still committed to that, but we're also committed to expanding access to treatment. And so a lot of our work is ensuring that we're doing all of the above. There's no single approach that's going to get us out of this crisis where a New Yorker is dying every 2.8 hours from an overdose. I mean, it's really so concerning. So we will have actually a lot more details for you in the coming weeks.
Okay, great.
And we did announce also the Staten Island budget specifically
Okay,
some months ago through sort of concerted work with the Staten Island delegation and stakeholders on that borough. We were able to announce specifics. And so you look at that release, and that's the level of specificity that you'll be able to get from this next
okay. And just to confirm from the last time, so it's been 90 million so far that has been allocated, I believe?
I believe that number's right, but we can get back to you on the
Okay.
actual number.
That was from.
Oh, you mean
what I
across
remember.
the city?
Yes.
Yeah, we
From
can
the
get
opioid
back
settlement
to you.
funds, I
Yeah.
believe
Well,
90
I can only
million.
really speak to what's in our agency's budget, but yes.
Okay. So then, I'm curious to know where the rest of that money's going. Okay. Yeah, if you could get back to us on the total that's getting filtered
Yeah.
through DOHMH, that'd be great.
Sure.
Okay. So next, just going on to the Trauma Recovery Center expansion. Trauma Recovery Centers, as if you guys don't know, not you, but it's folks, provide trauma-informed support to help people that experience violent crimes, including gun violence, domestic abuse, and hate crimes. There are currently 2 TRCs in the Bronx and 2 in Brooklyn, and all 4 are open and operational. So what benefits, if you could explain, have you seen so far from the TRCs, and have you identified additional council districts with a great need for trauma recovery centers?
We're really interested in and excited about this model. It's a model that has been used in other jurisdictions, has been written about recently, and at its core, it's really about building connection, breaking social isolation, ensuring that people who are victims of or survivors of trauma are not alone, and doing so in a trauma-informed environment where the staff and peers are trained to manage issues of trauma and the impacts across the life course. Remember, too, it's young people all the way to older adults. And so we are very interested and grateful for the council's investment in this model, and we're actively researching it and looking for.
What's the
future
youngest age
opportunities.
that you take for the trauma recovery centers?
Say it again?
What's the youngest age that are allowed to?
That's a great question. I'd have to get back to you on the details.
Okay.
Yeah.
So in the budget response, we called the administration to enhance the TRC funding for 7.2 million baselined in FY25 to sustain existing centers and open additional centers in Queens and Staten Island because we don't have any there. Have you had any conversations with the administration on expansion of the existing TRCs and opening new sites?
We're always discussing opportunities like this with OMB, and so we're in active discussions now. I'll ask Aaron to comment further, if anything.
Okay, and just from your opinion, based on how much it costs to run these trauma recovery centers, how much additional funding do you think we would need?
I don't have an answer for you, but all I can say is I think there's some promise in this model. But, I mean, it's a great analog to what Councilmember Brandon was talking about with the support and connection centers. It's a new model. We're learning a lot about it. We need to see evidence that it's having an impact before we really start pumping it with resources. Otherwise, we could be back here in years from now saying, where did this money go and what's the impact? So we're very interested in this model, and there is promise.
So when do you think we would be able to, what do you think is a comfortable cycle then to look at how long they've been running the programs, if the budget is sufficient or if we need more? What do you think that cycle looks like?
Yeah, we can get back to you with specifics on what evaluation might look like.
Okay. Okay, so going to the FACT teams, which I'm personally a huge fan of, the Forensic Assertive Community Treatment Teams. So FACT teams provide evidence-based solutions for people with serious mental illness. There are multiple teams that provide these services, including the IMTs, which are the Intensive Mobile Treatment Teams, and the HEAT teams, which are the Health Engagement and Assessment teams. So just wanting to know for fiscal '25, how much are allocated for these teams, including ACT, FACT, IMT, HEAT, SPACT, and CRT? I know there's a lot.
Yes, we have a lot of teams. They're all slightly different.
Yep.
The forensic ACT teams, assertive community treatment teams, we have 5 of those teams. They have the capacity to serve about 340 people at a time, and they are eligible for Medicaid reimbursement, which is different to our IMT teams, which was specifically set up to catch folks who fall through the cracks of our Medicaid system. With Medicaid reimbursement comes limits on the amount of time you can spend with the client, limits on the duration of time you can spend with the client, which is why the department created the IMT program in 2016 to really get the hardest of the hardest. But ACT is an evidence-based model. It's been around for some time. Both FACT and ACT are obviously related, and so we're very committed to it. I defer to Aaron on any specifics on budget.
Yeah, if you could actually talk about each of those funding areas and then how they've changed from the previous fiscal year, that'd be great.
Yeah, I mean, I could talk about intensive mobile treatment for sure is about $42 million budgeted for FY25. It was $41.8 this current year. I think if you want to go through each of the items, I'll get back to you the specifics on that. What were the other ones you wanted to?
ACT, FACT, IMT, HEAT, SPACT, S-P-A-C-T, and CRT.
Okay, we'll get back to you. Thanks.
Okay. And the reason why I'm bringing this up is because I think these outreach teams are super, super important and crucial, and it's a resource we have available in the city. And I agree, the insurance and the stream of money is a challenge. I think the oversight between state, city, and then once you're in city, there's different city agencies that oversee this. So I understand that these are challenges, but if you could speak to how the coordination piece is happening, because I just can't emphasize enough how important this is, because what we don't want is for people to end up in shelters or in the criminal justice system when they should be actually receiving treatment. So if you could speak to how those efforts are happening and the coordination, and if the funding is enough, that'd be great.
Thank you. I would never turn down more resources for more teams, so a good commissioner would never do that. But the coordination is strong, in part because it starts with a population approach, right? We look at starting with the most severely impaired New Yorkers, people who have touched our criminal legal system multiple times, people who have touched our hospitals multiple times. We do regular case conferencing and very granular patient-facing, client-facing work that is about coordinating. And you can imagine, you've got a mobile team that's following you in the community, and then you might be hospitalized, and then the role transfers over to the hospital team, but those teams need to be in close communication. You also have, if that person is in supportive housing, you've got a site-based team potentially run by the supportive housing operator. It's an extraordinarily complex system. A lot of what we're trying to do is to reduce some of the complexity as we start to fund it more. The governor's budget has put in consistently more money. Our budget has put in consistently more money. And as you've heard me say before, we didn't get here overnight, so we're going to build this up floor on floor. And in the process of building it up, I think we'll find more opportunities to streamline and find better coordination and alignment around these multiple teams. I too, even educating myself on this over the years, many years, as you know, it's word salad unless you're really in the weeds, right? So you need to really understand the differences between the teams. And there's a lot of, I wouldn't call it overlap, but there's a lot of points of coordination. So we do that very actively with DHS, with DSS, with H&H, with the Office of Community Mental Health, with other providers across our city every single day.
Okay. Yeah, no, and that's something that we definitely want to try to see if we can get more money. And I know that we wanted to basically call upon the administration to baseline an additional $7 million, specifically for the FACT teams. And so just wanting to see if there's any conversations about whether that could be baselined.
Well, we're in ongoing discussions with OMB, and we'll be happy to get back to you.
Okay, and then I think I know the answers to the next set of questions because I remember them from the last time, but just for the record, for OCMH, I know that, for example, with, you know, OCMH, the programs that they oversee, just wanting to know, because I know Be Heard, for example, is one of those programs, but what are some of the ways in which you do coordinate with them with programming or where you all overlap? And if you can speak to some of the services that they provide under their department, that'd be great too.
I cannot speak to what they do under their department because I don't have any insight into their budget or their work. I think they play, as far as I understand it, and our engagement with them is coordinating and collaborating across agencies, and they play that coordinating role. So that's the extent of our engagement with OCMH, and they've been a great partner. We work with them on policy changes, we work with them on advocacy, we work with them to disseminate through their networks as well. So yeah, we work very closely with OCMH.
Okay. So questions about budget, headcount, how it compares to last year. These are all things that are not under your purview, but separate, and it's completely separated from OCMH, from DOHMH.
Yeah, I would direct questions to the mayor's office for that.
Okay. So let me go to my next set of questions around housing, which I know were brought up a little earlier, related to some of the support systems. So specifically for the 1515 Supportive Housing Initiative, you know, it focuses on providing housing to people with mental illness as well as those transitioning out of incarceration or struggling with homelessness. In the budget response, the council called on the administration to allocate $19.6 million, which I believe is included for 1515 as well as JISH. And so what are the current budgets for 1515 supportive housing?
So the Department of Health's main role in supportive housing is to run the service contracts and to manage our community partners that run services within supportive housing sites, whether it be scattered site or congregate settings. We do not run the buildings. We do not manage the real estate, the contracts. We only work directly with the providers to ensure that they're providing evidence-based care and high-quality care for all of the residents under that. We spend about $282 million in combined city and state funding in this fiscal year alone on supportive housing services. And under our purview, in the last fiscal year, we expanded that envelope to more than 700 new units in FY23 and another 700 in this year, FY24, which is wonderful. We need much, much more supportive housing. About 75% of those are congregate units, meaning the entire building is supportive housing versus scattered site. And you know, there are real challenges in building congregate supportive housing, right? There's issues of siting and NIMBYism and zoning laws and all of that stuff. So luckily that's a little bit out of my purview, but we do focus in on the services. And we've done quite a bit, I think, in this administration to expand supportive housing in partnership with the state and their commitment as well.
So with the 700 new units that were added, which is great, what does that give us, what does that bring us to in terms of the total number of units?
I believe, and again, I would kind of refer more specific questions to the housing agencies because they manage the units, but we have, under our contract, we have 7,900 units under contract with us to nonprofit providers, and an additional 13, that's at congregate settings, and then 1,300 scatter site units throughout the city. So the majority is congregate, some scatter site.
Okay, and are you the only contractors to provide those services within the 1515 supportive housing units? Meaning, it's not like there's another entity or agency that is providing these specific services, right?
Yeah, that's a great question. I don't believe so. I think all of the supportive housing service contracts are run through us, but I can certainly, we'll get back to you and confirm that 100%
Okay.
true, but I believe that's true.
Okay,
Yeah, and just to flesh out the financial picture just a little bit, Councilmember, so for 1515 specifically, it has a baseline budget of $63 million. And we know that there are going to be much greater needs in the out years. That was the initial sort of envelope that was funded because of the 5-year city's financial plan. So we're in active conversations with OMB and the other agencies involved, DSS, HPD, about what that need's going to look like in the future.
Okay.
So
so the 63 million that's been baseline for supportive housing for 1515 specifically, so 282 is including 1515, and then what else then? So minus the 63 million, where's the rest of that?
I mean, it's the other portfolio of housing programs in New York 1, 2, 3.
Yeah,
Okay.
1515 is obviously just the latest
Yeah.
in
Right.
many decades of growth of supportive housing in our city. So that's what's contained in that universe of 282 million.
Okay. And then is this also the same, if it follows state guidelines, what are the age ranges for the supportive housing, just out of
We
curiosity?
have different types. We have family supportive housing. We have supportive housing for single adults, for couples. So there's different rules and regs around each of those
Okay,
different settings.
all right. And then, so just really quickly following up on clubhouses from last time. So I'm not sure how many of the staff remained to listen to the preliminary budget hearing public testimonies, but there were definitely a bulk of the folks who were testifying raised issues related to the new RFP requirements. And so just wanting to know, how is DOHMH ensuring a smooth transition? I know that you've talked about this, but how are you ensuring a smooth transition of the members belonging to those clubhouses that are facing contract termination?
And we're working in a number of ways. Number one, we've been in touch with every single provider that either didn't apply for the contract or applied and were not awarded the contract to work on transition plans at an institutional level. Those transition plans include transitioning their members to new sites, but also many of those sites exist inside larger institutions. So many of the services might actually be contained within other programs in that site. So if you're at a multi-service site, where they might get similar services at that site. We're also exploring other designations for these programs. We are developing a definition of clubhouses that adheres to international standards and trying to be consistent about that in order to broaden the envelope of revenue and support and partnership with healthcare, housing, and other systems. And that's a pretty tried and true standard that's adopted in many other places. State of Michigan, for example, you have to be accredited in order to be a clubhouse in Michigan and in order to get Medicaid revenue, for example. And that's true in many other places. So we're exploring other designations for these sites. That's at the institutional level. At the individual level, we're placing phone calls to every single person on the rosters of these clubhouses as best we can to reach them. Remember, active membership simply means you've been at the program for sometime in the last 90 days. So we're not able to contact every single person, but we're making every effort to do so, and then develop a tailored, individualized plan for how they might transition to a new site. That includes metric cards and telecommunications support and really accompanying people, doing whatever it takes to get them where they need to go. Lastly, we're working with the awarded providers. So we're convening them, in fact, in the next couple of days to talk about their obligations to these sites. So their obligations to reach out to form partnerships, to have transition plans for their members. So we are taking every step to do whatever it takes to make sure that no one loses their access to a community.
Okay. And then sorry, let me just clarify. So if I'm understanding correctly, with the new designations and the accreditation piece, does that mean that it could be potentially the case where some of the folks that did not get the RFP, if they go through that process and they qualify, they would be able to be eligible for one of these programs to be still continued at their site?
One of the conditions of the RFP is that they are accredited and that they also have to meet the other conditions of the RFP. So all of the different rules and regs and targets and plans, yes, they in future iterations, potentially they could, of course, apply for the future. But right now, the RFP has been awarded to whom it's been awarded to, and we're working directly with those,
Okay,
those
and then
awardees.
the RFP that was just, awarded, was there any consideration or anything in there to allow DOHMH to help those that were not certified or accredited to actually get their accreditation? Like, is there some sort of path that the city is providing to educate them on how to do that process?
Yeah, we have been for years. Since we've been running clubhouses, we've made it city policy that we want all of them to be accredited, not as a condition, but as a goal.
So this
and
is
so
even
we've been working with every system. Every single clubhouse has been reached out by this agency and said, what do you need to get accredited? And some of them said, we don't want to be. Some of them said, we don't know how, and we've helped them, and some of them have. Some of them have gone from non-accredited to accredited.
And do you know if these conversations were had before you came on as commissioner? Was this also true with the previous administration?
Many, yeah, many.
Okay.
And I know this also from my previous work.
Okay. So out of the 16 clubhouses that were awarded under the new RFP, how many did not apply?
How many did not apply? Let me get back to you on that exact
Okay.
number. Yep.
Okay, so yeah, I mean, I understand that we want to have certain standards, but I just want to emphasize that I feel like there could have been a couple steps in between, even aside from the accreditation, just even in terms of how much, data and requirements that we're asking of them. So, can you also provide a breakdown of how much funding each existing clubhouse received under the previous budget, and how much of the $30 million budgeted amount will you be allocating directly to clubhouses? And
Yeah.
how much is approximately each clubhouse getting funded at?
I think that's all publicly available data, so we're happy to follow up with that.
Okay, do you have that, or?
Oh, not on my, we'll have to follow up with you with that.
Okay.
Yeah.
Yes, if you could get back to us on that ASAP, because we haven't been able to find that data either.
We're also not at liberty to talk about specific awardees until the contract.
But I thought the
starts.
awards went out already.
They did go out, and
Okay.
it is in the public record, but my point is, we're still under contract, we're still finalizing contract negotiations with each of the awardees. The amounts, I don't know if the amounts have been published in the public record.
I'm not aware the amounts have been published.
Okay, but you guys know the amounts, hopefully.
Certainly,
Okay.
happy to follow up.
Yeah, if you could let us know, because my understanding is that it should be accessible. So, does DOHMH provide funding to advertise the clubhouses in sort of not having people fall through the cracks? Is that something that you're doing, is advertising the clubhouses as well?
Yes, but though I would say of that 30 million budget, the vast majority of it is going directly to providers. We are not holding on to a great deal of it internally. And so, yes, but clubhouse marketing is a part of that. Also, incorporating clubhouses into our common citywide single point of access. So we've created a single point of access for all, particularly serious mental illness services, but mental health services. So now they're a part of that common referral pathway.
Okay. Okay, so switching gears to maternal mental health, because this is definitely a priority for the council. And as you mentioned, thank you for earlier bringing up the types of services that you're providing under, and it's interesting to see that you're seeing more opioid and overdose situations happening within the maternal mental health space. And so the executive plan includes a funding swap of $1.9 million starting in fiscal '24 between units of appropriation for maternal mental health, and a portion of the funding went to mental hygiene management services for personnel services. So why was the shifting of the funds between units of appropriation needed? And what programs, if you could reiterate, what programs will this funding be allocated to?
Yeah, thanks. And we're as disturbed as you. This has now become a leading cause of death for pregnant and postpartum people, so it's critical for us. The budget line you're talking about is actually just a technical adjustment to reflect the actual breakdown of costs for the program within the Division of Mental Hygiene. I'm not sure there's more to add on that, but I'll kick it to Aaron for specifics.
Yeah, that was just getting the money out of the code it was put in and into the right place for spending. Yeah.
Sorry, say that again?
Sorry, that was just a technical, just literally moving the money out of where it was allocated into where it will be spent from.
Okay.
So,
So is this also related to the mayor's mental health plan as well?
Well, reducing overdose deaths and suicides is a part of our Healthy NYC goals. Reducing maternal death is a part of our Healthy NYC goals, and all of that is contained within our mental health plan. So that's the whole point of launching a Healthy NYC, is so that we see how it all ladders up to what affects the whole city.
Oh, sorry, I meant more for the funding swap.
The funding.
Yeah.
I'm sorry. Aaron, do you want to have a thought?
Yeah, I mean, about 250,000 of it will go to the mental hygiene management services.
Oh, Mike, sorry. Mike.
oh, sorry. Sorry about that. About 250,000 of it goes to the mental hygiene management services on the PS side.
On the PS side, okay.
The bulk of it will go to the Early Childhood Mental Health Network program.
Okay, and was there any sort of headcount attached to the funding swap, like headcount shifts or changes?
I don't believe there's any headcount.
Okay.
But I'll confirm.
And then my last topic before I hand it over, because people are probably sick of hearing my voice at this point, but mental health continuum, which is personally for me a huge, important service that we're providing, especially because it's such a small dollar amount. It's $5 million. If you think about it, in the vast majority of our city's budget, this is pennies, so to speak. So we called, for the FY25 budget response, we called on the administration to baseline $5 million, which we have asked for this past however many years, for the mental health continuum. It does not appear that the executive plan included any additional funding for the continuum. So is the continuum traditionally baselined, or is it funded on a year-by-year basis?
Thanks for the question. So just to be clear, the mental health continuum is really about mental health care in schools. These are clinics that are operated by H&H within DOE schools. Our only role is in the Joint Office of School Health, which is a joint DOE and Health Department office, which plays an oversight and technical assistance role in all school mental health clinics. And as you know, we announced last month, the administration announced last month, that 16 new mental health continuum clinics would be opening over the next 6 months, which will serve an additional 6,000 students in Bronx, in particular in the Bronx and Central Brooklyn, which are neighborhoods that, of course, have lower access to care. So our role is simply, we don't have any budget for the mental health continuum. We are simply in a partnership role, and so I would defer specific questions about it to DOE and H&H.
Yeah, and I don't know if you could speak to this, because I know you have part of this and it's in schools, but this was my question from last time, which I wanted to just clarify, because I know that there were 16 new mental health continuum sites that were announced, but if the $5 million previously in previous years was getting fully spent, my question is, if we're adding 16 new sites, then what is not getting funded? And that's what I want to know, right? Because if the $5 million was fully spent down and we have 16 new sites, where's that money coming from?
Yeah, because it's not in my budget, I can't really speak to that. I would have to defer you to OMB, Mayor's Office, and the two agencies I mentioned.
Okay, maybe you could ask that at your committee next. Okay, and then correct me if I'm wrong, but DOHMH's portion in the mental health continuum is less than $500,000. Is that correct?
That might be
Correct.
right. Yeah,
Okay.
and it's simply for partnership and technical assistance.
Okay, so it's technical assistance, and then what else, for staffing, or what is that money getting used for?
I don't know if it's PS or OTPS. I'll have
Yeah, it's a small amount. It's 472,000. I can get back to you on the specific breakdown.
Okay, if you could get back to us, that'd be great. Okay, I will hand it back to the chair, and we'll go through. Hopefully I'll have a second round of questions. Thank you.
Thank you, Chair. We've also been joined by council members Brewer, Stevens, Hudson, and Sanchez, and we're going to start with questions from Councilmember Farias.
Thank you, Chair. Good morning, Commissioner. Concussion care is a public health concern, but many concussion patients are also survivors of domestic violence and require trauma care as well. Typically, concussion services focus solely on the physical injury and not the patient's mental health. In the budget response, the council called on the administration to allocate $300,000 for a pilot women's concussion clinic, which would provide this trauma-informed care. What trauma-informed care does DOHMH currently provide for concussion patients?
Thank you for the question, and we agree that this is an interesting and important area of work. A lot of that work happens through our routine clinical systems, which DOHMH does not operate. So we look forward to learning more about your specific proposal and to discussing with our colleagues at OMB about whether there is a role for the health department in this work. Right now, most of that care happens through our routine clinical systems, primary care, emergency rooms, and post follow-up.
Okay, and do you folks have any clinicians that have training in providing mental health support for survivors of domestic violence, or do they just defer to the social workers?
It's a great question. Again, we don't have a massive roster of clinicians. We run a very narrow clinical footprint at our sexual health clinics, at our TB clinics, at our immunization clinics, and they do not specialize in domestic violence support. A lot of that happens within our routine clinical care system, so I'd have to defer to them as well as to the mayor's office to end gender-based violence.
Okay, and by any chance, does DOHMH collaborate with H&H on concussion care?
Currently, I don't believe we have active collaboration on this specific issue, but we're always open to learning more and exploring.
Okay, great. Thank you so much. I'm super interested in looking at further conversations around this, specifically as the main agency that's taking care of our healthcare systems along with mental health. And I'd encourage you, and I can also send over a bill I have in the council on traumatic brain injury and its outreach and training around
Please
providers.
do.
Thank you.
Thank you.
Thank you, Chair.
Okay, now we have questions from Councilmember Abreu, followed by Salam.
Thank you, Chair. I want to hammer down on the issue of clubhouses. The Upper Manhattan Mental Health Center, also known as Emma Bowen, in my district, lost their $500,000 contract and learned that the awardees are going to larger providers that also provide addiction services. We find this confusing because the stated goal of the contract cuts are to restructure and centralize services, but Emma Bowen already provides addiction services and has been doing so for decades. They've been providing walk-in services for the most at-risk mental health individuals in the city, and yet their program will be shuttered if they do not receive these $500,000 in funds. Can you please speak to how this decision was made and what alternatives can be provided in terms of funding so that these extremely vulnerable populations in Harlem are not being turned away at the door and potentially being forced back onto the street without proper care or treatment?
Thanks for the question. You know, I'm not really at liberty to speak about individual providers and awardees, but what I can say is this. Providing addiction or substance use disorder services was not a condition of the RFP, though providers that do are certainly at an advantage because we know that 40% of people with serious mental illness also have a co-occurring substance use disorder. So it's a very real intersection. And frankly, having been in this work prior, we've reinforced as a society and a city as well, a silo between these programs. And we need many more people experienced dealing with serious mental illness, schizophrenia, schizoaffective disorder, bipolar disorder, major depression, who also have experience in substance use disorder. So, you know, what we tried to do with this RFP is to invest in people who had interest, who had the ability to provide the services in the priority neighborhoods. One of the biggest foci of the RFP was getting into the neighborhoods with the highest needs and ensuring that no neighborhood with their highest needs lost a program. So even if a particular program closed in an area, reopening a new one or shifting, some providers shifted sites from non-priority neighborhoods to priority neighborhoods. And so we're committed to working with everyone, and we're talking with the provider you mentioned about a transition plan as we speak.
Well, thank you for that. Look, H&H is in the process of trying to dispose property in West Harlem on 145th Street, and Emma Bowen has been part of that conversation. For them to be part of a contractual arrangement for new housing in the neighborhood, and for them to not get this funding, it just doesn't make any sense. So it is my hope that they get support one way or another.
Okay, we now have questions from Councilmember Salam, followed by Menon.
Good morning.
Good morning.
During the joint hearing on finance and public safety, it was stated that the NYPD and the Department of Health and Mental Hygiene co-response team act before and after a mental health crisis, but do not respond during the event itself. If there was a mechanism for the co-response team to intervene during mental health crisis reported in 911 calls, Win Rosario might still have been alive today. My question is, what resources would the Department of Health and Mental Hygiene need to respond to mental health emergencies reported in 911 calls alongside the NYPD? And do you have an estimate of the associated costs?
Thank you for the question, and we certainly share your concern about events like the one you mentioned. Mental health crises deserve a mental health response, and everyone is saying the same thing. Our law enforcement partners, our health partners, our public health partners, our communities are saying we want a health response first. And so we're committed to that as an agency and as a city. You know, there are multiple options, and a lot of it gets back to the question that the Councilmember Lee asked earlier around how to use the available options and how to educate dispatchers, how to educate the people who are making the choices at the moment, not necessarily the people on the ground once they're there, but the people who are dispatching or deploying a team to select the right team. And so that's ongoing work of training, of culture shift, and I can say it's some of the hardest work that we do to shift that culture.
Just as a follow-up, has the DOHMH considered the possibility of taking the lead, both fiscally and operationally, on responding to 911 mental health crisis?
You know, I think all of what we do is in partnership. You know, the choice was made in the previous administration to kind of build up one form of non-law enforcement mental health response that didn't really explicitly involve the health department. We have our mobile crisis teams, our NYPD co-response team, so we do some crisis response. I think what you're referring to with the co-response team is whether they're available to a 911 dispatcher, and I think that's part of the culture change and operational change that we're seeking. I don't know what the right answer is in this vein, whether it should just be one agency taking the lead, because frankly, it requires all of our city coming together to make this shift, and so, and we do work in very close collaboration with one another.
Just one follow-up? Thanks. It was mentioned during the same hearing that about only 50% of patrol officers receive crisis intervention team training. Has the DOHMH explored partnering with the NYPD to train the remaining half? And what resources would you need to do this, and to provide a refresher course to these officers?
We are actively engaged in training everyone, so EMS, NYPD. We are always out training our front-facing public safety apparatus and the frontline workers on crisis intervention, particularly those who have the ability to use mental hygiene law like 941, 958 to intervene. So we take responsibility for that training as the local mental hygiene unit? I think that's a good question and one that we'd be eager to follow up with you on in terms of ongoing work.
Councilmember Salami, right? Good. Okay, now we have questions from Councilmember Menon, followed by Brewer.
Thank you so much, Chair Brannon, and thank you, Chair Shulman. Commissioner, I have a couple questions regarding the Office of Healthcare Accountability. As you know, the council last year passed the bill to create the Office of Healthcare Accountability. That law went into effect in mid-February. You and I have had many conversations about that, so I really want to drill down into the specifics in terms of that office. How many staffers are currently working in the office?
Thanks for the question. I'll get back to you on what the exact staffing numbers. Do you have those on hand?
I don't know. We're actually working on what this model is going to look like and standing it up now.
I'm sorry, I can't hear you.
I'm sorry. So we're actually working on what the model is going to look like in terms of exact staffing. So I don't have the exact numbers.
Okay, but under the law, it went into effect in mid-February, so I don't understand the comment that you're working on it. It's supposed to be up and running.
So we are in active discussions with OMB about what our next year's budget will be for this office, and we're eager to finalize that. And that will.
I mean,
determine
again,
what the
it's
staffing
late now. The office was supposed to be up and running, and I think it's really disconcerting that we're not getting more specifics on that. We've had numerous conversations about it. We also brought to you the idea of using the Fund for Public Health to staff those lines for several years until they're baselined into the budget.
Happy to follow up with you. We're exploring that right now.
Okay, I want to ask if Chair Brannon can please assist in that, because again, this is a top priority. It's not only a priority in terms of consumer protection, it's a fiscal priority. We're spending close to 10% of the city budget, as you know, close to $11 billion on public sector health care. That is almost double what it was 5 years ago. So, you know, it is estimated, studies have shown that by creating this office, we can save up to $2 billion from this.
Yep, we share your priority on this.
Councilmember Brewer, followed by Hanif.
Thank you very much. Back to the clubhouses, because I have Goddard Riverside, a budget of 600,000, 100 participants. So my question is, how many, whether they applied, Goddard did, or others that didn't but exist, how many individuals are impacted by not getting funded? And how much is the total funding?
The total funding
Of not getting funded.
total funding of not getting.
In other words, Goddard didn't get funded.
Yeah.
Emma Bowen didn't get funded.
Yeah.
Queens Hospital didn't get funded, et cetera.
Yeah, I'll have to get back to you on the total number of the total amount of funding that wasn't or is being redirected into the new RFP.
And how many people are involved? Because I think what happens is
Yep.
we're all very concerned. They're small. You know them as well as I do from your history at Fountain House. Perhaps they could be larger in terms of the population. It's not an easy population to work with. I don't think they're all going to transition somewhere else.
We're working hard to make sure that they do.
But,
the rosters that we have gotten from the providers amount to, in the hundreds, a couple hundred.
Each one is around 100, over 100 people, right?
Yeah, so, and that's based on, have you interacted with the program in the last 90 days? So we're making individualized calls to every single person and working with the sites.
Okay. I think we're all very
Transition.
concerned, we're very upset, we don't want this to happen, just so you know. Very, very clear, because they develop relationships. These are not, you know them, they develop relationships at their clubhouses. Sending them somewhere else is not going to help necessarily them, and it may not solve the mental health issue for them at all. It's a terrible discussion, terrible cut. Second, school-based. Now, you have nothing to do, I know about the 16 that are being funded, but do you have nothing whatsoever to do with school-based mental health services? How do you interact at all with them? Do you have any opportunity to have oversight over the school-based mental health services or school-based in general healthcare?
We do a lot in school-based healthcare and in school-based mental health care through the Office of School Health, which we jointly administer. I was speaking specifically to the Mental Health Continuum, which was a project built under the last administration, which does not involve our direct work on the ground. We get a small amount of money, as Aaron said, about $470,000, mainly for technical assistance. And So that's our role in that specific envelope.
Do you have, what amount of funding from your department does go to school-based health in general?
Oh, that's significant, and we can get back to you with
You don't have that number?
not on my
Do you have the number of schools that you are in that school-based?
hundreds, but we'll get you specific numbers.
You can get us a list. Is it you that does it, or sometimes it's contracted out to a hospital, or you're doing it directly?
School-based health centers are predominantly run by health systems,
Correct.
hospitals.
I know I go to them a lot. The other question I have quickly is going back to COVID, long-term COVID. What is the dollar amount, if anything, allocated either in terms of task forces, research, et cetera, from your department to long-term COVID?
Significant in the sense that we're the first jurisdiction in the country to launch a long COVID registry, like we did the World Trade Center registry. We have committed hundreds of thousands of dollars to doing a registry over the next 10 years and following people about the exact impacts of long-term.
Can you get us exact dollar amount
Yeah.
that you are allocating to that?
Yeah, we have about $440,000.
440,000.
Yeah.
Great. Thank you.
And Councilmember Brewer, just to go back to your question about school-based health centers, so the FY25 budget for school-based health centers that do run through us is $7.6 million.
7.6 million. And can you get me the schools that is applicable to?
We can get back to you on that.
Okay.
Yeah.
And Be Heard has nothing to do with you. That's the mayor's office 100% is what you're saying. Be Heard.
It's H&H, it's FDNY, and the mayor's office.
And do you coordinate? Who coordinates? That's the mayor's office that coordinates?
I believe so, yes.
Okay, it's kind of strange to have perhaps the number one issue that New Yorkers are concerned about, which is activities on the street, mental health, public safety, and not have you be in charge of that or have anything to do with it. That's just how it works?
I would defer questions around that to City Hall and to the mayor's office.
Thank you.
Councilmember Hanif, followed by Narcisse.
Thank you so much. Good morning. So I'll just jump right in. Following the killing of Win Rosario and the city's shameful decision to assign no disciplinary action to the officers who killed Kowalski Trawick, mental health crisis response is, of course, top of mind for me and many, many New Yorkers. The police should not be the default responders to situations that demand targeted health center interventions. I'm going to ask a few questions about how non-police response programs, about the non-police response programs and that the city operates. Could you share how many people are currently served by intensive mobile treatment teams in our city, and what's the total capacity for all existing IMT teams, and how many people are on the waiting list for placement on an IMT team?
Thanks for the question. Just so I'm clear, IMT teams are not involved in any way in mental health crisis response. So
could you clarify what they're involved in?
Yeah, so IMT is intensive mobile treatment, which is assigned to clients with severe mental illness, chronic severe mental illness, who have failed other mobile outreach or treatment attempts. So these are often people who have had an ACT team or a FACT team that they've been hospitalized a number of times, but they are not involved in specific crisis response. They are about long-term relationship and following someone through a variety of community settings, housing, the street, shelters, and even in hospital settings, they interface with clinical teams. So that's a much more of a community health and accompaniment model, and that has a psychiatrist or psych NP, a social worker, and often, and so all of them are trained specifically at dealing with severe mental illness.
And so this doesn't happen through any calls to 911 or any other direct.
No,
it's
no.
Sort of
IMT is not something you assign to someone in a mental health crisis, because it really demands that you know more about what's really going on and what the long-term prognosis is and long-term strategies to keep someone stable and avoid mental health crisis. It's very much a stabilization and preventive long-term recovery strategy.
So are you able to share how many people are served by the IMT team and then the waiting list?
Yeah, happy to. I'll get back to you with the specifics.
And then how many people are currently served by assertive community treatment teams in our city? What's the total capacity for all existing ACT teams? And how many people are on the waiting list?
Yeah, great questions. Similarly, I'll get back to you with specifics, but ACT teams as well not involved in mental health crisis response, much more around long-term care. And the interesting thing about ACT teams, because they get Medicaid dollars, we have ACT teams as well. H&H has ACT teams as well through their system.
And then are you able to share the funding for both of these teams?
Yes, happy to get back to you.
Hi, Councilmember. Yeah, so funding, and this is actually one of your questions, Councilmember Lee. So ACT teams, the whole envelope is $16 million a year, of which $3.7 million is for the forensic ACT teams.
And then how much did you say was for the forensic?
3.7 million.
3.7.
But that doesn't
5
represent what they can also bring in through
Right.
billing.
That's right.
So I also had a question about how many people are being served by the forensic assertive community treatment teams, and the wait list for that too. Is that something you'll share afterwards?
We
Do you
can
have
share
this-
that after.
Okay. And then what's the average amount of time it takes to assign someone to an IMT, ACT, or FACT team once they're found to be eligible?
Well, we try to ensure that everyone has an assignment within a 90-day window. It depends on what setting, from what setting they're getting the assignment. Let's say they have failed an ACT team, right? So ACT teams have very specific rules around how long a visit can be and for how long a person can be followed. So let's say they've failed that or they need more ongoing thing. Often the referral will come directly from the ACT team to the IMT team, and then we will work on that well before the expiration of so that it's seamless. It's rare that you get assigned an ACT team directly from, or an IMT team directly from a discharge from a hospital, for instance, because again, it requires that people understand a little bit more about what your actual circumstances are and what your long-term prognosis is. So it requires a little more psychiatric follow-up.
So for these programs, the funding that you just outlined, is this an increase or a decrease?
I think it's been fairly stable for some time, but when we get back to you on the details.
We did expand the treatment slots for IMT under the mental health plan, and we are working to fill all of those slots are filled. So we have invested in and are expanding those slots, but it's not just city dollars. It's
Sure.
a combination of city and state.
Yeah, these are critical programs, and we're really grateful that they exist,
Yep.
and definitely want to see an investment. Thank you, chairs.
Okay, now we have questions from Councilmember Narcisse, followed by Stevens.
Good morning. Thank you, chairs, and thank you for being here, Commissioner. The Nurse Family Partnership connects expanding Medicaid eligibility parents with personal nurse home visits for support on education to ensure healthy pregnancies and healthy infants. And we know the statistic for Black community and brown communities, right? The fiscal 2025 budget for the Nurse Family Partnership is approximately $15 million. The council called on the administration to increase the baseline budget by an additional $5 million. How many families have benefited from the Nurse Family Partnership in 2023? Second, do you believe that the current budget for this program is satisfactory for the services provided? What additional services can be provided with $5 million increase to the budget? Three, the family, I know I have to take my time,
okay,
you know,
no problem.
the time is ticking now. The preliminary plan included a technical adjustment that included an additional $3.4 million in fiscal 2024 for the Nurse Family Partnership Program in collaboration with the Administration of Children's Services. Why was funding transferred to ACS? A, what is the DOH-MH role in the Nurse Family Partnership, and how does it differ from ACS role? Do you foresee any additional funding transfers in the future? And that's another part of the question. Medicaid funding uncertainty, right? We know it's uncertain. Giving that additional $150 million for Medicaid is contingent upon federal payments that have yet to be realized. What contingency plans are in place if these fundings do not materialize as expected? I hope
Okay.
you take notes of all.
We'll do
All
our
right.
best. So we run the Nurse Family Partnership. We have for decades. It's an evidence-based national program, and in fact, the New York City's program, the health department's program, is one of the exemplars that has been used to establish the foundational research and evidence base for nurse-family partnerships. So we're entirely committed to this program, and it's something we celebrate. The partnership with ACS and the specific provider you talked about, I'll defer to Aaron.
Yeah, thank you, Councilmember. The ACS relationship is really just a technical one whereby we leverage funding that they're able to draw down from the state, Office of Community and Family Services, that helps support us. So it's really, we give them city dollars, they help bring down additional state funding to help. This is just an annual transfer.
The only other thing I would say is, you know, as far as ongoing funding or whether we have the right amount of funding, I would just defer those questions to OMB. We're always in discussions with them, and I certainly wouldn't turn down additional dollars for this essential program for maternal health, but we'll have to defer those questions to OMB.
But if you depend on the funding, don't you want to know if the funding coming and the plan that you have in place is going to take place, or you have to wait for OMB?
Well, I know what's baselined in our budget and what's presented in the executive plan. I think you were speaking to more funding.
Yeah.
And
if you don't get that, so what happened?
Well, more funding would fund more services.
Oh.
So we know what we can do with the funding we have, with what's baselined. Any additional funding, we might be able to do other things. But all of that is subject to discussions with OMB, which are ongoing.
Okay, so how many families have benefited from the Nurse Family Partnership in 2023?
We'll get you exact figures.
Okay. I guess my time is up. I cannot continue.
You have one more? Go ahead.
All right. So let's talk about the public health laboratory, right? The current capital budget for the construction, probably you're going to send me to OMB again, for the construction of the public health laboratory is about $150 million. And construction is estimated to be completed in fiscal 2026. What specific service will be provided by the lab?
We are so excited about this lab. This is the crown jewel of our public health system. As far as I understand, the construction is on time and on schedule, which is a pretty dramatic thing in New York City. And so we're very excited about this lab. This is going to be the state-of-the-art public health lab in the United States, which will protect this city. As we know, the city often is the epicenter for communicable disease outbreaks and
we know that
health emergencies. We know that all too well. And so we are now matching that with the kind of state-of-the-art laboratory capacity that we need. And the fact that it's located in Harlem, and we actually have a community hiring plan and community investment plan associated with the lab. We're very excited about this. So this will be the standard for public health labs in the country, and we just can't wait to get started in 2026.
I'm going to tie it up with the Black and brown communities, since we're doing it toward Harlem, right? So are you planning to hire in that vicinity, encourage, and what is your plan for future to integrate our youth from the high school on to see the opportunities?
Absolutely. I mean, that's what we're so excited about. Some of the work we're starting to plan around career pathways, about science fairs, about community engagement, and really ensuring that we're hiring locally, we're investing locally, and that people see futures in science, in public health. These are careers that we're struggling with workforce throughout this city and this country in our public health system.
That's the reason I'm asking those questions.
And this is a perfect opportunity for us to really invest in our communities while also ensuring that people who go into public health look like us and represent us and have opportunities that are equal. And so I'm very excited about this lab on many levels.
So what you currently have in place in those schools to kind of integrating and encourage those young folks out there, the Black and brown communities, to benefit from the bigger plan?
We do a lot of outreach currently with science fairs, with high schools. We also have the largest health internship program in the country.
What does the number look like? Because when you say the bigger,
we have 200 interns every year, but I can get more specific numbers. But hundreds of people come every year for summer internships to the health department to learn about public health, and that is a crown jewel for us, because often those people go on to be deputy commissioners and so, or leaders in their own right in other parts of our public health system.
Yeah. Thank you for that, because I believe that every child born gifted and talented is a lack of opportunities. And if we're having the biggest child and we have to be we have to be able to compete, because we're talking about New York City, and our black and brown kids every day on the streets. And then we have COVID pandemic with the mental health. So all those things need to be addressed. And I'm counting on you, like you said, people like us too. So we have to be very inclusive city.
Agreed.
Coming back to the lab, right? Will the new building include brand new services that were not included at the building that you're replacing now? That is replacing? You said state of the art. I'm expecting that.
Yeah, I mean, certainly it allows us to bring in state-of-the-art laboratory equipment. It allows us to increase the throughput of testing. So you might recall at the beginning of COVID, there was only a certain amount of testing we could do at the public health lab, and then we had to get commercial labs to come in. That may still be the case depending on the circumstance, but this allows us to do more testing. It allows us to invest in technology. So there's just so much more that we can do. I don't even know that we know all the areas that are going to benefit, because there's so much innovation happening in this space with technology, AI, and otherwise.
I know I was going to talk about AI, but I'm not going to do that because I don't want the chairs to get me off. At the preliminary budget, my last question, hearing, I expressed concern, all of us, over the closing of the William Hallock Park Memorial Public Health Library, which provided public access to medical journals and that database. Will the Public Health Laboratory provide access to these articles?
So they're a little bit different. The Public Health Library is located at the Health Department headquarters itself, and while it's technically open to the public, we have found over the years that the public hasn't used it really at all. Meanwhile, the cost of journal subscriptions has increased significantly, to the extent that even universities are canceling their journal subscriptions. Even the University of California has significantly reduced their subscriptions to medical journals because the cost is just going up and up and up. And so in a difficult environment, we had to make some tough choices, and this was one of the choices. But the positive news is that we are exploring with our academic partners, so CUNY, Columbia, NYU, specifically SUNY, on ways that we can partner to maintain access. And we have also managed to maintain access to key journals for our most critical staff, our frontline staff, our disease investigators, people out there in the field serving New Yorkers.
Thank you, chairs.
Now we have questions.
Thank you too, sorry.
Thank you.
Questions from Councilmember Marmorato, followed by Sanchez.
Okay, thank you so much. So your 15 for 15 and the Justice Involved Supportive Housing programs, they focus on supportive housing to people with mental illnesses, and as well as transitioning them out of incarceration and or struggling with homelessness. Is that correct?
That's correct.
Okay. Are these people allowed to refuse treatment?
Are they allowed to refuse treatment? It depends. If they're under an assisted outpatient treatment order, court-ordered treatment, then there are certainly there are legal consequences for refusing treatment. But being on an AOT order is not a condition of any of our housing in New York City.
Okay, thank you.
Councilmember Sanchez?
Good morning, and thank you, Chair. Good afternoon, morning? Afternoon, it's 12:02. I have 3 questions. The first question is on maternal care as well. And it's been very heartening to hear about your progress on the doula initiative. But in 2022, March of 2022, the mayor also announced a midwifery initiative. And we know that across the globe, although in the US we do not have a predominance of midwifery care, across the globe, midwives do deliver most children. And so The mayor's announcement said that the midwifery initiative would be expanded to 38 public and private birthing facilities across the city, that partnerships would be created with midwife organizations, private practices, and community members, and that a report would be released by the City of New York, and that care would be available at all 38 facilities. So can you first and foremost just report out on the midwifery initiative, how many NYC birthing facilities now have midwifery care, and have we seen any shift in the numbers or percentages of children babies being born to midwives?
Thanks for the question. I can attest personally, 2 of my 3 children were delivered by midwives, and I think my wife would be here celebrating them as much as I am. So it's a priority for us. We've hired a midwifery director at the health department to lead this work within the Division of Family and Child Health, and they are working with our maternal health review committee, as well as our maternal health quality improvement network, to start to build these partnerships with clinical facilities, some of which have invested already in midwifery services, and some of which have not. We're also working closely with H&H on that work as well. So we'd be happy to follow up with specifics for you, but midwifery remains an important arrow in the quiver to tackle maternal health and maternal mortality. I will say that with this, PEG exercise and contracting exercise, some of that had to be paused, and now is up and running once again.
Okay, thank you. I mean, I have 1 child, and I have vowed to myself that I will not deliver with an OBGYN next time. That's how negative my experiences were in childbirth. And it's just, midwifery care is just it's an easy, you just said your children were born to midwives, right? It's just such an easy way to improve, outcomes for women. And I'd also, just a quick follow-up, and sorry, I do have the other 2 questions, but the quick follow-up is on insurance care, right? Even as women who are searching for alternatives, many midwives are not in network. Out-of-network coverage is terrible. Is there anything that the City of New York is doing to assist in this?
Yeah, that's a part of our advocacy to state Medicaid in particular, knowing who is at greatest risk of a poor maternal health outcome is likely to be Medicaid recipients. And so, yes, this is a part of our advocacy, amongst many other points, in terms of how payment reform needs to drive improvement and quality improvement in maternal health care.
Great. Thank you. Chair, if I may, chairs. So second question is on 988. During a recent emergency near my office, neighbors were afraid to call the NYPD, and my staff was helping, and we brought this information. There's this other hotline, there's 988, and we sat there and we called 988 with the individual who was struggling with the emergency, and it was not helpful. They were not prepared to assist in a helpful way during that time. So for this just public education, for my education and my team, in what circumstances should we call 988 when someone is in distress? Are there particular kinds of distress?
Well, I'm very sorry you had that experience. We run our 988 program through a contractor that we've been working with even long before it was 988, when it was launched as NYCWell, which is the same contractor that's running the federal 988 hotline throughout multiple jurisdictions, called Vibrant Emotional Health. And that is, I would love to follow up with you about the specific case, because that is an opportunity for quality improvement that should not happen. You should be able to you should not feel that the person on the other end is unprepared. So, to your second question, when should someone call? They should definitely, you did the right thing, and your team did the right thing in trying to help this person through 988, because they are meant to be trained and prepared to handle a range of mental health needs through de-escalation and dialogue on the phone, but also through referral to a range of mobile response.
And are they able to dispatch crisis response teams?
Yes, certain ones. And this is part of the kind of both culture shift and protocol shift, that they, not all of our teams run through the 988 system. Some of them run through the 911 system only, and so these are active discussions.
Got it. Thank you so much. And I'll stop there, but just to say, I've been having great conversations with your team on expanding access to rapid STI testing, so thank you for those conversations, and
Excellent.
I look forward to resolution.
Thank you.
Thanks, chairs.
Okay, we've also been joined by council members Feliz and Brooks Powers, and now I'm going to hand it over to Chair Schulman to close us out. What's that? Yeah, if you want. You have more? Councilmember Lee.
Sorry. Just wanted to ask a couple questions, because I know this is an important issue for Deputy Speaker Ayala about the syringe buyback programs. So local law 2022-124 requires DOHMH to establish a needle, syringe, and sharp buyback program in 5 high-need council districts. DOHMH would determine eligibility for participation as well as the buyback incentive of up to 20 cents per needle with a cap of $10 per individual per day. The program is set up to expire after 1 year, and 6 months after expiration, DOHMH is required to submit a report on the names and locations of the buyback programs, the number of litters returned by location, the total amount of money dispersed, and recommendations on whether this program should be permanent and expanded. So at the preliminary budget hearing, we were informed that the pilot had not yet begun and there were issues finding a provider to manage the program. So what is the current status of the implementation of the program?
Thanks for the question. Two issues here. One is similar to the Vision program that Councilmember Brandon mentioned. This was caught in the freeze, the OTPS and PEG freeze. We couldn't really mobilize the resources for that at the time. But probably more importantly, we're working to finalize the rulemaking around the buyback, and that was open for public comment earlier this year, and we're working with working to finalize those rules with partners, and we plan to execute a contract with the vendor and launch a pilot as soon as we can in the next fiscal year.
Okay, do you have more of a specific timeline?
Once we know when the rulemaking is finalized, we'll have a better idea of how quickly we can get off the ground. So
Okay.
it's down to the technical rulemaking at the moment.
Okay, and then has the program locations and which districts the programs are located in, has that been established yet?
Not yet.
Okay.
That's, again, kind of subject to some of the rulemaking. As you might imagine, there's a lot of interest, but also a lot of opinions and ideas around how best to implement that, and that will also help determine where it's most needed and also where it's most likely to succeed. We don't want to get off the ground with a high chance of lack of success.
Okay, and then just the final question that was here was the update on syringe services programs. So I think the executive plan includes $60,000 in fiscal year '24 only for a syringe service program and kiosk adjustment. So can you provide the committees with the context for this adjustment and what specific services will be provided with this additional funding?
Yeah, this is a very specific transfer from the Parks Department to maintain one syringe kiosk program, but syringe service providers remain the bedrock of harm reduction in our city. Our first 2 overdose prevention centers are located at syringe service providers, and we took steps in the first tranche of the opioid settlement funds to invest in our syringe service provider system to prepare them for a wider array of services like mental health care, primary care, and so forth. So we're very committed to that model.
Okay, and then do you also have a breakdown of the syringe service program and kiosks that are part of the adjustment?
Yeah, we have the program with the Parks Department supports 30 kiosks in 14 parks across 3 of the 5 boroughs.
Okay, and then I know funding was added in FY24 only so far, it seems. So will DOHMH be able to spend this funding by the end of the fiscal year? If no, do you plan on rolling over the funding? And if yes, in terms of if you can spend it down, why were the funds allocated for fiscal '24 instead of fiscal '25?
I'll defer that to Aaron on the spend down. And
Yeah, I mean, we expect to be able to spend this down. If we don't, we would certainly advocate to roll it over and keep it going.
to roll. Sorry, I feel like you get quieter as you keep going. So that's why I'm like
Apologies,
listening very
Councilmember.
intently. I can't hear. Sorry.
Apologies, yes, we expect to spend it down, but if we don't, we'll certainly be in discussions about moving it over, continuing in the next fiscal year.
Okay, perfect. Thank you. That's it for me.
Councilmember Feliz.
Thank you. Thank you so much, chairs, for this hearing. Commissioner, it was great seeing you a few weeks ago on Fordham Road in the Bronx for the grand opening of a new healthcare facility. And great seeing you again today.
Good to see you.
So a few questions that I wanted to follow up. Wanted to continue on the same line of questions that Councilmember Lee started on the syringe service providers. Can you give us information about what exactly specifically the mobile syringe providers, what are services that they provide?
Yeah, so they do things like removing discarded syringes. They receive syringes directly from community members for safe disposal. They have distributed more than 20,000 naloxone kits. They've made more than 25,000 referrals to additional community services like mental health care or treatment or support for basic needs. They've removed over 400,000 syringes from parks, and more than 90,000 syringes have been handed in. So they're a key part of not only harm reduction and keeping people safe, reducing communicable diseases, but also maintaining safety and dignity in our parks.
Okay, for those that are providing syringes, would you say that's an exchange program, or are they simply providing them?
So exchange generally means that you turn in used syringes, and in exchange you get clean materials. I don't know if these mobile sites are actually doing the exchange part. That's something I can follow up with you.
Okay, I just want to say these are.
But that is at our other syringe service providers. They definitely do needle exchange.
Yeah, and I think all of us agree that these programs are life-saving.
Yeah.
But at the same time, we need to make sure that they're implemented correctly. We've seen in many parts of the Bronx trucks set up providing syringes, not exchanging them, simply providing them right next to a school. So children literally having to tiptoe their way to school. That's a tragedy waiting to happen. And not only next to our schools, but also in right next to children's playgrounds. Welcome you to visit the Kingsbridge and also the East Tremont part. Some of those areas are unwalkable. That's how many syringes you have on the floor. Of course, this is a life-saving program, but we need to make sure it's implemented so that we don't create a new tragedy or new public health problem while trying to solve the other. So look forward to chatting about that a little
happy
bit
to
more
continue.
offline.
We're aware of the issues and happy to continue conversations.
Yep. Thank you so much.
Thank you.
Councilmember Schulman.
Yes, so I want to thank you, Commissioner, and your team. I do want to say that at the expense budget hearing that we want to hear about numbers, so we expect you guys to get back to us with specifics on all of the questions that we asked as soon as you can, and we'll follow up as well. But with that, we look forward to working with you on New York, on Healthy NYC and all the other initiatives, and again, thank you for your time today. I will ask, so later this afternoon, we will have public testimony that somebody from your office actually be here. So I'm gonna make that request. Thank you very much.
Commissioner, thank you. We're going to take a 10-minute break, and then we'll hear from H&H. Thank you. We'll take a 10-minute break, and we'll hear from H&H. You got to sign up. If you want to speak, you have to sign up to testify. Thank you. If you want to testify, you have. Okay, please have her removed. Have her removed. Thank you.
Good afternoon, ladies and gentlemen. At this time, we're going to ask that you please find your seats. Once again, please silence cell phones and electronic devices. We shall reconvene momentarily.
Okay. Good afternoon and welcome to the final executive budget hearing for the day, focusing on the New York City Health and Hospitals Corporation. Councilmember Brannan, I chair the Committee on Finance, and I'm pleased to be joined now by my colleague and friend, Councilmember Mercedes Narcisse, who's chair of the Committee on Hospitals. In addition to who we had at the last hearing, we've been joined by Councilmember Hanks. Welcome to President and CEO Dr. Mitch Katz and your team. Thank you for joining us today to answer our questions. Again, on April 24th, 2024, the administration released the Executive Financial Plan for FY 24 to 28 with a proposed FY 25 budget of $111.6 billion. The Health and Hospitals Corporation is not a city agency, but under agreement with the city, it does receive a city subsidy to administer new programs. H&H proposed FY25 subsidy of $3.04 billion represents 2.7% of the administration's proposed FY25 budget in the executive plan. This is a decrease of $19.5 million or 6% from the $3.06 billion originally budgeted in the FY25 preliminary plan. This decrease results from several actions, mostly a net reduction in asylum seeker funding, offset by increased funds for the H&H collective bargaining agreement. The Council's preliminary budget response called for an additional $29.6 million to support a range of mental health programs, particularly mental health courts and diversion programs with the city's district attorneys, and a maternal health psychologist in each of H&H's maternal health departments, along with a call for a new trauma hospital in the Rockaway Peninsula. Once again, the mayor's executive budget includes not a dime of any of these proposals the council put forward, despite the council identifying sufficient funding. At this point in our city's history, especially when it comes to mental health, our neighbors need us to meet the demands of the time. We cannot afford to fall short. My questions today will largely focus on H&H's utilization of city funds, school-based health and mental health centers, the changes in asylum seeker funding, including the continued contracting with DocGo, and vacancies at various H&H hospitals. I now want to turn to my co-chair for this hearing, Councilmember Narcisse, for her opening statements.
Good afternoon, and thank you, Chair. Good afternoon, Dr. Katz and the team. I appreciate you being here. Good afternoon, everyone. I'm Councilmember Mercedes Narcisse, Chair of the Committee on Hospitals. Thank you for attending today's hearing on the city's fiscal 2025 executive budget. During today's hearing, we will review the New York City's Health and Hospitals operating fiscal 2025 budget of $3 billion, which represent nearly 3% of city's budget. But first and foremost, I would like to thank everyone that has joined us today, including everyone here. And now I have to say, who's my now? Farrell Lewis and Sylvina Brooks Power. Thank you, Chair. And Councilmember Hanks and Councilmember Brewer. As I mentioned in our preliminary budget hearing, it is very important to take care of New Yorkers. And Dr. Katz, you know that. But we should not forget to take care of our medical professionals too. It is critical that we seek to build safe and equitable work spaces and facilities for both patients and employees. As such, I will be looking to learn more about complaints and grievances procedures in H&H facilities, working conditions for residents and interns, and recruitment and retention practices for nurses across New York City health and hospital facilities. As many of you know, sickle cell disease is very important to me. It's a very important topic. And this council works to narrow health disparities in our city. The detection and treatment of sickle cells are critical to reshaping the quality of life of the Black and brown populations. In 2023, Local Law 163 was passed to increase access to information and testing of sickle cells. Today, I would like to hear about the status of implementing the legislation. Lastly, among other topics, we are going to discuss the collaboration between H&H and DOE schools on the temporary nurses in serving our students. In addition, we'll examine Mayor Adams' announcement on March regarding the substance use disorder clinic for expecting and parenting facilities. I'd like to thank my Committee of Finance Analyst staff, Veda Yagnik, Unit Head Florentine Cabaret, Committee Counsel Ria Ogazarwara, Policy Analyst Manu Butt, for their work on this hearing. I would also like to thank my Chief of Staff and all my staff that are working so hard to make New York City a place to live, work, and enjoy. I will now turn it to my Chair, Brennan. Thank you.
Thank you, Chair. Also, before we get started, I do want to continue thanking the Council Finance Division who works very hard behind the scenes this time of year, especially to Unit Head Florentine Gabore and Veda Yagnik, the analysts for today's hearing, my committee counsel, Mike Toomey. As a reminder, for this year's executive budget hearing, for anyone wishing to testify, we'll be taking agency testimony, a topic-specific testimony later today after H&H is done testifying. If you wish to speak on either the DOH-MH or the H&H executive budget today, just make sure you fill out a witness slip with the Sergeant-at-Arms. I'll now turn it over to Mike Toomey, committee counsel, to swear in the witnesses, and we could start.
Good afternoon. You raise your right hands, please. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and to respond honestly to councilmember questions? Dr. Mitchell Katz, John Olberg, Dr. Patsy Yang. Thank you. You may begin.
Good afternoon, Chairpersons Brennan and Narcisse, and so glad to see the members of the Committees on Finance and Hospitals. I'm Dr. Mitch Katz. I'm a primary care physician, and I'm the proud CEO of New York City Health and Hospitals. My great CFO, John Olberg, is here with me, as is Patsy Yang, who does a great job running our correctional health services. Our executive plan is consistent with the January plan. We continue to be stable as an overall system. We project to close fiscal year 24 with a cash balance of $760 million, or 28 days of cash on hand, and a break-even operating margin. This is similar to what we've projected earlier. We have some good news we look forward to sharing with you. We closed February 24 with a positive net variance of $156 million due to strong patient care revenue and risk pool performance. What I'm most proud of in my 6 years with us is that we continue to outperform year after year on revenue. We, in February, $325 million higher than the same time in the previous year, and this is all from insurance. And you remember 6.5 years ago, the idea was that health and hospitals had to shrink. There wasn't enough city subsidy. There was a huge deficit. And we said, rather than shrinking, we believe we can grow if we would only start billing insurance, not individuals. We're not interested in billing individuals. We're interested in billing their insurance and getting what we fully deserve. And the fact that 6 years into it, we've produced $2 billion in additional annual income, and that it keeps growing. And that's the only reason we can keep paying for nurses and all of the other things that we want for our patients. Our strategic financial initiatives remain on track, generating over $825 million in revenue with a line of sight to $1 billion for the fiscal year. We continue to work on the social determinants of health. I'm proud Health and Hospitals is the only hospital system that has a lawyer in every single hospital facility available to people to deal with things that may at first seem unrelated to their health, like eviction. But of course, eviction is entirely related to your health. because if you and your family are evicted and out on the street, it's going to be very hard to maintain the health of you and your children. We do immigration cases so that people can get the benefits that they deserve and be able to work. We completed our citywide expansion of our lifestyle medicine programs at 7 of the sites in all 5 boroughs that work with people on a plant-forward diet and stress reduction, exercise, improved sleep, meditation, and have seen people actually get off hypertension medicines and cholesterol medicines and diabetes medicines once they're able to change their diet. We're pleased that for the additional money for overdose prevention programming in the executive budget that comes from the settlement funds, and we're, of course, as Chair Narcisse was talking about, the substance use disorder clinic that's going to be at Lincoln that's really going to focus on expecting and parenting families. I mean, that's such a critical time in the life cycle, and that's when we really want to be able to do everything to make people healthier. And I'm very pleased that we've now hired more than 1,000 nurses since the new contract, and we are in line to hit 1,500 new nurses. You'll remember that at one time our salaries were so non-competitive that we had 1/3 of registry nurses because we couldn't hire, and our goal now is to have every nurse work for health and hospitals, to use registry only for what registry was intended for, which is someone has an unexpected illness, you're going to save their job for them, you need someone to come in for 2 months, someone's on parental leave. That's what registry is for, holding somebody's job, having that nurse position filled, but not for 1/3 of your workforce. So we appreciate how City Council helped us to advocate for making that happen. There will always be challenges at the state level, but we appreciate the support from the governor's office as well as State Senate Health Chair Gustavo Rivera and Assembly Health Chair Amy Paulin, and lots of state senators and assembly members who represent our facilities, and all of you who talk to them and help make sure that the state budget is a fair one to us. We also, of course, rely on federal funding. We're very grateful to Representative Clark and several of our delegation members for making sure that the dish cuts did not happen, and I know this is an issue City Council has also been working some on. So overall, we're in a good position. We want to keep growing so that we can do more. We want to end each year without a surplus because our patients have so many needs. Our goal is to bring in as much insurance revenue as we can and spend every penny of it on our patients and maintain as low an administrative structure as possible so that the money goes to the people we serve. Thank you so much, and I look forward to your questions and to your recommendations.
Thanks, Doc. We've also been joined by Council Members Marmorato, Palladino, and Moya on Zoom. Okay, in the executive plan, the city funds total $2.6 billion for FY25, an increase of $1.1 billion compared to the FY24 adopted amount of $1.5 billion. So could you tell us what is the reason for the significant increase in city funds in the FY25 executive budget?
Good afternoon. Yes, it's been a pretty interesting journey, I would say, for health and hospitals over the years. We've responded to, COVID and T2 and now HERC. And the reason for that almost nearly $1 billion increase is primarily attributed to additional investment and resource need related to HERC.
Related to what?
To HERC, the HERC program,
okay.
the asylum, yeah.
And are there projects that are exclusively city-funded, or do most H&H programs and services include a blend of funding?
So most of our services are blended. And we don't aim to provide this amount of money for this medicine versus that medicine. We try to get as much money from insurance, and then we spend it all on our patients. But the exceptions are correctional health, which gets a specific amount, which dates back to when the city contracted out correctional health, and the HERCs as well, the humanitarian centers. We have an agreement with partnership with OMB and the Department of Housing Services, so that we together decide, here's what we're going to do, this is what our contribution is, and OMB approves the expenses and pays us, so that the money to support the humanitarian centers doesn't take away care from our patients.
Could you detail for us which programs and services are exclusively funded with city dollars?
Besides correctional and humanitarian.
Yeah, I would just mention NYC Care would be another example of that for $100 million.
I would say that's a mix, because we remember that it was an add-on.
Yep.
So when we did NYC Care, the city agreed to certain additions, right? But the vast majority of money is actually our traditional sources.
Sure.
Yeah.
Yes.
Any others that are 100% city?
No, nothing comes to mind, other than we do receive some subsidy funds, but
Okay.
that's just it.
If you could provide us with a full list, a detailed list, just, you know, the ones that are fully city subsidized versus.
Sure.
Okay.
Absolutely.
And what programs or services funded in the current year do not have baseline funding?
Do not have baseline funding.
Yeah, which of it is, you know, one-time, one-shot funding?
Oh,
I mean, just within our.
one shot.
Yeah, I would say we don't have much in the way of one-shot dollars. We have things that phase in and phase out, but no particular, one-shots.
So you don't have programs that every year you have to pray that they get fully restored?
No, nothing that. I mean, we try to stay away from those sorts of programs because they're disruptive.
Sure.
Right. Yeah, they're disruptive.
Everybody loves a baseline.
Yes.
Do certain hospitals receive more city funding than others?
Well, yes, because think about it. You have hospitals that are huge, like Bellevue, which is currently running a census of 860. And then you have a hospital like Woodhall that runs a census of about 120, 140. And then even if you look within, some hospitals have higher insurance percentages than others, or said the other way, some hospitals have higher undocumented patient volumes than others, so that the amount of revenue. But what we maintain is there's only one standard of care. So a hospital is not penalized if more of their patients are uninsured. We don't say, well, then you have to work on a tighter budget. We're giving you fewer nurses because you don't bring in the money. So we bill as a system, and then we distribute the money, and the money is based on the volume, not the insurance mix.
There is a $207 million decrease in federal funds in the H&H federal budget. Is that part of the reduction in funding due to the expiration of COVID money?
A reduction of, yes, it probably is. There's a number of things going on. Back to the HERC program, there's actually an increase in federal funding related to HERCs, a small amount. But yes, I would say that the 207 is more, we can confirm this, but more than likely the reduction related to COVID. And we're pleased to say that we'll be submitting our last COVID claim this week. So that draws a conclusion for us in terms of the claiming that we've done to FEMA and the federal government.
How will the FY25 adopted state budget impact your budget?
Yeah, at this point, we're still evaluating the budget. There's many different components to it. I think if today, our assessment is that it's probably neutral. There's some reductions in areas that we don't support or appreciate. There's another, capital reduction, 10% capital reimbursement reduction in the Medicaid rate, which is approximately $20 million, which was on top of a 10% reduction taken in the previous year. There's a reduction to the MCO quality pool. I mean, it's a very valuable pool of funds that health plans receive, and then they in turn distribute those dollars downstream to hospitals and other providers based on their performance. There was another reduction in that pool. And then there was also an across-the-board reduction as it related to managed care reimbursement, which affects us at Health and Hospitals because we run our own health plan, Health Metro Plus, and we're a collaborator with Health First. So when there's reductions that are taken as it relates to MCO, managed care reimbursement, health plan reimbursement, that does ripple down to us. So those are the negative side of the equation on the budget. I would say on the positive side, there was a lump sum investment. We don't really quite understand how it's going to be administered yet, but it would be an increase for our hospitals and nursing homes of, I think it was roughly $575 million statewide. So again, waiting to see how those dollars are distributed. And then there was a pool of funds set aside for safety net hospitals, specifically $300 million. We're eligible to receive those funds, but how they're going to be distributed, not yet determined. I think what the state's trying to do there is encourage collaboration between safety net systems, of which we've been obviously a partner in that. But yeah, on balance, we're still trying to sort it out, but we think we'll be okay with the state budget.
At the FY25 preliminary hearing, H&H agreed to provide the council with a breakdown of position-based vacancies at H&H hospitals. Woodhull has a nursing vacancy of 18.1%. Could you tell us why Woodhull's vacancy rate is higher than other H&H hospitals?
So all of the vacancy rates don't yet reflect the movement of the nurses into their positions because, as Chair Narcisse knows, there's an orientation period for all nurses who join a hospital system. So we maintain the registries and the position is open until the nurse finishes his or her training, and then we'll move into the position. Each of the hospitals has different challenges hiring, sort of based on neighborhood, specialty, things people want to work there, people don't want to work there. What's important to us is we always maintain registry when necessary so that no patient is underserved. That's our bottom line is patient arrives at whether it's Woodhull or any other hospital, they have to have a doctor, a nurse, a social worker. If we don't have those positions, then we're going to be using registry. So we don't mean, even if there's a vacancy, that doesn't mean you don't have a nurse. It just means that the nurse is from the registry side, not from the permanent employment. All our staffing is based on census. More patients, more nurses.
Can you provide the vacancy rate for physicians at all the hospitals, Jacobi, Lincoln, Metro, North Central?
Yes, absolutely. But again, just because our budget is so different than most of the city budget, if I have a doctor vacancy, I can't allow that to mean that the person doesn't see a doctor. So I have to fill the slot one way or another. So the way in a doctor case, most of the slots are filled with per diem doctors. So doctors can volunteer to do additional hours, or we'll use an agency to get a temporary doctor till we fill the vacancy.
Is that more expensive?
It is. So the goal always is to hire the full-time doctor. It's just not always possible. Our physician salaries, while compared to what most New Yorkers earn are quite good, are less than the wage people get in private hospitals. And so we're always sort of piecing together. Often, some of our best doctors are doctors who are earning higher salaries in private facilities, and then they'll work for us per diem as a way of giving back. So they'll work 20%, 30%, but they would never take a full-time job with us. because of the salaries. So that would show as a vacancy because I don't have a full-time doctor, but the patient would still be seeing a doctor. It was just that doctor is a per diem doctor who's giving back. So that's why, again, because we don't run static staffing, our vacancy rates, they do tell you something. They tell you whether or not the job is attractive in the market. But it never means that the patient doesn't get served.
What's the salary that's offered for
For a physician?
Yeah.
Oh, it can vary tremendously. So in the market, at the bottom are people like me who are primary care doctors, pediatricians, primary care doctors. Salaries run low 200s. So again, relative to what New Yorkers are earning, it's quite a lot. And then you can have surgeons who are earning, a cardiothoracic surgeon could earn $850. But again, they might in the private sector be earning, believe it or not, $1.5 million. I mean, this is New York, and it is a high market for physicians, in part because of the cost of living.
What about nurses? How many temporary nurses has H&H utilized over the past year?
Well, so before the council helped us to get raises, huge numbers. Do you
Yes.
have?
Yeah, no, I would say the number probably at our high point that we're trying to solve for was somewhere near 1,500 nurses.
And what's it at today?
Today, well, as you know,
500.
Yeah, and as Dr. Katz had mentioned, we've hired 1,100 of our own replacement, H&H replacement nurses. There's a pretty extensive training program, so they don't really come online immediately, but we have an 18-month plan to eliminate the 1,500 nurses that were at the high point, during COVID, post-COVID, that we were, we relied on, but our goal is to eliminate those 1,500 contract positions.
How many or what's the percentage of H&H residents that are CUNY medical students?
H&H residents who went to CUNY?
Yeah, right. CUNY medical students.
I don't know. We'd have to survey from the existing residents what medical
Is there any kind of pipeline there?
Yes. I mean, I think on pipeline, downstate is the medical school that produces the most residents. It's just the CUNY Medical School is still a pretty small medical school in terms of number of graduates. But downstate is a huge provider.
A couple more from me. Just to follow up on the school-based health centers and the school-based mental health centers. April 17th, the mayor and H&H announced the opening of a 16 school-based mental health clinics in DOE schools over the next 6 months. I think the plan was to serve 6,000 students across the Bronx and central Brooklyn. Can you provide specific details on H&H's role in establishing those 16 new clinics?
Well, we'll be doing the clinical services for those 16 clinics. And, we think that, the need for mental health for school-based is huge right now. Coming out of COVID, I believe all of us have been traumatized, adults and children too. But for them, they're clearly at a precious point in the life cycle. And I think a lot of psychological issues that no one's seen before, high levels of anxiety, high levels of depression, probably made worse or amplified by social media. So we're very happy with the funding, and we'll do a good job of providing those youth with mental health services.
Do we know when those 16 clinics are expected to be fully operational?
You have a date?
Very soon is the answer to that. And the funding is an allocation of about $3.6 million, and then it's being supplemented with funding of about $700,000 from the Office of Mental Health. And I should have mentioned in the recap of the budget that the governor's been very supportive in behavioral health, and we've enjoyed the benefit of those investments.
I see the executive plan includes $24 million in intercity funds for H&H school-based health centers in FY24 only. Is that funding related to those 16 clinics?
Yes, I think so. Yes, I believe it is.
Okay. Okay, I want to ask about DocGo. How many contracts does H&H currently have with DocGo?
Well, so I'll say what I know, and because there was recent news about us entering into a contract, so I just want to be clear that that particular contract has no guarantee of dollars, and it actually does not look like we're going to be using that contract at all, not just specific about DocGo, but the contract that was in the newspaper. We went into it with the idea that we would be setting up new HERCs, new humanitarian shelters. But it does not look like there is the need, or that it will be health and hospitals doing it, to the extent that there are more needs for clinics, for shelters. So that particular contract was for the effort that it takes to identify a building and do whatever fire safety things and whatever renovations and start it. Now, there is an ongoing contract that I know I can't characterize, but that provides, I believe it's medical care.
Yes.
And screening at the center. Is that the only other one?
Yes, I believe so.
I'm pretty sure.
Yes.
So there's one other one, which is a long-standing one, which has provided medical care. It is our goal, and again, this is not even specific to DocGo, to redo all of the contracts related to HERC, because they were originally set up as an emergency, right? The city suddenly was getting hundreds of people on a daily basis. We needed quickly to house them and give them medical care. But we're in a different situation now. The numbers are stable. We don't have growing population, and we've learned a lot about how to do it, which is different than where we were at the start. So we want to redo all of the contracts, and we've redone the food contract. We redid the contract for setting up future HERCs. Did we redo any of the other?
No, I think those are the major.
We could get back. I don't know.
Yeah.
Do you know the expiration date of the medical HERC contract? We'll get you the expiration date of that contract.
So how many contracts does H&H currently have with DocGo?
We have two, one of which is unfunded.
Okay. And how much, what's the funded amount for that one contract?
The one that runs, do you know?
Yeah, we would have to get back to you on that.
You don't have that with you?
I don't know what.
It's a large contract.
It is. And
April 9th, the mayor said the city would not be renewing a $432 million contract with DocGo. Is that a different contract?
Yeah, that's HPD.
Okay, with so many nonprofits and NGOs that do this work, is there any insight into why DocGo was chosen in the first place?
They did well during
COVID. The lowest bidder?
They did well during COVID, and I think, and a lot of this, again, you have to go back to the moment. The moment was for the medical contract, hundreds of new asylum seekers. You need somebody who can set up the contract with the idea that they're not going to get paid anytime soon. I mean, I don't know how many nonprofits could pay a large workforce without any initial payments. I mean, that's just the reality. Now, once you, and again, that's what I think is different between the beginning of something and how you go forward, right? Nonprofits, once you establish a stable, this is how much work you're going to get, we just had no idea at the beginning, right? And so, you know, till we figured out what the level of service, and we've changed. For example, now we do x-rays for tuberculosis at our arrival center because we found there was a lot of tuberculosis. That wasn't even a service that we did at the beginning. So I think the idea was we needed a provider who had tremendous flexibility and the ability to eat the dollar amount for a while without going broke and continue to hire staff and growing, but that now is the time that the city can do competitive bidding and choose the best provider. And I'm always in favor of nonprofit health care. So I always, believe if you can get a nonprofit provider, that's better.
Yeah. I think you've touched on a larger issue with the city's procurement dynamic with, only these big guys who can manage to float this kind of money are the ones who are, viable for some of these contracts, and we don't always pick the best contractors. Does H&H collect feedback on DOCO services?
We do. We have not, obviously I read the newspapers, but the clients who we have served have been, very happy with the whole service package. Right now, the whole, again, we're somewhat different, and I think you've had hearings and you've met Dr. Ted Long and you've met the people. We're very involved. And that has not always been true for all the centers. So, we view it as we're in charge. The DOCO might provide services, but we don't allow them to make the decisions. And I think between Dr. Long and Chris Keeley, we just have a very strong set. And so, we don't say, the clients don't even know what DOCO is doing. They view it as one thing.
Sure.
And I think generally, and I'm sure you've spoken yourselves to asylum seekers, those who've been in our HERCs generally have positive things to say about it. We have not had much in the way of unhappiness from the clients.
Okay, I have some stuff I want to circle back to, but I'm going to hand it over now to Chair Narcisse. Thanks, Doc.
Thank you.
Thank you, Chair. Dr. Katz, one thing I heard and I like, you did not make long-term goal or plan on a short-term money. So healthcare cannot depend on a long-term plan for short-term money, so I appreciate that. Our health is so important, and especially we see what happened during COVID, the height of the pandemic. We have to address the inequities in healthcare throughout New York City. And that's what I love New York City, because we're not afraid of the challenges, and you step up, and I want to say thank you. Having said all that, the executive plan includes an $18.9 million intra-city payment between H&H and DOE as a reimbursement for temporary nurses contracted to fill vacancies in the Office of School Health. Are you aware of the reason DOE utilizes temporary nurses for school facilities as opposed to hiring permanent nurses?
I don't know about DOE's hiring. I know that we always want to be helpful. And I've helped multiple agencies to hire nurses or other professionals, social workers, in the example of Be Heard. We've provided nurses to the police department at various times. So if someone says to us, Mitch, you have a nursing registry contract and I need nurses, I'll say, happy to help you. My guess, but you'd have to ask them, is that that there must be challenges with salaries if they're having difficulty hiring people, or just the general nurse workforce has shrunk, making it more difficult to hire nurses. Our goal is just to be helpful to people.
So you've been helpful with them, trying to get...
So we say if you need to hire registry nurses, you can use our contract to do it. That saves them having to go out for bid, and we get very attractive rates because we're such a large, user of the registry contracts historically. So we just get better rates than they would likely get if they went into the market themselves.
Are you still creating incentive for the new graduate from CUNYs? I heard my partner was learning to that. Are you still creating that opportunity? I'm one of them that end up in Elmhurst Hospital, right?
Yes,
because you give incentive. Are you creating those kind of incentives?
Yes. So we have a whole package of ways of trying to make sure that all of the new nurses that we've hired stay, both recruitment bonuses, educational leave, opportunities to get an advanced degree, loan repayments, right? We don't want to make the same mistake that was historically made, which is we train the nurses that went to other hospitals.
Yeah,
Right.
and that's what you do. You're training for other hospital. Unfortunately, that's what it is. But having said that, some of us stay. I went for a couple of years. I ended up staying for, I think, over 10 years.
Yeah.
So therefore, if the structure is creating for opportunity, like you just about to say, that the nurses will stay. Because not everyone, yes, we need to pay our bill. It has to be decent. But if you're creating the structure for growth, our nurses, New Yorkers love to serve New York. As a matter of fact, you see some of the doctors, they want $1 million, but yet they will come and give sometimes if we promote it the right way and showing that this is New York City.
That's right.
So thank you for that too. Is H&H working with DOE? You said you are. Do you have an estimate of how many nurses are expected to be contracted into DOE schools in fiscal 2025? Do you have an idea?
I don't know the number. I mean, the dollar figure is a large figure, right? So you could think about it in terms of how many FTEs that would buy. I would, off the cuff say it's about 100 FTEs that now whether they're going to use all of them, how they're going to hire, I think those questions have to go to DOE.
So you would not know how many nurses were funded through this contract?
No, because they could be using part-time, so I don't know that. I can only give you, based on the dollar, the number of full-time FTEs, but they may not be using them that way. They may be using them, 2 hours here, 4 hours there.
I overheard something that Justin just asked. So the vacancies we're talking about is not really real vacancies, because you're using those dollars to make sure that the spaces, whatever the time, the day that is occupied by doctors and nurses, real people to do the work.
Correct. Again, you as a practicing nurse understand this. I mean, we run trauma centers. Right, I can't have a trauma
nurse here.
Right, say, sorry, I have a vacancy in my trauma nurse, so we can't serve you today. Right, I'm in a hospital's heavily regulated 24-hour, 7-day a week. I always have to have the doctor, the nurse, the social worker, the environmental service person. And so that's why all our staffing is based on census. So I increase or decrease based on how many patients are in the hospital, but it's always meant to aim for full staffing.
So, but you're making every effort to have the maximum, so when we go on vacation.
Right, we would much rather have our own staff who are committed to our mission and have registry again be used the way it was meant to be used, which is for unexpected absences like parental leave, disability, sickness.
Thank you. What is H&H doing to address any gaps in care caused by these contracts?
ED docs?
Okay, I repeat it for you.
Yeah.
What is H&H doing to address any gaps in care caused by these contracts?
Yes, so the gaps we again fill by using a variety. We have a sort of set for every kind of position. First thing is, ask people if they're willing to stay longer. Then, go to a per diem list. Then if the per diem list fails, go to the registry. And in the case of doctors, there are specific, agencies that are able to fill in for doctors. We're also experimenting with some success in some areas with virtual care in the hospital for specialty, because what we've learned is there are doctors who will work at our salaries if they're not paying New York City rents. So they'll live outside of New York City, and they're willing to work virtually for our salaries, but they're not willing to move to New York. And that for some things we can, like we have a very successful pilot now going with child psychiatrists, where no physical examination is necessary. The child is in a room with the nurse, and then the child psychiatrist comes in via the computer. They can do the full assessment, they can make decisions, and we can recruit them because we're paying a New York City virtual salary, which is less than a New York City in-person salary, but it's still, if you're not living in New York City, it's a very attractive wage.
Okay. Since you lead me to something, I have to ask that. What criteria are you based on, like especially if the person is not in New York? We know we're a little different. New Yorkers, we kind of like dealing with a lot.
Sure, well, I'm glad you asked that. So our number one recruitment is we go to the people who trained with us and then moved outside of New York City. So they're often, and again, demographically, you would understand this, they came to New York and then they had 1, 2, 3 children and decided that it was too expensive to live in New York City. They moved outside of New York City, but they trained with us. We know them, they know us, they know our patients. They're happy to work for New Yorkers.
Yeah.
They see themselves as New Yorkers. They're just not willing to pay the rents.
Because I have one outside too. So we know New Yorkers, we're different, right? Are we different? We are
different.
we saw that on March 2024, HNH launched the Nurses for NYC recruitment campaign. Can you elaborate on the programs and the fellowship that have launched under this campaign, and what hospital are being targeted?
Yes, so first, and I know you know her, I give tremendous credit to Natalia Sineas, who was born at Kings County. She's our chief nurse. During the NISNA negotiations, the nurses gave her a standing ovation. And what it's specifically about and what she has been so good at is saying, if we want to keep our nurses, we have to promote education and advancement, that is the number one way. And she's really, I think, it's had so many positive ripples in terms of professional development and in all sorts of ways, not just keeping people, but for example, we don't want nurses to say, yes, doctor. We want nurses to question doctors. We want nurses to feel empowered to say, well, that's not how I read it, or I'm going to my nurse leader. And so the things that she's done to sort of say, we want nurses to be better trained. So we have a nurse residency program. So as a physician, I had to do a residency, but many nurses do not do a nurse residency. And the nurse residency allows people to get additional skills around leadership, around specific clinical issues. We have a critical care fellowship. We have an emergency department fellowship. We, under Nurse Corps, pay for 60% of unpaid nursing education debt over 2 years. We have the National Health Services for Nurse Practitioners, which gives repayment. We have a public service loan forgiveness. And so all of these things together, I think, are going to enable us to not just keep the nurses, but have an empowered group of nurses. That's what we really want.
Okay, so those are programs that the fellowship that's launched as of May 2024, right?
Correct.
Okay. What are the expected timelines of programs and fellowship that have not launched as May of 2024? How many nurses have been hired as May 2024?
So we're at 1,000. So far, we've launched.
1,015.
Yeah, we've launched all of those are launched now, and we've hired over 1,000 nurses.
Okay.
So far, many of them are still in training, but that's what we want. But we're looking forward to them joining us as permanent nurses.
So those are the ones for 2024, as May of 2024.
Correct.
And you have 1,000 and then 1,500, you said somewhere?
Is the goal. 1,500 was our peak registry, and the goal is to get to 0 registry.
Yeah, I was trying to get my numbers right, because I heard it when you
got
answered
it right.
Justin. How is HNH conducting outreach for those programs? What are the engagement numbers for digital outreach as May of 2024?
Yeah, we're still underway, so I'll have to get you the May numbers. Right, we're still in May, so I don't yet have them, but we'll provide them.
So what are the goals for this campaign, and how will they be measured?
We'll measure it based on, once people leave training, how many registry nurses we still have. We have set the specific goal of registry nurses only for absences, not as
Only for work absences. I love
Right.
that one. Okay, got it. Substance use. You know we have a lot of that lately. In March, Mayor Adams, I think Justin started writing that question. Okay, in March, Mayor Adams and the system, that was close question, but not the same, announced plans to open an $8 million health and substance use disorder clinic at Lincoln Hospital for pregnant and postpartum women and their families. What is the current status of the clinic? When is the clinic expected to be open?
We're currently, now that it's funded, we're doing the renovations, and fall of 2026. We can't wait till you're there to cut the ribbon with us.
You know, for good things, I'm always present. Are any opioid settlement funds being used to fund this clinic? If yes, what's the percentage of the clinic costs are funded through opioid settlement funds?
So the opiate will fill out whatever we don't get through regular billing. So we'll bill it as a Medicaid service to the state, but whatever the hole is will be filled by the opioid settlement. Because it's not yet running, and also it's not due to start till 2026, the actual dollars needed will depend on what the rates are at that time under Medicaid. So I can't yet say exactly what the percentage is, because I'll need to wait and see what the Medicaid rates are in 2026. But the opioid dollars will fill whatever the hole is.
We are hoping that our Medicaid reimbursement increase to more than 20% because we cannot keep New York City hospitals open.
That's right.
And I hope the governor did the right thing by us. What services will be offered by the clinic? How many patients are expected to be served annually?
So it is, the whole idea is that it will be a one-stop shop for the whole family. So the parents, the children, with a focus on women's health and children's health and addiction medicine. And since it's going to be right across the street from Lincoln, we'll be able to make sure that all of the women and families that are served by Lincoln are seen there who need it. We're aiming at 200 families annually.
What community-based organization will the clinic partner with?
So we know that it's going to be a series of community-based organizations, but that will have to come out of an RFP. So
RFP, you want to
yeah,
put it?
we'll bid it.
But they will be going to CBS?
Correct.
Okay. How will the clinic conduct outreach in the community?
Well, I think that the CBOs will be key to making sure that it's culturally appropriate and that people know it, and we will do a variety of paper and digital formats, but also Lincoln, as you know, is a huge hospital with a huge volume of people going in and out, and the fact that we'll be able to directly refer will make a big difference.
Okay. Be Heard. Can you speak on H&H's role on the Be Heard program and how the system collaborate with other agencies? What are the specific ways that Be Heard works with different city agencies?
So our major role on Be Heard is the hiring and training of the social workers. That's our specialty. We love working with the EMS system. We hope that it will be broadened in the future and with the fire department, and we will hire and train as many social workers as the city decides it makes sense to fund through the fire department.
So how do you collect feedback regarding Be Heard?
Yes, so we do surveys of the individuals served by Be Heard, and we also talk a lot to the community providers who are responding to calls. We've heard that at the most recent survey, 95% of patients felt that the Be Heard team helped them. 97% of patients surveyed felt that they were treated with courtesy and respect. Of the patients surveyed who had previously received an EMS response, 94% said that the Be Heard response was more appropriate to their needs. So I think that fits what the City Council has been saying for a long time, which is that it would be better to respond to these mental health emergencies with a mental health professional.
So I'm assuming there's room for improvement.
There's always room for
Always. But in medical, we don't say always. So, but this time, for this one, we do. We do need improvement, always on that one. Can you provide a breakdown of the number of people served by borough, by Be Heard?
Yes. So the borough breakdown I'll have to send to you, but let me give you the overall, which is 1,933 calls in 2023. Be Heard responded to over 7,000 calls more recently. So we'll have to do it by borough, though. I don't have that data here.
You don't have it?
No.
Will you share it?
2022, 2022 is 1933. 23 is 7,187. But what I don't have here
by borough?
By borough. But we'll get you the by borough.
Okay.
But I love the growth, right? From 1933 to
so Be Heard is being heard now.
187. So that's more than 3 times the number of responses year to year.
Okay. I'm interested in the borough-wide because for some reason it's very quiet in Brooklyn so far. I don't know where I'm at. How would you measure the overall success of the Be Heard program?
Well, certainly the client data makes me feel very good about it. I mean, in a sense, you know, each person who is better served, I think, is how I would think about the success of the program. I hope that at some point we're able to offer the service throughout New York City.
I was saying each of the precincts deserve to have Be Heard collaboration. How does H&H plan to improve Be Heard services in fiscal 2025, since you have a plan?
Right. Well, I think, you know, continuing to recruit the best people. It's a special kind of work. It's not meant for everybody. And training them, making sure that they have the skills that they would need to do a great job. I think that's our role.
Okay. Now, I'm going to deviate a little bit to ask you about downstate. Can you tell me a little bit, are you making preparation just in case if downstate have to close? Are you putting any budget on the side for 2025 to deal with that if they have to close?
We have not. As you know, the governor's budget set up a commission to look at the future of downstate.
I'm hoping they stay open. Let's be clear.
Right.
Because I don't want Central Brooklyn to come at me. Yes, I want it to stay open, but just in case.
Yeah. So at the current time, we haven't. And I think it's important, right? If we're simultaneously saying, here's our preparation for it to close, that could be seen as making it easier to close.
We don't want it to be closed.
Right.
Absolutely not.
So that's why, you know, we don't have a plan for closing, for what to do if it closes.
But when the rumor is out, it's just like you have to think, what's the long term, what's the process, what can you offer? Are you collaborating? Let me go out of my realm now. Are you collaborating with the downstate to see, even though we city, but the downstate is the only place that have the renal transplant that we don't have, right?
Correct.
And then it's in this, and then talking about the staffing and all this, all the folks that working there, that's kind of like, I don't even want to imagine it. So that's why I wanted to stay open, let's be clear. But our job where I am now is not a nurse right now. So
Right.
we want to know what's the plan to make sure if something like that happens.
I mean, if they were to close, clearly Kings County would need to expand. I mean, I think it's pretty straightforward, and we are helped by the fact that the hospitals are across the street from one another. So I think it would be trying to figure out how the patients who currently go to downstate could get served at Kings. I think would be my number one focus.
Okay, but in the meanwhile, have you have any engagement with downstate leadership to see how we can keep it open?
Yes, yes. I mean, the collaboration between those two institutions is very close. In fact, Kings is the #1 site for the downstate medical students, not the university hospital, just because of size. Kings is so much bigger as an inpatient facility than University Hospital. So, there's a lot of crosstalk, and we want what's ever best for Brooklyn. We
I want the
have
best
more
too.
than enough patients. We're not trying to get anybody else's patients. We're trying to do the best possible job for the patients who come to us, and we're happy to support University Hospital staying open, and we would, if the hospital were to close, we would certainly work on expanding Kings to deal with the volume.
We want the state money, and we want the King's money to stay in central Brooklyn. Sickle cell disease. How much funding is budgeted in fiscal 2025 for sickle cell services? How much total funding for these services is in the budget for fiscals 2026, 2028?
Yeah, so, and this in some way pertains to Chair Brennan's question. I can answer how much do we spend. I can't answer how much do we budget, because I would spend whatever was necessary, right? We don't ever limit by...
Approximately.
So
what you think the course going to be? Because when somebody tell you, I can't do this, and there's no money to do it, then it's not going to be done.
Correct.
So
we spend $30 million, and the way we got that is we have in our computer system, we know diagnoses. We can take the people who have a diagnosis of sickle cell and calculate the dollars that are spent. But we will take care of everybody who has sickle cell who comes to us, and we will provide them all the evidence-based treatments for sickle cell. If it next year turned out to be $35 million, we wouldn't put people on a wait list. We wouldn't say, I'm sorry, we've allocated $30 million to this, you have to wait. Whatever people need, that's how we function.
Okay. Because with the influx of the migrant from West Africa and Haiti, that's raised a concern for me for the sickle cell disease even more.
Yes, no, that's an excellent point. I mean, so far, and it's been a happy thing about the asylum seekers, the #1 health need of the asylum seekers to us has been pregnancy.
That's not something to laugh, but it's something like, pregnancy, but it's just like, hey, it's a natural thing.
Yes,
we're concerned about the sickle cell disease, the high blood pressure.
Population there, right? To be able.
So birth control is in order, I'm assuming. Okay.
To be able to travel from Guatemala or Venezuela all the way on foot to the U.S.
Yes.
You have to be pretty healthy, right? So the people who are
I'm in
coming
agreement.
don't have a lot of chronic illnesses, but we're happy to care for them and their new babies.
Thank you. Thank you for caring. Local Law 163, that's what we're just talking about, requires the Department of Health and Mental Hygiene in consultation with H&H to create guidance to educate medical professionals and the public on detection of the sickle cell trait through pre- and post-conception genetic screening and on the management and treatment of sickle cell disease. Can you provide an update on H&H preparations for providing genetic screenings for individuals who are at risk for sickle cell disease? Besides the pregnancy, they're at risk of that too.
Yes, so first, within the last year, we've gone to a model where we offer genetic testing to every pregnant person. And this is, enables us to be able to counsel people about a variety of genetic issues. We also will offer genetic testing to the families when somebody has sickle cell, so they can learn, as you've talked very openly and bravely about what it means to be a sickle cell trait. That can be important in people's health in ways that are not always, were not previously appreciated, the vulnerability that can come with trait. And so we do genetic testing for all of the families. I don't know if in your hearing earlier, DOMH talked to some of their educational tools and health advisories for the whole community. I know less about that because that's their role. We're focusing on making sure that everybody at health and hospitals gets genetic treatment either at pregnancy or if there's a family history of sickle cell or risk of sickle cell.
Yeah, especially those that, since you say there a lot of pregnancy, so people need to know.
Correct.
Before they get pregnant, because when you have 2 sickle cell trait, each child born with 25% of being a sickle cell disease itself, and it's not going to be good for the city of New York. That's very costly. Okay, how is H&H working with the other agencies on the implementation of local law 163?
Well, again, DOHMH is the lead on this, and we're following their instructions, and we'll make sure that everything that we do is supportive of their overall plan.
Thank you. In the April hearing on school-based health centers and school-based mental health centers, we were told that sickle cell screening is not being done within the schools. What screenings are required for students? Are there any plans to increase screenings for students and young people for sickle cell disease?
I'd be happy to work with you and the DOHMH on all types of screenings. I know the mayor is justifiably very proud of adding screening for dyslexia as a universal standard. And I think that then raises the question of what are the other things that we could do to identify and help people with other needs. We again, while we don't run the schools, we always want to be great partners, and we're happy to work with you and with the school district on what they would like to do. Almost all of the schools have close relationships with a hospital and health and hospitals or a clinic, because we are the only hospital system that will provide outpatient care regardless of insurance status. You want to work with anyone else, then you have to say, okay, well, we can see your insured kids, but we can't see your uninsured kids. We're the only group.
Not in New York City, we cannot do that.
Right. We're the only group where we take care of everybody regardless of the insurance status in the outpatient area.
And not only that, the reason I told people that we have to take care of people is cost effective.
Yes.
Once a person is in New York City, if we don't address their problem in the prevention, we're going to end up paying more money at the end. So COVID did not know any color, any race, any, how your economic status was. It just entered. So as a city of New York, so thank you for doing the work you're doing. How will local law 163 be integrated into schools?
I think, we should have together a conversation with DOE and DOHMH about what makes sense for the school district. I don't want to dictate what the school district does. They know best sort of how to make it work in a school setting, which is their role.
Yeah, I have a lot more questions, but I want to pass. I don't know if my colleagues have questions, so I'm going to pass it on Chair Brennan.
Thank you, Chair. We're going to start with questions from Councilmember Brooks Powers, followed by Brewer.
Thank you so much, chairs, and it's always great to see you, Dr. Katz, and
Thank
the
you.
folks from Health and Hospitals. I have a couple of questions, but I'm going to end on the trauma hospital. I'm going to try to go through all of the questions so you can be able to respond. We have always known that there's a disparity between reimbursement rates for Medicaid compared to private insurance. What is the current rate of Medicaid reimbursement? When did it go into effect? And if it has increased, how has it affected the revenue for health and hospital, if at all? Also, we have the Gotham Center being built out in downtown Far Rockaway. Wanting to know the status of that, the timeline for its opening. And then I'd like to switch over to the trauma task force that both you and I chair on, and wanting to hear from you, what trauma models is Health and Hospitals aware of that could be considered viable for the Far Rockaway community? And since the closure of Peninsula Hospital in 2012, residents in Far Rockaway, Queens, have not had access to a neighborhood trauma center. In the fiscal 2025 preliminary budget response, we called on the administration to commit capital resources to build a level 1 or level 2 trauma center on the Rockaway Peninsula that provides trauma-focused care to community members. The fiscal 2025 executive budget includes no funding for this project. How does Health and Hospitals plan to work with the administration to increase access to care, specifically trauma care, because we know we have the Gotham Center, but that offers different type of service for the residents of the Far Rockaway community?
Sure. Well, let me start at the end, just because I was so proud to serve with you, and I thought it was such a positive experience. I learned a lot, and there was a clear consensus in the community on the need for a trauma hospital and the recent loss of a police officer who had to travel 40 minutes to Jamaica Hospital following a gunshot, I think showed what the issue was to a lot of people in very graphic detail. It's a long way in New York City traffic to have to travel that way. I think from a feasibility standpoint, it will always be easier, I think, to address the biggest problem first. And the biggest problem first in trauma is the stabilization of the person who's been shot, who's been stabbed, who is in the car accident. So what I'm thinking is, we want the highest level, and if we can get that center to deal with the highest level, but maybe in the beginning it will not necessarily have, say, rehab, which, say, a hospital like Bellevue, which is a trauma center, has rehab. Maybe we don't keep people long periods of time after we stabilize them, right? That for all of the reasons you well understand, right? The larger the service demand will be, the harder it will be to fund it. And often you don't have to do it all in one bite. And I think it's always, in my experience, easiest to talk about what is the immediate need, right? The immediate need is to stabilize critically ill people. That's really a 24 to 48 hour period, right? Where they have to be able to go immediately to the OR. They have to be the most advanced radiologic things. There are other things that are related to trauma care, like rehab, physical therapy, speech therapy, but I feel like those things we could work on a second tranche. So that's with you. I'd like us to, once the report is finished, to go up to the state and talk because ultimately any hospital has to be licensed at a state level. It's not a New York City function. Talk to them about sort of how we see the need, show them the demographics, which you've talked very persuasively around. It's not just the question of how many trauma calls there are today in the Rockaways. It's the question of, given the building that's going on in the Rockaways, right, what does the population look like in 3 years and 5 years, and how do we prepare for that? So I'm looking forward to that next stage. As you say, we're proud of the Gotham Clinic. It doesn't replace a trauma hospital. No one wants to, have a gunshot person arrive at their clinic. But there is an important need for primary care, good hypertension treatment, good diabetes treatment, good immunizations, good child care, well child care. We're looking forward to the center. I know you've seen the pictures. It's going to be beautiful. It's in a great area. John, do you remember the open date? Do we have the open date?
Yes, we'll begin construction in FY 2025, and we anticipate an opening date in the first quarter of 2026.
On the state budget, while there was a Medicaid increase, there were also withdrawals of other monies. So, as John had said at the beginning, I think if you took the whole budget as a whole, it's sort of neutral. We gained, we lost. To your other question, which I think underlies a lot of the disparities in New York City, on a hospital rate, a private insurer probably pays, depending on what the private insurer, about 2.5 times what Medicaid pays. And so that's why those hospitals, whether in Brooklyn or Queens especially, that have very large Medicaid populations are struggling. In the inpatient setting, there is emergency Medicaid, so there are no true uninsured people the way there is in the outpatient area. But if you're getting, a third of the expense, it doesn't necessarily cover the cost, and that's why so many Queens and Brooklyn hospitals struggle with maintaining it. So I think I backwards hit your question.
Yes, you got them all. Thank you so much, Dr. Katz, and to the rest of the team here.
Thank you.
Thank you, chairs.
Okay, now we have questions from Council Member Brewer, followed by Lewis.
Thank you very much, Dr. Katz, and we also thank, he's not here, but Dr. Long, we have great respect for. The question is about this DocGo, which I know you're sick of, but I'm not. So the issue is, we think they have 4 contracts with health and hospitals, and we understand that there's at least $259 million to fund the migrant-related work. I assume that's the one that you talked about earlier on medical, but you also have the ambulance, which is a DocGo subsidiary. Can you be really clear that you really only have 2, because every newspaper says 4?
Okay, so as so often you've taught me things, I was answering the question in terms of the HERCs. I was not answering in terms of the ambulance.
Okay, or anything else, go ahead.
I know the ambulance contract. Is there anything else?
That's ambulance.
Ambulance is definitely DocGo.
Yeah. That's the only thing comes up, but we can
We'll
provide
go
a
back.
list. Yeah,
We'll go
provide
back.
a list
The
and
list and just the general discussion has gotten me interested in seeing what the expiration date is on the medical contract.
Correct,
which I
and how
don't
much
know.
also, specifically? Those were the 2 questions. All right, I think there's still 1 contract missing according to the Daily News, just FYI.
Okay.
Okay, all right, the other questions. The timeline for health and hospitals to transition its migrant shelter residents to the Department of Homeless Services. Is there such a timeline? Is it being discussed? What's going on?
So it's definitely being discussed, and again, I'm always happy to hear how you all think of it. I think the history is instructive. This is not our usual mission.
Correct.
We got involved in this because the agencies that do this got overwhelmed through no fault of their own, right? The Office of Immigrant Affairs and DHS. And they were getting more people than they could take care of, and we said, hey, we've done this before under COVID, let us help you out. Okay, so now we are in a different setting. I would ideally like to transition all of the centers with the possible exception, but this is a city decision, of the intake. I think we do a very good job with the intake.
Yeah. That would be at Roosevelt or wherever.
Yes. I know you've been there.
Every minute.
Seen it.
I very intimately.
Right.
Yeah.
I think we do a good job.
Okay.
If you or someone else said, I think somebody else would do a better job, I'd be okay.
All right, but so how about, but you still have all the HERCs elsewhere.
Right. So our goal is to transition the other ones, and in an ideal world, we would do the intake and we would do the case management.
The case management in the hotels as
Yes.
well. Okay, that's quite a bit. Okay.
But not we wouldn't be a shelter provider.
Right.
We wouldn't be a food provider.
Okay.
That those, and even on the case management, I'd say the same thing. If someone else could do it better, by all means,
Okay.
we have no.
I have a few more questions. The issue of PeopleSoft, in other words, obviously I had oversight and investigation, the committee. Because you're using PeopleSoft, they cannot produce invoices. So we've had to go to the vendors. Guess what? Everybody gave us what we needed except for DocGo, just FYI. But we want, in other words, for the food and for the case management and for the everything that, security and so on, PeopleSoft cannot produce invoices. Do you know about that? And how can we make that, because they say that's just not possible under the current software?
PeopleSoft is our personnel system.
No, but it also, we use it for,
I'm up to
Okay,
here
so
with
can
the
you explain it?
invoices.
Yeah, yeah, I'm not familiar that we can't.
Cannot.
Yeah, and I know we can produce invoices.
Okay,
and-
but-
and we have, produced invoices, and we're very transparent, because that's the
Okay,
way. by which-
there's a problem with PeopleSoft and invoices, believe me. So maybe we could talk about it offline
no,
and
that-
try to get it straightened out.
Certainly.
Okay. The other issue is just in terms of school-based. You've heard, I'm confused, having been involved with school-based for, I don't know, many, many decades. There are a lot of them that are, there are 103 of them that are underfunded. Obviously, we have the 16 new ones. Anybody who's in that world would love to see more because they're so effective. There's no question that school-based healthcare is phenomenal for mental health, for physical health, and everything else. So, is it Health and Hospitals that's in charge? Is it the combination with DOE and the Department of Health? I know Dr. Platt used to have two. He was very proud of his opportunity to work in both agencies. But how does one determine whether it's a nurse, whether it's school-based, et cetera? Because I don't think it's getting its full due or full funding.
It's confusing.
Very.
It's confusing for a few reasons. I mean, one thing, and I was very proud of this that we did during COVID, and I would stand by it, is that every school should have a nurse.
Okay.
That is not a school-based health system.
No, I understand that.
But at one time, every school did not have a nurse.
Yes.
And
But now you're saying every school does have a nurse.
Yes.
Okay.
I mean, that is, I think that should always be the baseline, because at least if you have a nurse, then you have the ability to refer people.
No, I understand that. But, a lot of people don't go for the referral. They just don't go.
Right. But if you don't have the nurse, then you have nothing.
I got it.
You have no shot at it. So then I think what part two is, again, if you want to sort of build basic blocks. So I agree with you that school health centers are good, but I think the biggest need is the mental health part.
Okay.
I think that is the part that's, in general, children are healthy.
Right.
Right.
Okay.
And if they're not healthy, they're so sick that they're generally not going to most need a school health center.
Okay. Well, then-
So I'm of the feeling that at this moment, the right next thing, we achieved nurse for everything, next should be mental health. I think the fully interdisciplinary school health center has worked super well in some places and not so well in others, and I based it on volume. If nobody comes, then there's something wrong. I don't know what's wrong, but there's something wrong if no
Okay,
one comes.
I think it's an ongoing discussion. And then just finally, I know that you're discussing with the residents, what would be the amount of pay increase that would be involved if you're able to settle that contract?
Well, the negotiations are going on now. I think the basic challenge with the intern and resident contract is that residency salaries have gone up significantly at other hospitals throughout
Correct.
New York City.
Yep.
And so while we were once at parity with other hospitals, we are not now.
Correct.
As you well understand also, the city engages in pattern bargaining,
Yes.
in part because city unions cannot strike, different system. Pattern bargaining does not work so well in the marketplace if suddenly one part of the sector pushes up salaries. And I think that's essentially the problem the city is facing. And we're working very hard with OLR and with CIR to try to find a solution that works for the city and for CIR. We cannot function without the interns and residents.
Right, the 2,300 are looking forward to a settlement. Thank you very much.
Councilmember Ressler.
Thank you so much to Chairs Brandon and Narcisse. Greatly appreciate the opportunity to be with you all today. Good to see you, as always, Dr. Katz. You know, when you arrived at Health and Hospitals, there was a kind of constant drumbeat that the city's budget was going to be destroyed by Health and Hospitals. And not too many years later, nobody's talking about any economic or budgetary issues, fiscal issues at H&H. In fact, this mayor is throwing every problem he can, as did the previous mayor, your way that isn't even necessarily germane to H&H's mission, because you've done such an able job. We're fortunate to have you and your team serving the city. And also just want to say we're joined by many distinguished advocates, especially labor leaders, and I really want to thank the leadership that we have from our public sector healthcare unions that do so much to advocate, that do so much to provide high-quality healthcare for New Yorkers. I'm proud to be a Metro Plus member. It's where I get my healthcare, encourage more of my colleagues and my constituents to do the same. It's New York City's public option. I'd like to ask my questions, though, to Dr. Yang this morning, so nice to see you, Patsy. I was really pleased that the administration did the right thing and finally is moving forward on the outposted therapeutic units, not just at Bellevue, but at Woodhull and North Central Bronx. Just a couple questions for you. One, are there considerations for additional outposted therapeutic unit sites at this time? And secondly, the issue that I'm most concerned about as it relates to the jail facilities that are the borough-based jail facilities is that the administration cut in half the number of therapeutic beds that are planned for the Brooklyn Detention Center, for the Brooklyn Borough-based jail. It was originally 44, 45%. Now I believe we're at about 22% of beds that are therapeutic beds. I think that 55% of people in Rikers custody, in DOC custody right now, have a Brad H designation, have mental health needs. That's a big number. To go from 55% of total people having a mental health designation to only 22% of the beds actually being designed to meet their needs is a recipe for disaster. What are the plans to expand the number of therapeutic beds in our borough-based jails? Can we safely do therapeutic beds on the two-tiered systems, two-tiered designed housing units? And could you speak to that a little bit more? I know that I appreciate the work and the leadership you provided here and would greatly appreciate any guidance you can offer for how we can expand therapeutic bed capacity within the borough-based jail system.
Yeah, thank you for your support also, very much so on the therapeutic units. For the outposted, the number of sites and beds that are currently projected are fine. They are sufficient. We don't expect that currently for the population or for the projected population that will need more. These are very specific beds that are located in community hospital buildings where those specialty services are needed. That is very different from what could happen in the therapeutic units that were in beds in the borough-based jails, which are in a jail facilities. We are talking about the design, the physical plant design and construction. I think that we are very much involved in part of that design question of how to build and design jails that can fit the projected census. We're aware of what the census is now and what the jails initially were designed to hold. The changes that have been determined so far really present more of an operational challenge to accommodate or compensate for the change in physical plant design. So, for example, a two-tiered system, a two-tiered unit presents more of an operational challenge for DOC.
Can I just pin you down on that? So in the two-tiered housing units, if we have the right clinical staffing model and the right operational solutions, do you think that we can properly convert those housing units into therapeutic beds?
Our Correctional Health Services will provide what it needs to provide in the setting that it does. It does that now in the facilities that are on Rikers. We will do that certainly in the new jails. The question about the two-tier system is more one of security and safety for mostly our patients. And we are in conversation with the department. They are fully aware of what those additional
measures would require.
Do you believe it's possible?
I'm sure it is.
Okay, I hope we can get there, and any advocacy that we can provide from the council for additional staffing and resources so that we can provide that extra care to the patients, to the detainees who need it, we want to make sure that happens. I'm just, the Brooklyn Boroughs-based jail is in my district, and I'm deeply concerned, as are my constituents, that we've got 55% of people in Rikers today that have a mental health designation, a Brad H designation, but we're designing a jail where 22% of the beds actually are going to meet their needs. That's a disconnect that is so vast that it's hard for me to persuade my constituents that we're actually going to do better. And I hope that we can come up with an operational solution together that will inspire the confidence that my community deserves, that the people who are detained deserve, that everybody who's worked so hard to close Rikers deserves. It's really important. So thank you for your work. I look forward to continuing the conversation.
Thank you, Councilmember Russell. Now we have some more questions from Chair Narcisse.
Me back again. Earlier, we were asking, I think Chair Lee was asking the question about the $5 million as an exclusion of the funding that we have for mental health, right? So now, knowing that we don't have that kind of money, were you using it? And if yes, which I think you were, so what's the plan to expand without that extra $5 million?
Do you know the $5 million? We're not sure which $5 million.
The mental health continuum?
So
this, yeah.
Yeah, no. Yes. Yeah, maybe there's two $5 millions. There's $5 million of which DOE, DOHMH, and
the $5 million that we were pushing, the council were pushing.
Yes.
So now it's not part of it. So what is the plan? Because I understand some of the school gonna have this. We have 16 mental health in the school, but we're talking about in general that $5 million, maybe not much, but what is the plan if you were using that budget?
Yeah, we don't have a plan for that $5 million, but certainly if additional resources are made available to us, we will expand that clinic.
Right, we understand it's a joint initiative between the council and the administration. We're happy to be partners in that and provide the services the city decides.
But it's not allocated for right now, it's excluded.
Correct. It's not currently allocated.
No.
Right.
So you don't see a problem for not having that?
Well, I mean, obviously, we want to provide as much services as we can. We are a well-funded relative because New Yorkers are so generous compared to most other cities. There's certainly more we'd like to do if the city, the mayor and the city council decide to do so.
So the school not going to be affected for that $5 million not being? Okay.
No, I mean, if it doesn't happen, we will still be okay, but we would welcome it if it were to happen.
Yeah, I have a question earlier that I think you start answering on the asylum seekers. Before I go any further, I want to remember of that one. Oh, tuberculosis. What are the numbers that we're seeing? You were talking about a little bit of the testing.
Right.
When you were
well, people who come from Central America, South America, Africa, all have much higher rates of tuberculosis exposures.
Is that exposure, not active? Have we have any active?
Both. So then I was going to say as well as active. And so we have diagnosed a large number of people with active TB, and we treat them at Bellevue or one of the other hospitals. And then an even larger number of people with exposure where we want to give them prophylactic treatment so that they never develop tuberculosis. I don't have an exact number. I mean, it's a daily number.
So as they arrive, I mean, anyone arrive, the asylum seekers, all those tests are being done. That's
Correct.
my job as a nurse, I have to make
Right.
sure that is.
Correct. So that's why even if we're no longer doing shelter, I think we should continue to do the intake center at Roosevelt Hotel, because then we can make sure that everybody gets a TB test and an X-ray and appropriate treatment if they do have tuberculosis.
Okay.
It also makes sure that we don't put people who are at risk in a congregate shelter before we've done the testing, right? So that's another way you could go wrong, is that you could take in an asylum seeker, put them in congregate shelter before you had the results of the TB test. And then you could expose a large number of people. So we're very careful about checking and not putting people in congregate shelter until we're sure that they don't have tuberculosis.
Back in my time, before you even put anyone that just come in, there's some questions that you have to make sure doing. Now I'm gonna go out of my realm on that. Being the fact that when the person comes, some of them don't speak. We don't have people that speak their languages. So how do we, first of all, do you have people that speak those folks' languages to make sure we can ask them the question? Because based on my question as a nurse, I can tell you if you are being exposed or you have active
Sure.
TB without doing any tests.
Yeah, well, I think both are true. What the questions are very good at is figuring out if somebody's contagious.
Yeah.
If they're not coughing, they're not
That's what I'm saying.
contagious. But they could still have TB of either kind, so we still need to do it. We have done very well in terms of translation for South America, where we were having trouble, but I got an update just 2 days ago, we're much better, is some of the African languages, especially Wolof, where there just were not enough interpreters. And Wolof, as you know, is also a language where, depending on where you live, Wolof at one portion of the country may not be understandable to Wolof at another portion. It's a heavily dialect language. So we were having trouble getting enough Wolof translators.
Now we do have.
But now we do. I just got an update, and we now, right, but for a while that was an issue. And again, not an issue of money, just an issue of identifying people who could interpret correctly the different dialects of Wolof. So, we do phone, video interpreter at the Roosevelt. So right now we're doing okay on asking those questions, but we still think that the chest X-ray and either the blood test are important to get done.
Okay. So before we put anyone in congregated area or to any shelter, those tests are being done.
Correct.
That's right. And no one is on our street with the possibility of having TB.
Correct. And that's why I want us to continue to run the intake shelter, because I see the intake as a very medical thing, while I see the ongoing shelter as not necessarily medical.
So do you have nurses in those? Okay. I'm sorry, I would feel confident because once you told me there's nurses there that's trained, that knows how to ask the question and to identify, because I can identify back in the days from somebody sitting there looking at the person, even they don't tell me anything, just based on assessment.
Yes, absolutely.
Yeah. So thank you for that. We have received data regarding quality assurance from H&H facilities. We stated that there were 3,544 complaints and grievances received system-wide in 2023. Can you outline the complaint and grievance process within the H&H system? What happens when a complaint or grievance is filed? How many complaints and grievances were received in 2022? What are the recent trends in complaint and grievances filed?
So first thing, which I think is the most important, is we want people to complain. We do, because that's the only way you can make things better. So we encourage complaints, and we see that if the complaint number is growing, we think that's a good thing, because we think it enables people to speak up. And as a nurse, and if you talk to family members, people always have complaints about being in the hospital. Number one complaint, food, right? 2, privacy. We want people to complain, and we do our best to do service recoveries. The number of complaints, 3,544.
So they're mostly not related to health, because when the hospital, Food is to some extent, we will say it is, it's not. But it has to taste a little, because most food that's good for you doesn't taste good. We all know that. But the cultural competency around the food, because we don't want too many people, if you're in a hospital, especially for a long time, we need you to eat.
Sure, absolutely.
Okay, and because we know we had issue with religion. Some folks complain about they're not having their religious, according to their religion.
We do our best. We certainly provide halal meals, kosher meals,
Okay.
vegetarian meals.
How do these numbers compare across facilities? Which facilities have the highest number of complaints and grievances?
Well, in general, the most complaints are the biggest facilities. It's really a volume issue. The more people you have, the more complaints.
Yeah.
Right. It's not, there's no systematic difference. But, again, our biggest hospital, Bellevue, has more complaints than our smallest hospital, Woodhall. It's just a function of volume.
Thank you. You're so practical. Even I want to beat you up sometimes. Thank you. And that's the truth, because I've been there. I know sometimes people complaining about, my bed was not fixed at the time it usually fixed. So, but as long as it's not health related, then it's not okay, but we still need to improve, because I love criticism, because critics make us do better. H&H received 271 malpractice claims in 2023. What is the process for when H&H receive a malpractice claim? How many malpractice claims were received in 2022? Can you provide the number of malpractice claims by H&H facilities?
So total malpractice claims, 271.
What is it?
Settlement and payouts, which is probably the best way to measure at least the significance of the malpractice, because malpractice is very different, obviously, than complaints.
Yeah, that's what I want to know the number.
Absolutely, malpractice is real.
Yeah.
So in fiscal year 15, 135 million, now down to 67 million in fiscal year 23, which we think is
67.
67 million.
Okay.
We think that it's due to all of the ways that we in the last few years have improved the quality of care. And I think anyone who's been to our facilities recently talks about that. I ran into someone in the city family who said, I never would have gone to one of my Bronx public hospitals, but I went there and I was amazed at how good the quality of care was. So I think we've done a lot to really improve it.
Okay. I wanted to go a little deeper, but I'm going to skip on that, because I want to know by the malpractice, what are they? If by any chance you have the data, can you share that?
Yeah, I don't have here by hospital, but
By hospital and then
we
you don't have them.
Provide it.
Okay, so you'll share it later?
Yes.
Okay. Committee on Interns and Residents, CRR, SEIU Healthcare. On May 1st, CIR filed over 20 out of the title work grievances across 7 of H&H hospitals. In the grievances, the residents reported over the previous month of having to routinely undertake the duties of social workers, nurses, transporters, phlebotomists, and clerical staff. Why are residents being relied on to perform non-physician duties? 2, residents have told us that having to take on non-physician duties to ensure their patients receive the quality of care they deserve is a big driver of burnout. Are you concerned about your residents' burnout and overall morale?
Yes, I mean, of course, I was a resident once too, and so I remember challenging. It's a very hard time of life. Residents are both employees and students in a very complicated way. They are expected to work very long hours, and it's very stressful work, and it's a time in your life when you don't feel very secure necessarily about all of your work because you're also still a student, right? It's this constant, growing, and also the stakes are great, right? So you worry tremendously if you're going to make mistakes. No question that even when we successfully staff, you get call-outs, someone's sick, and good doctors and good nurses fill in. And I wish they didn't, but I would rather they fill in than not fill in. I'd rather they fill in and then, put in a grievance, because what I don't want is for the patient to be hurt. So let's say, for example, you're in the emergency department. Say you were me, and you were in the emergency department at Bellevue, because that's where you get your care when I was ill. And the residents took me to radiology, because at that moment there was no radiology tech. I'm glad that they took me to radiology, and I'm glad they take everybody to radiology when there's no clerk, transport person. I want there to be a transport person, but if there's no transport person, I want them to take the patient to radiology. I don't want them to say, I'm sorry, sir, there's no transport person here. You'll have to wait until the transport person arrives, right? So good doctors, good nurses put patients first. And when you put patients first, you sometimes do things that are out of your job. And I think they should file grievances when that's the case. I think we should look at them. And again, sometimes you're fully staffed on paper, but you're not fully staffed in reality. And you understand that. And life happens, right? Someone was fully planning to come to work and got sick, or their child got sick. And it was too tight for us to get somebody else in for that shift. We'll always try, but sometimes we don't succeed. So, a lot of what I try to do when I mentor residents is to recognize the stress, because I think part of it is the old medical culture, suck it up. I apologize if that's too vernacular, but I think that's the attitude. Stop complaining. Do your job. Just do it. We did it before you, right? That's all bad. And what instead you want to do is acknowledge the problem, help people to understand why there's a problem, right? As in, I'm sorry, we were fully staffed tonight, but so-and-so called out sick. Could you take the patient to radiology?
To me, being in that experience, being in the space, back in the days, I used to do like 40 patients for medication and go back and forth and don't even have time to eat. But back then, it was a different time. We're in a time where people burn out easily because of what we never been through before. And I seen older doctor from my family, hearing them, I said, no, it's not the same time, because our mental status is not the same. So I want to know how often that a doctor have to stop what they have to do to take a patient to radiology or to take them to get a test, any test done.
Yeah.
Is that how often?
Yeah.
If it's happened quite often, that's when we look into, because I know once in a while, because if I want to get something done, I do it myself. I will run the patient all over the place to try to get things done.
Right.
But nowadays, the mental things, we cannot take it at the same time from the old time to now. Now is a different line of approach of things that are going on around us.
Yeah.
So I'm hoping and I'm praying that you go look into it and making sure that their grievances are, because we don't want to run our doctors, the resident, out of our facilities.
Understood. Understood. Thank you.
Thank you. H&H and the city have been in contract negotiations with CRR for over 9 months. The latest salary offer would still have H&H resident salaries as the lowest in the city. How does H&H plan to provide fair wages and work assignment that are outside of traditional resident work assignment?
Yeah, well, as we talked about before, you understand that the city settles contracts through the Office of Labor Relations with OMB on a city pattern bargaining. And that's the usual pathway. We do not hold Health and Hospitals do not hold the negotiating certificate for CIR, which is just a way of saying that it is, like many things in the city, it's not a simple process. But you remember, and you were incredibly helpful around the nurses.
And I'm trying to do the same. Don't get me wrong.
Some tough
I'm working it for the
moments there
residents.
too.
Mhm.
But we got over the finish line, and I believe we're going to get over the finish line with the residents too. But it is not straightforward.
I know, but they are as important as the nurses to me. So I want the hospital, because when we talking about preventive care, we want our residents to stay in New York and H&H. Why is this contract not, but I'm not gonna even ask you that because you already, how does the city plan to address any stay long-term in community? I know you want them to stay long-term, right? The residents that here with us. Okay. It's now May, and what do you think, where do you think we're going? Are we gonna get there anytime soon?
I think so. I think it's going to get resolved in the month of May.
But they are completing, because as of June 31st, about a third of the current resident will complete their residency requirements and will begin their career as attending. Most of them have never had a pay raise the entire time they have served the city of New York. And I know as a doctor, that's bad.
Right.
It's bad for us. Will the city put forward a proposal that is fair and respect the value these doctors bring to our hospitals in enough time for these doctors to receive the increases and the back pay, the more deserved than ever. They work for it. They deserve it. So I know you're doing your part because we spoke about it. Keep on pushing, please.
I'll keep pushing, and I appreciate your pushing and other members of the City Council pushing.
Thank you. Now I pass it on to my colleague, Chair Brennan.
Here we have last questions from Councilmember Sanchez.
Thank you so much, chairs, and good afternoon, President Katz and team. It's really good to see you. I came up because I want to ask a question that I asked of your colleagues earlier at DOHMH, but specifically would love to hear the answer as it applies to the Health and Hospitals Corporation. Across the globe, midwives provide the bulk of prenatal, delivery, and postnatal care and have dramatically better outcomes than we do here in the U.S. In March of 2022, the mayor announced the Midwifery Initiative, which was supposed to expand to all 38 public and private birthing facilities citywide, and would create partnerships with midwife organizations, private practices, community members, and the city would begin to report on midwifery care. So specifically within H&H facilities, can you share progress on expanding midwifery access, particularly to women of color and birthing persons of color?
Sure, I'm happy to. So I agree with your perspective. We want to have robust midwifery practices at all of our hospitals. Woodhall has led the way within our system. Jacoby has also had a strong, with NCB, a strong midwifery program traditionally. Bellevue has a good midwifery program. We have a new midwifery program at Harlem, and we have a midwifery lead and 3 midwives, which are brand new to Harlem Hospital, which previously had only an OB service. We are recruiting for midwives now at Kings County and at South Brooklyn Health. So those are 2 sites that haven't had midwifery programs that will soon have midwifery programs. I didn't mention, Met also has a successful midwifery program in existence. So we have some that have been success. Elmhurst has a successful one. Queens does not do, does Queens do deliveries? Queens does not do deliveries. One important fact that I learned recently, and it's been very relevant to us, is that if you want a midwifery service, you have to have at least 5 midwives. So I didn't fully appreciate it, but once you start thinking about it, it's true. If a woman comes and she says, I want a midwife to deliver, you got to cover all 7 days, 24 hours, because you don't know when she's going to go into labor.
Right.
So it's not like so this is why it's not a simple thing to just hire one midwife and you're set. At the moment, it's not a money issue. It's a training, and we want to, in particular, we're talking to CUNY about creating a midwife training program, probably in partnership with Downstate and Kings County, because there right now just are not enough midwives to recruit.
Yeah.
And when you realize that you got to have 5 at a minimum, if you're going to guarantee that woman that when she actually is ready to deliver, there's a midwife, we have to grow quite a lot at several of our facilities.
Thank you, chairs. And if I may, I know you've been here a very long time, but just to wrap that into a single figure, would you be able to tell me of all the birthing centers that H&H has, all the birthing facilities, how many have access to midwives in that way, 5
Sure.
or
So
more?
right at the moment, there are enough midwives to guarantee a woman a midwife delivery at Bellevue, Elmhurst, Jacoby, Woodhull, and Met.
And not
So
North Central Bronx?
5. Oh, I'm sorry, I think of NCB and Jacoby are under one license now.
gotcha.
So, yes. But at the moment, we are recruiting, but do not have the critical 5 at Harlem, South Brooklyn, Kings, what did I miss? And Elmhurst, we have it, if I didn't say that. And Queens, I believe, does not have
You're gonna sleep here? Where's
the
the bed?
pregnancy service.
Thank you. And Metro Plus insurance coverage, does that, I don't know how to ask this in a way that I'm going to get the most useful answer to what I'm looking for, but are you covering midwives to the same extent as OBGYNs? I've heard a lot of complaints from midwives and midwifery groups about not working with the city and not working even with private practices because the reimbursement rates are so bad.
I wonder if they must mean outpatient visits? I think we'd have to get back to you. Certainly in our system, it doesn't matter, right? Everybody in our system is salaried. So your salary, you're a midwife, you're a city midwife salary, that's your salary.
Okay. No contracted services? Every employee is a direct, or every worker is a direct employee?
Is a direct or an affiliate. We don't have any contract.
Okay.
So I know less about what it would be like in the contractual setting.
Okay, thank you. I mentioned earlier, after my first pregnancy experience, if I can and if it's healthy to do so, definitely want to deliver with a midwife. So I'm fighting for all New Yorkers to be able to have that same access. Thank you.
Wonderful. Thank you,
President.
for fighting
Thank you, chairs.
in that way.
Thank you, Councilmember Sanchez. I'm going to ask a quick question just about the street health and outreach and wellness vans, the show vans. Are those all being discontinued because of the PEG?
No, none are being truly discontinued. 2 of them are transitioning to DHS. So 2 of them focused on...
Which ones?
The 2 that focused on subway homeless. So when the city initiative to try to provide services to homeless people living in the subway, the fastest way was we said, okay, health and hospitals will create a show van, and the show van will be your home base. So now, because DHS has much more experience, they're just going to take over that function because they're doing the rest of the function. So it was a case where they're the major provider and we were sort of a sub. And so instead it's more direct, the money is going to them. So it's out of our budget and into their budget.
Okay, because I'm being told that due to PEG reductions, that's why those 2 vans are being,
Not
you're saying.
what I was told.
No, I think they're just being transferred over. We still have 6 of our own, 2 being transferred over.
Okay, could you get me a list of which ones are, so you're saying 2 are transferring to DHS, the other 4 are staying with you
The
guys?
other are staying with us.
Yeah, the other, we'll have 6.
So it's a total of 8. 6 we keep, 2 go to DHS.
Oh, I see. Okay.
And we have those locations.
You have it here?
I could read them to you.
Yeah.
Lower East Side, based at Sarah D. Roosevelt Park. In Harlem, based at Marcus Garvey Park. Elmhurst, Jackson Heights, Rotate, Homestead Playground, Bed-Stuy, Washington Heights, South Bronx.
Okay, and what's happening with those? Those you're keeping?
Yes, those are ours.
Now, didn't you have a van in downtown Jamaica?
Not that.
Maybe it visits downtown.
Yeah.
Some of them
Yeah.
stop in more than one place.
Okay, I'm going to follow up with you.
Yeah, that's fine.
Chair Narcisse.
Yeah, my question is, what the language that we were talking about, the language is, Wolof was the only one that, that's the one that you mostly don't have.
That was the biggest hole. There is a second language. Do you remember? It's with an L. There's a second West African dialect that was a challenge that we're.
Wolof is the most popular language.
But Wolof is the most
popular language
Yeah.
spoken in Gambia.
Yes, correct.
So that's one of the things in Senegal. And I have another, the 100, for the state, are you making plan, because if you don't get the 150 million, I think, that's supposed to be for Medicaid, are you making plan if just in case? I'm hoping that we have the increase, at least 20% of Medicaid
Yeah.
reimbursement, but I'm talking about the 150 million.
We're okay on the state because we got some positives and some negatives, so it all sort of zeroes out the same place where the budget is. So I'm not anticipating any holes due to
Yeah.
the state. The capital is worth saying a little bit about, just because City Council is aware, and I know NYCHA shares this problem as well. We have old buildings, and some of them, the roofs leak when it rains, and you can't provide health care under a leaking roof. And we have a lot of sort of HVACs that need to be replaced, and boilers that need to be replaced, very non-sexy things, but you can't run your buildings without them. And so the loss of those capital dollars at the state are actually the thing that bothers me the most.
Yes, and I think that there's a great demand. Let me just go back to the 150 million number. I think I could speak to that. There's a transfer. So HRA, for certain Medicaid supplemental payments, HRA will transfer dollars to the state. They're kind of the conduit of the non-federal share of funds from the city to the state. We transfer monies back and forth between HRA because there are some instances where H&H has the non-federal share. We give it to HRA, they send it to the state. The transaction in the budget is HRA actually giving us money back. It doesn't. It's just an accounting adjustment in essence. It's not additional services or less services. Mitch makes a very good point about our infrastructure. There's an accounting term called useful life, which kind of measures the age of your infrastructure. And at health and hospitals, our infrastructure is about twice as old, right, as other hospitals in the city and in most parts of the state. So it's an indication that we must rebuild and we must keep up with our infrastructure. There has been limitations, placed on the state in terms of our ability to access statewide capital funds, and we keep fighting for those because of our situation. And we'll continue to do that, and I know that you have a strong voice with them as well, and we appreciate that.
Thank you. Now I have to say thank you so much for being present and keep on fighting, because we have that holistic view of healthcare. And if your house, you don't have a home, you're sleeping on the street, your health cannot be okay. You don't have enough residents, your health's not going to be okay. Enough nurses, your health is not going to be okay. So you need to actually strike a balance on that so we can have the best quality of healthcare in New York City. So thank you. Thank you so much. I don't know if you have anything to add to that.
Doc, thank you so much. We look forward to working with you. We're going to take a 10-minute break, and we'll hear from the public. Thank you.
Thank you.
Thank you. Thank you for doing a good job prepping us. Very nice. Thank you. I'm very honored.
I love that. The more complain, the better. I love that.
Again, give my regards to your wife. Thank you so much.
Thank you.
Great having you.
Good afternoon, everyone. Your attention, if we could please start finding seats. We're going to reconvene in just a few moments. Once again, please find a seat. Thank you.
You can't make it up.
Okay, now we're going to head into public testimony in person and here on Zoom. Make sure if you are here and you want to testify that you filled out one of these slips with the Sergeant at Arms. And I'm going to call the first panel. Apologize in advance if I mispronounce your name. Okay, first, C. Virginia Fields, Annie Moran, Chantel Charles, Ben Mosi, Elise Benosa, Kyron Banks, and Esther Reliever. You want to start? Just say your name before you begin.
Hello, Esther Leliev. It's French. It's a little bougie.
I took French for 8 years. When I got to France, I started speaking French, and they answered me in English.
Well, now with all the
That's how
Senegal
good my French
people
was. Yeah.
here, we'll be talking even more French.
All right, cool. Go ahead.
Okay. Good day, City Council members. I'm Esther Leliev. I'm one of 2 co-founders of Cultivated Community Foundation, proud parent of a DOE student, and auntie to many. We have been in the community in DOE doing cannabis and vape education. Our approach of education is fact-based, cultural awareness, and data education. I work with some of your offices to provide support and training with students, parents, faith-based leaders, seniors, veterans, city and state agencies, including NYCHA Smoke-Free Division, ACS, CPS, Infant Safety, community boards, Cannabis NYC, even family enrichment centers in Far Rockaway, and we are partnered with CUNY Health and DOE SAPIS Division. Our outreach has impacted 40,000 New Yorkers, but I want to speak about what work we have been doing and some solutions. One thing that we have noticed is a lot of agency training that is lacking within it. When we talk about Department of Health, we will want them to support doing inspections with the convenience and smoke shops and convert it into convenience stores that begun carrying food where they can provide support. We want to talk about social media education because some of the access to cannabis is going through social media. In addition, we want to do a community focus on what is causing mental health, which is food insecurities, affordable housing. We have people on unemployment that don't actually qualify for SNAP cash assistance. I want to urge to support our families providing funding for prevention instead of majority intervention. Training across all agencies with these issues would be amazing. I know there's some current laws that are in effect, but they are finding the loopholes within your laws. In addition, to support medical cannabis patients, families, and lack of medical providers and participation to support medical patients, there's biases and discriminations and lack of resources. We're talking about our senior population and our D75. Locations of safe spaces for children is very important, but I want to focus on the SAPIS and pre-pandemic of supporting the SAPIS workers in this prevention work. We have been providing support with them, and we understand that they started pre-pandemic for 1,200 and were reduced down to 266 with 1,600 schools and how many other children. I would like to thank Chancellor Banks, Mark and Kellyanne and the SAPIS workers and start providing funding for them. I'm here for any questions or data or references.
Thank you. Tell me the name of the organization again.
Cultivated Community Foundation.
Thank you. Go ahead.
Good afternoon. My name is Chantel Charles. I'm a SAPIS counselor, which stands for Substance Abuse Prevention Intervention Specialist. I'm here to represent Local 372 and the about 236 SAPIS that I work with. So pre-pandemic, we saw about, I'll say 2018, 2019, approximately 1,100 incidents reported in schools. With the pandemic, since the pandemic, and I'm sure the numbers are going to be higher this year, but the 2022-2023 year, there were 14,048 incidents reported, and that's according to the reports that were actually made. Myself, as a SAPIS with experience going on 9 years in the school system, working with these kids is crucial. They are heavily misinformed. They are very hard to motivate and engage in the school system. They are learning things off social media that really don't make any sense. The reason we're here asking for help with our finances, with the budget, is so that we can do more for those children in the school. As a SAPIS, we not only educate the children, but we also work with their families, we work with parents and staff to help get these children in school as opposed to outside in the streets. And as recently as last week, there was a very violent situation where I know Denise Mieses, who was supposed to be here, wanted to share, was one of her students, a student from her school, that incident in Queens that a 15-year-old stabbed another child in the throat and she passed away. Incidents like these are too high and the children are not being engaged in school. The information and guidance provided by SAPIS is to prevent them from heading out there in the streets, to give them that support system that they need inside the school building.
Thank you. Thanks for all you do. Go ahead.
Good afternoon.
Make sure that mic's on. No.
How about now?
Good.
Good afternoon, everyone. Chair Brannon, Chair Narcisse. My name is Annie Moran, and I'm a case manager at the Center for Urban Community Services Prospect Place, which is a mental health shelter that provides medical and psychiatric services and works with clients to move them into permanent affordable housing. I'm also a proud member of DC 37. We are currently in negotiations for a first contract. I'm grateful for the council's response to the mayor's preliminary budget, in which the council stated public health and public safety issues are intrinsically intertwined, illustrated by the continued and increasingly high number of New Yorkers with mental health challenges being inappropriately directed into the city's criminal legal system and jails rather than into treatment, end quote. CUCS provides services ranging from career development to street outreach to supportive housing for people with mental health histories. All too often, I see my clients get caught up in the justice system as a result of disinvestment in their communities and a lack of access to robust mental health care. The mayor's executive budget proposes DOH-MH funding that is $500 million lower than the amount forecasted for 2024. Across the city, CUCS and agencies like ours suffer from chronic workforce turnover, high caseloads, and high vacancy rates due to low wages and disinvestment in mental health services. The staff turnover at agencies like ours weakens the trust built with clients, an essential element of services that support people on their journeys to stability. As the cost of living continues to rise, I want my coworkers to also enjoy stability and to be able to continue working in a field they find meaningful. In addition to the investments in housing, education, childcare, and arts and culture that are proven to lead to positive health outcomes, I ask on behalf of my fellow human service workers for the council to continue to push for increased funding to DOH-MH and the mental health services that New Yorkers deserve. Thank you.
Thank you. Madam President.
Good afternoon, distinguished members of the council and chairs. I'm here today to speak about the elimination of faith-based outreach programs through Department of Health. And I was very pleased to be here earlier to hear the commissioner say, number one, that there had been ongoing discussions with the organizations impacted, and I can speak specifically for my own Black Health and the Latino Commission on AIDS, whom I know you will hear from. We were notified roughly around April 18th by the Public Health Solution that manages these contracts. Then we received a letter follow-up from the Department of Health. To be told within 8 weeks that your entire program is going to be eliminated is totally unacceptable, disrespectful. We also have a very long-standing relationship with the City Council and the Department of Health with respect to the faith-based programs. I think the commissioner also said that consideration was given to programs that had been launched through COVID. This particular program is at least 25 years old, and we have results to show impact. Faith leaders are credible voices in our community. Faith leaders are the ones we come to immediately when there's any pandemic or epidemic, and faith leaders are the ones who carry the messages on the ground. So this funding allows us not only to hire staff, but to provide funds to faith leaders to do the work on the ground. And I urge you to please work with us, advocate for the restoration of these dollars to the HIV faith outreach programs that have currently been eliminated through the Department of Health. I have provided a copy of my longer testimony, which I knew I would not have 2 minutes to do, but I at least wanted to come and share this with you today. Thank you so much, and we ask for your support.
Thank you very much. Go ahead.
Thank you. Before I begin, I have copies of my testimony for the Sergeant at Arms. Good afternoon, and thank you to Chairpersons Brennan, Shulman, and Narcisse, and the rest of the committee members. My name is Karan Banks, and I use he, him pronouns, and I am the Manager of Policy and Advocacy at Callan Lord Community Health Center. Callan Lord is a global leader in LGBTQ+ healthcare, providing sensitive and quality healthcare for more than 20,000 New Yorkers in the surrounding region, regardless of their ability to pay. While this budget increased funding for healthcare initiatives and canceled the 5% agency cuts are positive signs, we urge the council and the mayor to make additional investments in programs that improve access, advance equity, and proven to work. Just a few short weeks ago, DOHMH notified several community-based organizations like Callan Lord that some of our FY25 contracts would be reduced or eliminated. For Callan Lord, one of the contracts provides case management and behavioral health services for crystal meth users, and the other contract provides incentives for viral load suppression for people living with HIV/AIDS. These contract reductions and elimination raises serious concerns and will set us back from our collective goal for a healthier city. According to DOHMH 2022 HIV surveillance report, reduction in new HIV infections have plateaued, falling only 2% since 2021, evidence that our city should be investing more in prevention and treatment efforts. We urge the council to reverse the proposed DOHMH contract reductions that will lead to eliminating key programs. I also want to highlight other vital programs that we believe are critical in advancing health equity and improving access to care. We urge the council to support the following initiatives in the FY25 budget. Sustain the continued funding of $3.4 million for support for persons involved in the sex trade initiative. Support the continued funding of $9.3 million for Ending the Epidemic initiative to ensure the ongoing success of our efforts to eliminate HIV/AIDS. And also, we urge the council to support the continued funding of $3.2 million for trans equity programming. In conclusion, this executive budget should be an opportunity to invest in health and social services to improve access and advance equity for all New Yorkers.
Thank you.
Good afternoon. My name is Elise Benusa, and I'm the Government Relations Manager at Planned Parenthood of Greater New York. I want to thank Chair Brannan, Chair Narcisse, and Chair Shulman, and all the Finance and Health Committee members for the opportunity to discuss PPG&Y's programs, services, and FY25 funding requests. For over 100 years, PPG&Y has been a trusted provider of sexual and reproductive health care and education programs for communities throughout New York City. In 2023, our New York City health centers conducted over 70,000 patient visits, providing care to all those in need, regardless of immigration status, identity, or ability to pay for services. We are so thankful for the City Council's continued support of our programs and services. With the ever-changing national landscape and continued attempts to restrict access to care, New York is seen as a haven for critical healthcare services. Support for PPG&Y is more vital than ever. We recently received news that we are facing an unprecedented 12% cut in our government funding from the New York City Department of Health and HIV Services. We're hoping that the New York City Council can restore these losses. This is why we are here today, asking the council to restore these cuts and continue to fund reproductive and sexual health services for all New Yorkers. Funding from the council allows PPG&Y to continue to provide sexual and reproductive health care services and educational programs throughout New York City. PPG&Y provides the full range of sexual and reproductive health care services that includes gynecological care, STI treatment and testing, contraceptive care, cancer screenings, and LGBTQ+ health care at all 5 of our New York City health centers. We also request support for the Trans Equity Initiative to help empower the trans and gender non-binary populations to lead healthy lives by expanding access to sexual and reproductive health services and gender-affirming care at all our health centers. We also seek funding for the Ending the Epidemic Initiative, which supports the critical work of Project Street Beat, our mobile health center unit that provides targeted outreach and services to individuals who are living with or at risk for HIV or who have chronic health conditions. Okay, I have a couple more paragraphs, but I'll just end with PPG&Y continues to be committed to ensuring that all New Yorkers, no matter their background, get the care they need. It is important that the Council continues to support PPG&Y's Speakers Initiative requests. With these funds, PPG&Y can continue to provide services and programs that focus on New Yorkers' most vulnerable populations. We look forward to working with the Council to ensure healthcare access for all. Thank you.
What's your total cut?
Sorry, what'd you say?
The cut the DOH is making to Planned Parenthood?
Oh, it's 12%.
12%. Thank you.
Of course, thank you.
Good afternoon. I'm Ben Mossy. My name's also French. Delegate for the Organization of Staff Analysts. In behalf of the staff analysts, I would like to thank the members of these committees and the City Council as a whole for their unending commitment to the health of all New Yorkers. I've worked at Health and Hospitals for 13 years, and I've seen firsthand the positive impact to the health and lives of our patients and community. Thank you again for your understanding and commitment to the mission of Health and Hospitals.
Thank you. Any questions from my colleagues?
Yeah, not a question, but I just want to tell you that we're very focused on making sure that HIV and AIDS is whatever cuts were made or put back. I know you said 12% from Callan Law. Do you have a figure? Numbers.
Yes. So for the crystal meth harm reduction program, the contract was cut by $40,000.
Okay.
And for the undetectables, it was eliminated completely.
Okay, which is how much?
Which is about $245,000.
Okay, no, because that helps us,
Absolutely.
when we're trying to push back. And I want to thank Esther. I'm sorry I wasn't here for your testimony, but I just want to thank everybody here for everything that you do. I used to work at Gay Men's Health Crisis some years back, and in the midst of the HIV/AIDS epidemic. So I just want you to know that I'm very committed to making sure that we have the resources we need to end the epidemic. So thank you very much.
I want to say thank you, and you've been in the council. That's welcome home to sit there to advocate. And one of the things that you said, Ms. Greenfield, I remember, it's about credible messengers. When you're talking about, if you want to know where to pass any messages, you go to the churches, you get all the black and brown people on Sundays. So if you want the message to get to the people, that's where you go. So thank you for continue fighting for the faith leaders in our district. And Planned Parenthood, you heard it earlier that we need your presence. We need that because what Dr. Katz said, most people were coming all pregnant. So we need to have the educational part go around our new arrival as well. So thank you all for doing, healthcare is in my heart, so thank you for all your work. Thank you.
Thank you all very much. Okay, we're going to call the next panel. Dalvir Kaur, Daphne Tamasila, Suchai Tai, Heather Choi, Yuna Yoon, Barry Post, Lilia Burns.
My apologies, Fields. I just say Greenfields. It's Fields, Virginia Fields. We fought hard back in the days for HIV and AIDS, right?
Okay, you want to start? Go ahead. Just make sure your mic is on.
That would be helpful.
Go ahead.
My name is Delvia Kaur. I'm the Director of Healthy Communities at New York Immigration Health Coalition. Thank you for hearing me out this morning. And whilst we're really grateful for all the support that we get for both documented and undocumented immigrants, New York Immigrant Health Coalition is an umbrella organization serving 200 immigrant refugee rights groups, and we are advocating for the enhancement for Access Health to $4 billion. This program offers information, support, and education to communities across New York City, specifically immigrant communities. They are able to get access to pantries, to work employment, legal rights, food, childcare, education system, knowing their rights, in addition to making sure that they get the vaccines that they need. In 2021, I worked for the Department of Health as a COVID-19 lead respondent, and I can tell you without these organizations, a lot of immigrants, both documented and undocumented, would not have received both necessary vaccines to be vaccinated. So the work that these 38 organizations that we are doing with, through Access Health are making this possible, not only to keep New York City safe, but to make sure that these immigrant populations get the care that they need, the support that they need, and get the food that they need to feed their family, so that they are contributing New Yorkers. And so I'm here to really make the plea that we encourage the enhancement of Access Health funding.
Thank you.
Thank you.
Good afternoon. My name is Daphne Tomasula, the Associate Director of Programs at the Asian American Federation. Our budget ask is simple, that our nonprofits in the Asian American Mental Health Roundtable be provided enough resources to implement and expand essential services to support the mental health needs of our diverse community. We urge the City Council and members of the committee to consider the following recommendations to make sure Asian New Yorkers receive critical, culturally and linguistically appropriate mental health services. 1, invest in CBOs that provide culturally and linguistically competent services to the Asian American community in New York City. 2, increase funding for mental health programs that are culturally sensitive and linguistically appropriate for Asian American populations. And 3, invest in a linguistically and culturally competent mental health care workforce. As you'll hear today from members of our Asian American Mental Health Roundtable, our roundtable that's made up of 12 organizations across the city directly providing mental health services to the Asian community. They're joining me on this panel. Our budget requests are a reflection of the unique mental health needs of Asian New Yorkers. Through our mental health work, we found our member organizations report a 20% increase in Asian New Yorkers requesting mental health services to address the excessive anxiety and fear that persist within our communities. Community members stated that one of the places they prefer receiving mental health services and mental health information is from community-based organizations. Our roundtable organizations are an integral part of the mental health care ecosystem, and they often serve as a referral from larger hospital systems without receiving funding to do so. Over 50% of our roundtable partners lack sufficient funding for mental health services. 75% of the organizations in our roundtable express a need for additional funding to not only support their existing mental health services, but facilitate their expansion to address the rising demand for services. Thus, this work and the work of our community mental health providers need support more than ever before. We ask that you support us and our partners as we continue to provide critical mental health services. Thank you.
Thank you. Go ahead.
Hello. Okay. Good afternoon. My name is Siqi Dai, and I serve as a counseling center program manager at Garden Hope, a linguistically and culturally competent nonprofit organization dedicated to serving and empowering individuals across Chinese American communities. Beyond providing services to survivors of domestic violence, sexual assault, and human trafficking, our focus extends to addressing the mental health needs within our Asian immigrant community. In response to COVID-19 and rising anti-Asian hate crimes, we launched the Garden Hope Counseling Center in January 2021. We are committed to providing support and empowerment to individuals surviving from depression, anxiety, trauma, adjustment issues, and various mental health concerns. We provide individual counseling, support groups, and mental health outreach programs aimed at raising public awareness and combating stigma. Our outreach initiative reach senior centers, cultural centers, community fairs, and faith-based organizations, where we conduct psychoeducational workshops. Emphasizing prevention, our youth services actively collaborate with schools to advance mental health education and support. I stand before you today to address the critical issue affecting our community, the urgent need for funding to sustain and expand our culturally specific prevention and intervention programs, addressing mental health challenges among Chinese immigrants in New York City. Our programs are particularly designed to meet the unique needs of Chinese immigrants in New York City. In 2023, Garden Hope provides trauma recovery services to 1,071 adults and 317 youth and children, with 94% of adults clients having limited English proficiency. This underscores the critical needs for culturally specific support and language accessibility. With 21 bilingual staff members, we deliver culturally competent mental health services to overcome barriers and promote well-being. And together, let us work together a future where every individual, regardless of their background, has access to the resources and support they need to rebuild their lives with dignity and resiliency. Okay, thank you for your attention.
Thank you very much. Go ahead.
Thank you. Good afternoon. My name is Heather Choi, Youth and Community Engagement Coordinator at the Korean American Family Service Center. At KFSC, we are dedicated to supporting immigrant survivors of gender-based violence and their children, offering essential services in a culturally, linguistically appropriate setting. The pervasive issues of DVs, SA, and anti-AAPI hate crimes highlight a profound need for specialized mental health support within the AAPI community. At KFSC, we're deeply aware of the mental health challenges our community faces, often exacerbated by cultural stigma and language barriers. These barriers not only deter individuals from seeking help, but can also isolate them during times of need. Our services are designed to eliminate these barriers by being accessible without the need for insurance, documentation, and completely free of charge, ensuring help is available to all who need it. Our organization serves as an essential resource for the AAPI community, with 100% of our staff members being bicultural and of AAPI descent, and 90% of our clients primarily speaking languages other than English. We provide continuous support through our 24-hour hotline, crucial for many, particularly young AAPI women and elders who often feel particularly vulnerable to the complexities of violence and discrimination. These services are integral not only for immediate assistance, but for fostering enduring mental well-being and resilience. The psychological impact of violence and discrimination on our community members is severe and tangible. We hear the distress in their stories and see their fear in their expressions. In addressing mental health, the most significant challenges are not only linguistic and cultural, but also include the fears associated with immigration status and the financial burdens of healthcare. By removing these barriers, KFSC ensures that mental health services are accessible to those who typically have the least resources but the greatest needs. We urge the committee to acknowledge the critical importance of mental health services tailored to the cultural and linguistic nuances of the AAPI community. Your support can help ensure that survivors and their families not only recover, but also thrive beyond these challenging times. Thank you.
Thank you. Go ahead.
Hello? Okay. Hi, my name is Yuna. I'm the director at Korean Community Services, KCS's mental health clinic. Thank you, Council, for this opportunity to testify. Just first of all, I wanted to highlight that we are working so hard to receive funding in a way that maybe in other systems like hospitals, it's just considered essential, and so there's no second thought about it. It's just it doesn't need to be explained, and we need to advocate and we need to somewhat justify it. And I just wanted to highlight that. So I wanted to say how we prioritize different types of mental health support is something for us to really think about. I wanted to focus on this concept of an essential worker. When we think of how funding is not questioned, we need to think about how essential outpatient clinics are and whether the funding allocations reflect that. So I echo a lot of what everyone said here before, that these are the kinds of issues that we're seeing. At an outpatient mental health clinic, some of the clients could be domestic violence. Some of the clients could be the person who is the perpetrator, the child, the family. The parent has a language access issue. The child does not communicate with the parent because maybe the child does not speak a foreign, only speaks English. And so within all of that, we also need to navigate medications and staff turnover and pay parity and just trying to coordinate all of that and then becoming this system or this point where if a hospital cannot continue, and they will throw people back, they will just send them out in a day, and we just shoulder the burden of that. So I just urge council to really think about how we can work together to make sure that things aren't reactive, so that funding when anti-Asian hate happens isn't the kind of thing that, even before COVID, mental health support happened was reactive when violence was associated, like school shootings, and it's only organizations roots in the community with complex that really know these crises and have complex relationships. They can create that sustainable and cost-efficient care, and not only after tragedy strikes.
Thank you. Go ahead.
Hi, good afternoon. My name is Lilia Burns. I am the Assistant Executive Director of Behavioral Health Services at Hamilton Madison House. I'm here with my colleague Barry Post. He's the Director of Development. We are a nonprofit settlement house in the Lower East Side. I also want to just shout out to Bay Ridge. Yeah, thanks. So we are a nonprofit settlement house in the Lower East Side. We are the largest outpatient mental health provider for Asian Americans on the East Coast. We serve about 630 clients annually. Currently, we operate 5 mental health clinics, a personalized recovery-oriented services program, a substance recovery program, and a supportive housing program for individuals with severe mental illness in Queens. And since 2022, we have been piloting the Connect program, which is the community arm of the mental health clinic. This team goes out into the community to see clients wherever they are. We have staff who are all bilingual, and we provide services in English, Chinese, Korean, Japanese, Cambodian, and Vietnamese. And in line with the City Council's priority for the resurgence of efficient and impactful city services for fiscal year 2025, I'd like to bring your attention to a few of our priorities that need continued and robust funding. I was very pleased to hear this morning that Chairwoman Lee talked about related to the Forensic Act teams. The CONNECT program stands for Continuous Engagement Between Community and Clinic Treatment. This was launched by the DOH-MH in partnership with the Mayor's Office, and I believe the funding came from COVID. Each of these teams were allocated $1.4 million. In the last 18 months since we've launched the program, we've had significant impact. Connect is essentially a lighter version of ACT, and this morning we heard about assertive community treatment teams, how they are evidence-based model, which Forensic Act teams are also modeled after. So essentially the Connect program takes over some of the clients who are being discharged from FACT, from ACT, and also from IMT teams. For many, many years, I worked for ACT teams. One of the struggles that we had were that we were not able to discharge people who have been on these teams for years and years and years, and we're talking about 15, 20 years. And we thought that the city finally heard us and came up with this ACT Light model called Connect. I think that it is on the brink of probably being cut, and it's definitely a life-changing program for our community, definitely because of the anti-Asian hate A lot of our seniors refuse to go out. They're fearful of their lives. With the Connect model, we're able to go into the homes. We're able to give them medications, give them essential food, clothing, and whatever it is that they need. We really want to highlight the importance of this program. In the last 18 months, we were able to collect a lot of the data, which demonstrated that it was very effective. We even presented at the American Psychiatric Association this last week as a poster, and more of the data I can send after the testimony. I just want to highlight that this is a very significant program and that we need more time to provide more outcomes.
Thank you.
Thank you.
Oh, hello. And to add on to that, so measuring pre-pandemic to post-pandemic, demand for our services is up 30% when you measure emails, phone inquiries, and referrals. So we would like to meet this rising demand, but recruitment is a standing problem, particularly in our clinic because we speak 11 Asian languages and dialects. So where do we find these folks? Well, for decades, on our own, we've developed a talented pipeline of culturally proficient and linguistically proficient Asian American mental health professionals by recruiting international students who first intern with us as part of their MSW studies, and then they remain with us as permanent staff. However, to stay there beyond their internship year, they need sponsorship. They need an H-1B or a green card. Over the past 6 months, we have spent $35,000 on H-1B and green card sponsorships out of our general operating budget. So that's tough. So each H-1B costs us $6,000, each green card is $10,000, and then over the past 5 years, we believe we spent $175,000 on this. So we've only had sporadic piecemeal support for this kind of spending for like talent sustainability. However, as of last year, we did get a line item in the Connect budget that we were just talking about and via OASIS, substance use disorders. So wouldn't it be great if there were other funding lines for that available, if it didn't have to come out of our general operating and not just OASIS and Connect? That's all.
You have internal lawyers, or you use other CUNY for support for the papers for the immigration part?
No, we have a consulting lawyer that we work with.
Consultant lawyers, or you partner with CUNY laws or
we pay
Legal Aid Society? None of those? No.
No.
Oh, I'm just.
For the visa sponsorships you're referring to?
You know, when it has to do with immigration, to do anything with immigration? No? Okay.
Councilmember Lee.
No, I just wanted to say hi to this panel, and I was just with a lot of you in Albany this past week because May is AAPI Heritage Month as well as Mental Health Awareness Month, and so it's fitting that we're having these conversations right now. And I mean, the reality is also when I was at KCS, we had to do that too, not just for the mental health clinicians, but for so many staff, because the H-1B visas and the folks that have the bilingual cultural competency, that is a very creative way to think about it, so that's something we can explore. And then just in general, quick question with the Connect. So what is the timeline exactly? Because I know that you said that it hasn't been that long since DOHMH launched this program. Obviously, we need time to see it roll out and to see how effective it is. So what's the timeline?
So it is slated to end December 31st, 2024. We were told verbally that it may be extended through end of 25, but there's been no confirmation, and there's been no talks about the extension at all recently. So.
Okay. So that's something that we can definitely follow up with on our end with DOHMH. And also, just out of curiosity, I know that there's a lot of nonprofits sitting in the audience. Just by a show of hands, how many of you received your discretionary funding for FY24?
We didn't.
None. Okay. Yeah, that's what I thought. That's a problem. Okay, thank you. And just shout out, of course, to KCS, KFSC, Garden of Hope, NYIC, AAF, all the groups that are doing amazing work on the ground. It is not easy, and just from starting up the clinic at KCS, it is labor of love, that's for sure, and severely underpaid in terms of staffing. So thank you for all that you do.
Thank you all very much.
Thank you.
Okay, our next panel, we're going to hear from Prama Ilepemel, Juan Vasquez, Fio Grady, Kumari Cruz, Casey Starr, Zach Hennessy, okay, you want to?
Thank you. Good afternoon. My name is Dr. Juan Vasquez. Thank you, Chair Showman, Narcisse, Brennan, and Lee for the opportunity to testify here today on behalf of my fellow CAR members. I'm a third-year emergency medicine resident at Bellevue Hospital and NYU. My program, like most of the programs at Bellevue, is a split program. This means that while all of the residents are in the exact same program, doing the exact same work and caring for the exact same patient population, we are divided across two payrolls. And over the last 2 years, those of us on the Bellevue payroll have been paid over $20,000 less than our colleagues on the NYU payroll. Like all of my colleagues, I'm incredibly proud to serve in one of the nation's largest public health hospitals and be able to care for our patients regardless of their race, their ethnicity, their immigration status, or whether or not they can pay for their hospital visit. But like our patients deserve to be cared for by the best doctors, and in order to be at their best and for us to be able to give our best, we need to first be able to meet our basic needs, like affording housing, food, and transportation without being forced to go into further debt. Currently at my program, we have residents commuting all the way from New Jersey because they can't afford to live in the city that we work. And we've had instances where residents are outbid from housing leases because our salaries don't allow us to basically compete with others who are competing at market rate. H&H residents don't just face the usual stressors of residency that comes with long hours. We also face financial stress and the stress of working in hospitals that have faced years of understaffing. We're constantly required to take on transportation, nursing, social work, and clerical and more duties to ensure that our patients get the care that they need to be able to be discharged back to their families. This is a daily occurrence. I was hoping that Dr. Katz would be here so that I could provide some perspective on that, but unfortunately he left. Basically, to kind of sum things up, we are hoping that the administration will take the steps to safeguard the quality of care that we can provide at H&H and to agree to a contract with pay parity for residents that does not delay future pay increases and provides additional funding to our patient care fund and on-call coverage that does not come at the sacrifice of our own pay raises. Everyone here understands that the increasing pay gap between public and private hospitals is draining our safety net hospitals of resources, including talented, caring, and committed providers. And this is how disparities in healthcare outcomes are created. And today here we have the opportunity to do what's right for our patients and to provide better funding for our hospitals and fair compensation for the relentless work that we all do. Thank you.
Thank you. Go ahead.
Thank you. Good afternoon, Chairs Narcisse, Shulman, Lee, and Brennan. My name is Dr. Prama Ilepemel. I've completed my internal medicine residency at Woodhull Hospital. I'm currently a fellow in pulmonary and critical care medicine at South Brooklyn. My fellow CIR members and I have testified 3 times now in front of the council discussing working conditions, well-being, and the administration's unwillingness to pass a fair contract. In my almost 6 years at H&H, I've rotated across 4 different H&H hospitals. I've been here through each wave of COVID. I've seen our patient loads increase, and I've seen our residents get pushed to something of a breaking point as we navigate struggling to avoid our basic needs on the H&H pay scale, particularly with increasing housing, healthcare, and childcare costs, all while being forced to take on the extra burden of excessive non-physician and non-educational tasks. On May 1st, as Chair Narcisse pointed out, we filed 26 out-of-title work grievances representing over 400 individual instances of across 8 hospitals in the previous month before that May 1st period, demonstrating how health staff are routinely asked to undertake these duties. Typically, they would go into the purview of social work, nursing, transport, phlebotomists, or clerical work. And I reflect personally on the maybe hundreds of hours I've spent in the last 6 years doing these things that are outside of the scope of my training program, very much like my co-fellows and residents, all without extra pay or recognition, only to still be among the lowest paid health staff in New York City, even among safety net hospitals. So this simply can't be the norm. Dr. Katz testified that this was an occasional thing that happens when people call out. It's not. It's routine. It's inherent to the workflow of our hospitals, wards, and clinics. In my time at H&H, we've had house staff commit suicide. I personally had a colleague attempt suicide leading to hospitalization. I've had colleagues had to go on mental health leave, and a handful more start on antidepressants. This is that breaking point kind of point that I'm talking about. The stresses of the job, combined with being unsupported in our employment environment, financially and otherwise, takes a toll. And unfortunately, a lot of talented doctors are not going to stay on at H&H after we finish our training. To add insult to injury, a lot of active health staff now will not receive will never have received a pay raise if they graduate in June without a ratified contract, unless Mayor Adams and the city can take action to agree to a fair contract urgently. That's why we urge this administration to take this issue seriously, to push everybody to pass a contract that invests in our communities, our patients, and acknowledges the efforts that us health staff are putting into this system. Thank you, guys.
Thank you.
Thank you, Chairs Lee, Brannon, Narcisse, and Schulman. My name is Casey Starr, and I'm the co-executive director of Samaritans of New York, the city's only community-based organization dedicated solely to suicide prevention. I also represent Samaritans USA on the National Council for Suicide Prevention and serve as the representative for North America for Befrienders Worldwide, the oldest and largest suicide prevention network in the world with over 400 centers in 40 countries. Last year, Samaritans trained nearly 3,000 mental health providers. We provided direct support services to 649 survivors of suicide loss, and our anonymous and confidential hotline was contacted more than 50,000 times. Samaritans is a vital support amidst a troubling landscape. In our city, someone dies by suicide every 16 hours. As you review the executive budget, I urge you to consider the profound impact the proposed funding cuts on our city's mental health services will have. These reductions threaten the very fabric of our community support system, particularly for those most vulnerable. And we know that on the conservative end, 60% of adults and 70% of adolescents who need mental health services are not able to access treatment. And a new 2024 study conducted by MHA said that nearly 94% of adults with substance use disorders never receive treatment and aren't able to access it. I want to thank the council for their longstanding support of the hotline and our other programs, and just to emphasize that the reduction in funding to the city's mental health services at this critical time is not only a disservice to those who utilize these defunded programs, but undermines our city's long-term mental health goals. Suicide is the end result of unalleviated suffering, of a failed safety net. It's a barometer for our society because it tells us about the quality of our lives, how we address challenges, and how we treat those most vulnerable among us. And the deep-rooted shortfalls in access to mental health care really illustrate that instead of providing urgent and sustained attention, the executive budget betrays an entrenched aversion to parity and deeply held biases. Thank you.
Thank you.
Thank you, Chair Brannon, Chairs Schulman, Lee, and Narcisse for the opportunity to speak today. My name is Fiona O'Grady, Director of Government Relations at Samaritans also. I'm here to discuss the critical role Samaritans plays in New York City's mental health landscape. New York City is at a crisis point in mental health care availability, which will be made worse by the cuts proposed in the executive budget. The necessity for completely anonymous and confidential mental health services cannot be overstated, particularly as many individuals most at risk, including those with serious mental illness, LGBTQ individuals, youth, elderly, veterans, Black and brown communities disproportionately affected, and those impacted by the criminal justice system are often wary of seeking help through government-run services. Last year alone, Samaritan's confidential anonymous 24-hour hotline responded to over 50,000 contacts from New Yorkers in crisis, many of whom would not seek help in a less confidential setting. Cuts to essential mental health services should not be seen merely as budget adjustments. Rather, they are decisions that will profoundly affect the lives of thousands of New Yorkers. Reducing funding sets back our city's commitment to safeguarding residents, especially at a time when those services are crucially needed. This is akin to withholding lifeboats on a sinking ship. Both actions knowingly increase vulnerability and potential harm during a crisis. Maintaining a confidential and anonymous hotline allows Samaritans to serve a diverse group of individuals who would otherwise avoid seeking help. The hotline is a necessary complement to 988 by providing New Yorkers with essential choices in their crisis response, which is vital for effective intervention. In fact, offering multiple points of entry for the suicidal is something borne out by the US Air Force in their seminal study that reduced suicide. So 3 things for us. Firstly, please restore the $312,000 for the suicide prevention hotline. We haven't had an increase in many years, and our costs are much higher, especially with staffing and recruiting volunteers. We're asking for $65,000 more. And also help us, which Chair Lee even though, has offered to help, which the DHMH cut our budget last year. We had a $65,000 annual, which is $180,000 in a 3-year contract. They told us off the cuff in September, after we'd already provided 3 months of services. Then they said, oh, the Fund for Public Health will be picking you up. We then got in contact with the Fund for Public Health over months. They also said no, they had nothing in their books. So we're also asking the City Council to help us to reinstate that 3-year contract, and Chair Lee will help us with that. So it's another example of the DHMH, and we had a 3-year contract at that amount for 9 to 12 years. And this year it would have been $72,000. So that's $210,000 over 3 years. And that money we're asking for the enhancement and is not the same as asking for our $312,000 and our $65,000. Thank you.
Thank you.
Good afternoon, and thank you, Chairs Brennan, Lee, Narcisse, and Schulman, for the opportunity to speak today. My name is Kamari Cruz, and I am the Director of Public Education and Bereavement Services at Samaritan's Suicide Prevention Center. Every day, I witness firsthand the impact of mental health disparities, particularly around the marginalized communities. Our services are crucial in helping individuals through their darkness. The executive budget includes cuts that are deeply concerning to me, as they do threaten to dismantle the support structures these communities rely on. They intensify already prevalent issues of access and equity in mental health care. I see these issues mostly in our education programs that are often the primary and sometimes the only line of defense against mental health crisis in underserved areas. Our city's youth has reported alarming and consistent increases in major predictors for suicide, including feelings of hopelessness, self-injury, suicidal ideations, and it bears out in other data. Suicide is the 3rd leading cause of death for New Yorkers aged 15 to 24. Suicide accounts for more than 20% of all deaths for children aged 10 to 14. 1 in 3 transgendered youth considered suicide in the past year, and 2 in 5 have made an attempt. These distressing trends underline the critical needs for accessible mental health support. Reducing fundings for services like ours not only deprives vulnerable populations of crucial tools for managing their mental health, but also increases the likelihood of preventable crisis. Samaritan's programs are tailored to meet the unique needs of these communities we serve, creating culturally appropriate and effective interventions. It seems almost unfathomable that in the face of this dire situations that we're here talking about cuts to mental health. By reducing fundings for services like ours, the city risks depriving its most vulnerable populations of essential tools to treat, maintain, and improve their mental health. Restoring and enhancing this funding is not merely a budgetary consideration, but a profound commitment to social justice, equity, and public health. Support for Samaritans is a direct investment in maintaining our city's resilience and ensuring a healthy future for all New Yorkers.
Thank you.
Good afternoon. Thanks for hanging in there. My name is Zach Hennessy. I'm the Executive Vice President and Chief Strategy Officer at Public Health Solutions. We are, for more than 60 years, we are a nonprofit public health organization committed to health equity in New York City. We do that through providing services directly to families, supporting community-based organizations through longstanding public-private partnerships, and bridging the gap between healthcare and community services. I'll touch on 3 areas today: sexual and reproductive health, maternal and child health, and benefits access. Through a combination of federal Title X New York State Family Planning Program and billable activity, we operate 2 Article 28 licensed sexual and reproductive health centers in Fort Greene, Brooklyn, and in Brownsville, where we provide high-quality care that is patient-centered, trauma-informed, and focused on reproductive health. We have successfully prioritized sexual and reproductive health needs of Black women, women of color, and persons capable of pregnancy who are under or uninsured or living below the federal poverty level. On an annual basis, we serve up to 2,500 patients at our sexual and reproductive health centers and work with many local middle and high schools to provide evidence-based sexual health education to about 5,000 teenagers annually. On top of severe workforce challenges and dramatically escalating costs, our centers are struggling due to funding cuts in both New York State's Family Planning Program and the federal Title X program. It's remarkable that this is occurring post-Dobbs. So we are requesting support from the City Council to allocate $350,000 for PHS in fiscal year 25 through the Speaker's Initiative and or the Dedicated Contraception Fund in support of our sexual and reproductive health centers. In maternal and child health, where we are really addressing the issue of Black maternal morbidity and mortality, we're requesting $175,000 from the Maternal and Child Health Initiative for Family Connect and our New York City Breastfeeding Warm Line. And lastly, on benefits access, where we are seeing an incredibly increased demand for resources due to the asylum seeker surge, we are requesting $225,000 from the Access Health and support our seniors initiative for our Benefits Bridge program. Thank you.
Thank you. Thank you all very much for your testimony. Okay, the next panel, we'll hear from Erin Verrier, Dash Yeats-Lonsky, Janine Mendez Sr., just Janine Mendez, Greg Mihalovich, Alice Bufkin, Jonathan Chung, Judy Wessler,
no, I already uploaded it. Thank you.
Do you want to start?
Sure. Hi, everyone. Hi, and thank you for the opportunity to present today. My name is Erin Verrier, and I manage policy and external affairs for Community Healthcare Network, otherwise known as CHN. CHN is a federally qualified health center with 14 sites citywide that provide critical primary care and social services for patients in underserved communities. We reach over 50,000 patients annually and welcome patients of all ages, regardless of their ability to pay. Today, CHN is working to increase our reach by relocating and expanding health centers and renovating health center infrastructure. Currently, we are in the process of relocating our South Bronx Health Center, moving it 1 block away, and are requesting city dollars in support. We will be significantly increasing the center's square footage, therefore upping the number of exam rooms, and will be able to include new dental operatories, adding dentistry to our already robust set of services. Overall, this move will allow us to provide more services for more patients in the South Bronx. In addition, we are requesting support for the renovation of our Long Island City Health Center. We will be making critical infrastructure improvements to build out a high-quality clinical environment for patients and staff. An exciting development for this site, the LIC Health Center will house a new family medicine residency program that will begin this July. The program will train newly graduated medical residents in community-based primary care, ultimately adding to the much-needed primary care workforce in underserved communities. Now, on to a separate priority I'd like to highlight, which is the needed support for our school-based health centers. We have 2 school-based health centers that provide a full range of primary care services, including mental health services. I'll jump to the main point, which is that we seamlessly integrate students' physical and mental health, and that's what we call primary care at CHN, and we want to ensure these services, along with those at school-based health centers citywide, continue. As such, we request baseline funding for all school-based health centers at the level of $100,000 per school-based health centers, plus $100 per student enrolled in the school. That's all for now, and I appreciate the opportunity to speak today.
Thank you.
Good afternoon, Chairs Brandon, Lee, Shulman, Narcisse, and members of the Joint Committees. My name is Jonathan Chung, Director of Public Policy and Advocacy for the National Alliance on Mental Illness of New York City, or NAMI NYC. We're the only nonprofit providing direct and extensive family support to New Yorkers who care for someone living with serious mental illness. Thank you for the opportunity to testify. I will speak today about 2 important things: the importance of implementing a youth peer-to-peer model through NAMI NYC, and the importance of supporting us with our programming for family members of individuals living with mental health conditions. First, the youth mental health crisis we are facing in our city and our nation is real. We commend Speaker Adams for outlining peer-to-peer mental health programs for students as a priority in her State of the City address. NAMI NYC brings 40-plus successful years of experience in peer-to-peer support with real impact on the people we serve. We hope to expand at the intersection of peer support with teens and young adults. This is crisis prevention and will be cost-effective as an upstream way to mitigate issues young people are dealing with. We hope the Council will consider funding us to develop and implement this programming. Second, NAMI NYC sees families as a threat across a fractured system for New Yorkers with serious mental illness, or SMI. Families are the ones there before, during, and after mental health crises and episodes. When given proper tools and adequate support, families can intervene and improve mental health conditions for peers. Academic research of family interventions broadly and of NAMI's evidence-based programs specifically point to these results. When a family member is actively involved, emergency room visits and psychiatric hospitalizations decrease, and there is greater engagement with community-based mental health care. NAMI NYC, again, is the only nonprofit providing these direct and extensive supports to family members. For this reason, our organization is respectfully requesting that the City Council follow through on its commitment towards family and peer support services by making a $250,000 investment in our one-of-a-kind, evidence-based Care for Mental Health Caregivers program, which is critical to helping New Yorkers affected by mental illness. This modest funding request will also remove the burden from city agencies to implement new programs with the same end goal as the programs NAMI NYC has already provided for over 40 decades, free of charge, irrespective of insurance or immigration status. Thank you for the opportunity to testify and appreciate your support. Thank you.
Thank you.
Sorry. All right. Good afternoon. Thank you, Chair Brandon, members of the New York City Council, for the opportunity to be here. My name is Greg Mihailovich. I'm the Community Advocacy Director for the American Heart Association here in New York City. So for the last 100 years, our organization has been dedicated to fighting heart disease and stroke, which approximately 80% of diagnoses are preventable. Unfortunately, heart disease and stroke continue to be our city's leading cause of death and disability. High blood pressure or hypertension is a key risk factor to heart disease and stroke, and more than 2 million New Yorkers report having high blood pressure, but less than half of those diagnosed actually have them under control. So self-monitoring, self-measured blood pressure monitoring, which is the regular measurement of blood pressure by the patient outside of the clinical setting, is actually a validated approach to managing hypertension and is associated with lower blood pressure and improved blood pressure control. That's because often the measurements in the clinical setting differ from at home. It can be higher, which is white coat hypertension, or lower mask hypertension. So getting these like improper measurements out of the system really help address that. Barriers, of course, are financial. Patient out-of-pocket costs, lack of reimbursement, lack of insurance coverage for devices. Now, New York City, the council's all over this. Last year, the council passed legislation that, subject to appropriation, the New York City Department of Health and Mental Hygiene has the support making at-home blood pressure monitors available at no cost to the public in 5 high-need areas. The highest incidence of hypertension, which probably won't be shocking, tend to be lower income, non-white communities that need help managing their blood pressure. So New York City, if they really want to make an impact here, they need to make an investment. The recommended amount that Department of Health is $1 million to support the self-monitoring blood pressure programs for Department of Health. And we're hoping that in a difficult budget negotiation that we can find that funding this year. Thank you.
Thank you.
Good afternoon. My name is Janine Mendez. I'm the Senior Director of Strategic Initiatives and Government Relations at Astor Services. Astor Services is a mental and behavioral health agency that serves over 4,500 children and families in the Bronx annually. For far too long, the mental and behavioral wellness of our most vulnerable New Yorkers has fallen through the cracks. Social and emotional learning has been prioritized instead of embedded in the core educational values. It is no secret that we are facing a mental health crisis that continues to grow and affect our most vulnerable New Yorkers daily. Mental health challenges are the leading cause of disability among youth, according to the U.S. Department of Health and Human Services. Nationwide, 1 out of every 5 children between the ages of 3 and 17 suffer from a mental, emotional, developmental, or behavioral health disorder. In the decade before COVID struck, feelings of sadness among youth increased 40%, while suicidal behaviors increased 57%. As the pandemic exacerbated the conditions leading to these rates, the U.S. Surgeon General issued an advisory about the crisis. U.S. Surgeon General Dr. Vivek Murthy has clearly stated that the future well-being of our country depends on how we support and invest in the next generation. As we now face a new pandemic of inadequate mental and behavioral health supports for our New York City residents, that investment needs to start today with ensuring that our human and social service workforces are equipped to manage the current needs that exist when it comes to the capacity and access to care. Today, I want to speak to you about our Astor's Trauma Recovery Center. It serves as a community hub to support victims of violent crime with clear referral pathways from local hospitals, legal defense services, law enforcement, and other community pathways. We have been fortunate enough to receive funding from the Speaker's Office and the City Council the past 2 years to establish and kickstart the program, but the funding is in danger of being cut. Astor's TRC is one of 3 in the city of New York and the only one in the Bronx, and lack of continued funding can be detrimental to the communities and families we serve. The program is crucial to addressing the current gaps in support services when it comes to mental health disparities, and lack of support will result in people not accessing services in a timely fashion. Decrease in funding will also make it difficult for us to hire qualified, licensed professionals to provide trauma-based therapies, as well as clinical and case management services. Continued support would allow us to hire and contract with medical providers who offer psych evaluations and medication management. When we do not have these licensed professionals on hand, the wait time for these services in the community are astronomical, and a lack to access to trauma services in communities that are already lacking resources and services at a crucial time of need will only create a cycle of despair and continued trauma. We're all aware of the unprecedented challenges ahead, but considering the exacerbating mental health challenges facing our communities, we remain optimistic that you will partner with us in this journey to recognizing how imperative it is for us to secure crucial mental health funding.
Thank you very much.
Good afternoon, Chair Brannon and members of the committees. Thank you for the opportunity to testify today. My name is Dash Yates-Lonsky. I'm a policy analyst at Urban Pathways, a nonprofit homeless services and supportive housing provider serving over 2,000 single adults annually. Chair Narcisse. First, thank you for including the $6.4 million increase to the Justice Involved Supportive Housing Program, JISH, in the Council's budget response. JISH, contracted by DOHMH, is the only designated supportive housing program for people leaving Rikers who are living with a serious mental illness or substance use disorder. We are one of 3 providers of this program. The funding increase that you included would raise the service rates such that the expansion of the program envisioned 5 years ago in the 2019 RFP could finally actually happen. This program cuts recidivism in half, it keeps people housed, and in the long run, it will save the city money that you don't have to spend later keeping people in shelter and jail. The problem is that, as you know, this increase was not included in the executive budget. Please fight to get this into the final budget, it's important. Second, thank you for including in your budget response the increase in service rates for NYC 1515 supportive housing and scattered site. 1515 has only awarded 17% of scattered site allocation compared to 80% of congregate, so that would fix it if, again, it's in the final budget. Third, the Be Heard program is the main alternative to police for mental health crisis response. We call on the city to restore the pegs to the Be Heard program and to create a training program for peers, people with lived experience, to allow them to fill the mental health worker role on Be Heard teams. Fourth, we are alarmed to see a steep cut to MOX in the fiscal year 25 executive budget. As it is, nonprofits contracted by the city are still not getting paid on time, and this would make the problem worse. Finally, source of income discrimination is the biggest challenge that people served by Urban Pathways face when searching for an apartment. We appreciate the City Council's proposed $4.4 million increase to the City Commission on Human Rights to protect the rights of voucher holders. Thank you.
Thank you.
Good afternoon. My name is Alice Buffkin. I'm the Associate Executive Director of Policy at Citizens Committee for Children, a multi-issue children's advocacy organization. Thank you for holding today's hearing. I'm going to focus my attention on youth mental health. I first want to express our gratitude to the City Council's staunch advocacy with the administration to ensure critical education programs are not lost as a result of expiring federal COVID-19 relief funding. Many of the restorations we saw in the executive budget will directly impact the mental and emotional health of students, including the $74 million for school social workers and psychologists and the $54 million for community schools. However, as we know, many vital mental health programs were also left behind. Chief among these is the Mental Health Continuum, which I know the City Council has also championed. This innovative model cannot be truly sustainable if the city continues to fund it 1 year at a time. This initiative must be restored and baselined to fully reach the high-need schools it's targeting. We were also deeply disappointed that restorative justice funding was not restored. Restorative practices correlate with improved academic outcomes, school climate, and staff-student relationships. Additionally, I want to uplift our strong support for the full funding of the City Council's mental health initiatives, many of which you've heard from providers about today. These initiatives have always been a crucial backbone of community-based behavioral health in the city, offering targeted but flexible services that can adapt to the needs of communities. Unfortunately, these initiatives experienced a cut of nearly $1 million in last year's budget. Those cuts impacted initiatives like Children Under 5, autism awareness, and mental health services for vulnerable populations. We're due to restore and maintain funds for all of these critically important programs. Finally, I want to underscore what we hear time and time again when we speak to young people about what would help improve their mental health and that of their families. They talk about third spaces outside of home at school where they can find resources in community, like libraries. They talk about the importance of out-of-school programming, like Compass After School, and they talk about the mental strain they feel when their family is struggling financially, unable to afford essential services like childcare. All of these programs are on the chopping block in this budget. I want to uplift how urgent it is that this budget fund the types of resources and supports that are not in the mental health budget, but undeniably strengthen the mental health and overall well-being of families. Thank you for your time and consideration today.
Thank you all very much for your testimony. Oh, I'm sorry.
It's okay. I came a little bit late, so.
No, it's all good.
Sorry. Thank you.
Sure.
Thank you for the opportunity to testify. My name is Judy Wessler, and I'm a board member of the Commission on the Public Health System, also the retired director of the organization. I'm here today to urge City Council to include $4 million for Access Health New York City in the FY 2025 budget. CPHS, one of the original organizers of Access Health, has been actively involved in developing resources and providing training on healthcare and the healthcare system to support the involved community organizations acting to empower their communities. Access Health NYC is a citywide initiative that enables community-based organizations across New York City to provide education, outreach, and assistance to all New Yorkers about how to access health care and coverage. Access Health fills an information gap and provides critical outreach and education to hard-to-reach populations across New York City who are uninsured, who are undocumented, who have limited English proficiency, have disabilities, or LGBTQ+, and who are unhoused. CPHS was organized 31 plus years ago to support the public health and hospital system and fight for equitable access for everyone, regardless of their race, ethnicity, language spoken, disability, or ability to pay. Over the ensuing years, CPHS has worked with labor and community-based organizations to support that mission. These efforts were accomplished through organizing, research, writing, and advocacy to support the institutions and communities needing the support of legislation, litigation, organization, and writing services. I am going to sum up in a second. Let me just find the second page. Okay. Just that as long-term impacts and obvious racial and ethnic inequities of COVID-19 pandemic continues to challenge the community's health and economy, community-based organizations like ours continue to fill in the gaps for a strained healthcare and mental health care system. Given the influx of new arrivals in New York City, the demand for our services and support has spiked. Enhancing AHNYC can bring additional support for emerging health concerns and connect vulnerable communities, such as asylum seekers, to critical health information and referrals. Thank you again for this opportunity.
Thank you all very much for your testimony. Okay, now we're going to hear from Shannon Rocket, Daniel Levy, Guillermo Chalon, Karina Escamilla, Jane Ma, Emily Lee, Jonathan Sue, and Christina Reef. Thank you. Okay, you want to begin?
Good afternoon, Chairs Brannon, Narcisse, and Lee. My name is Shannon Rocket, and I'm here today on behalf of Carnegie Hall. We were very encouraged to see the speaker's inclusion of arts and culture and maternal and youth mental health initiatives among her priorities for the year ahead. The speaker's focus here calls out the essential services our city's cultural organizations provide. With the council's support, culture has been a highly effective resource to address many human services needs. For this reason and many more, I urge the council to restore the devastating cuts to culture that have been enacted this year and called for in the next year. As a member of the CIG, Carnegie Hall takes seriously its public service to our city's residents, and since 2011 has invested deeply in developing and evaluating evidence-based music and mental health programs. The Lullaby Project connects new parents and caregivers and their newborn babies with professional artists to compose original lullabies, meeting families where they are, in public hospitals, high schools, and other community centers. Evaluations of the Lullaby Project indicate that the creation, singing, and recording of personalized lullabies help parents to develop their self-confidence, well-being, creativity, and capacity to be loving, sensitive, and responsive caregivers, while also providing infants with the opportunity to experience new and soothing vocabulary, figurative language, and elegant phrases that are important to development and learning. Our Wellbeing Concert Series offers thoughtfully curated concerts that bring people together for an experience that builds connection and celebrates our shared humanity, regardless of socioeconomic circumstances or background. In addition to public concerts, a significant proportion of the program invites specific groups to attend without cost. These include healthcare workers, students, and clients of H&H and DOHMH, veterans invited through the New York State Department of Veterans Services and Black Veterans for Social Justice, individuals and families impacted by the justice system, and older adults. All of Carnegie Hall's social impact and early childhood programs are informed by a significant and growing evidence base that demonstrates how musical engagement can promote health and prevent illness across the lifespan. Please see our submitted testimony for more on our research-backed outcomes for these programs. Our impact and partnerships throughout the city demonstrate that investment in arts and culture is a compound investment in human services and our communities. Cuts to arts and culture, therefore, have a compound negative effect on our communities. Culture is not a budgetary indulgence. It is part of the solution. We urge the Council to prioritize and protect funding for arts and mental health programming in the year ahead. Thank you for your time.
Thank you.
Good afternoon. My name is Jonathan Suh, and I'm a project coordinator at Korean Community Services. I'm here today to urge the Council to include $4 million for Access Health NYC in the FY25 budget. First, I'd like to thank the Health Committee Chair Lynn Shulman and members of the Health Committee, as well as the Chair Linda Lee, for their commitment to making sure New Yorkers can access health care and for supporting Access Health NYC for over 9 years. Access Health NYC is an essential part of how we at KCS are able to assist individuals receive quality health care. CBOs like KCS are able to provide education, outreach, and assistance to individuals about healthcare and coverage through this citywide initiative. Through Access Health NYC, we have been able to increase health fairs, increase outreach, and perform presentations related to healthcare. We also increased our deliverable numbers from 200 in 2023 to 240 in the current year. But in spite of this, we have assisted 492 individuals with access to healthcare thus far. Considering these facts, it is clear that CBOs like KCS play a key role in helping low-income individuals receive quality healthcare. Since its foundation in 1973, KCS has been operating under the mission of helping Korean American population, as well as the wider immigrant communities in the areas of aging, education, immigration, public, and mental health. As a project coordinator at KCS, I help apply individuals for healthcare, resolve billing issues, and general case management. Ms. Pak is one of the many individuals whom I assisted this year. She was undocumented and came to KCS after hearing that we help undocumented individuals receive Medicaid. Many clients like Ms. Pak visit our organization through word of mouth and express immense gratitude and relief that organizations such as ours exist. The city's support for those like Ms. Pak is imperative, and we kindly ask that the city continue to support and fund our organization so that we can do our job in assisting these low-income individuals. Thank you for your time.
Thank you.
Good afternoon. My name is Emily Lee, and I'm a project coordinator at KCS Korean Community Services. First, I want to thank you all for the opportunity to share our story today. I also want to thank the Council and their commitment to health equity for all New Yorkers. Since 2014, KCS has been part of the HEP-Free New York City Coalition and assisted in hepatitis B prevention by offering free testing, education, and providing culturally competent patient navigation services. We mainly serve low-income Asian American immigrants with limited English proficiency, who are uninsured or underinsured. In the past 9 years, we have screened over 3,800 people and identified over 200 positive Hep B patients. Approximately 330,000 New York City residents are estimated to be infected with chronic hepatitis B and C. Given this statistic, it is crucial to address this largely overlooked health crisis. This past March, I assisted Mr. Singh, who is uninsured and undocumented. Due to his unique situation, KCS paid for Mr. Singh's medical appointment and his liver ultrasound. Mr. Singh was informed that he also needed an MRI scan of his liver. KCS helped to reduce the MRI cost to a more affordable price from $400 to $100. Thankfully, Mr. Singh's overall test results were good and he didn't need any treatment or medicine. He was really appreciative of our help. KCS requires the continued funding of the Viral Hepatitis Initiative to provide free hepatitis B screenings and streamline medical care access to our pro bono doctors. I kindly urge the Council to include a total of $4.4 million for the Viral Hepatitis Initiative to achieve the New York City viral hepatitis elimination goal of preventing liver cancer and disease by 2030. Secondly, KCS is seeking $85,000 for the Immigrant Health Initiative to lower tobacco use in the Korean community, where 22% of Korean American men and 16% of Korean American women smoke. So far in 2024, not only did KCS refer 13 smokers to Asian Smokers Quit Line, as well as the New York State Smokers Quit Line, we also provided nicotine replacement therapy to 23 clients. KCS also shipped one of our clients 4 weeks' worth of nicotine patches, a pack of nicotine gum, and a pack of nicotine lozenge at no cost. Community-based organizations such as KCS have a long-standing tie with the community members and are well-positioned to deliver much-needed services to the community. Thank you.
Thank you.
Hello, my name is Jane Min, and I'm here to represent Korean Community Services, KCS, and advocate for the continuation of the Building Resiliency and Advancing Vaccine Equity BRAVE program initiative. The BRAVE program is a project facilitated by the NYC Department of Health and Mental Hygiene in partnership with the Fund for Public Health in New York City. I appreciate the opportunity to share with you how the BRAVE program is impacting the lives of our community. I would like to start by thanking the members of the City Council for holding today's hearing. According to the Department of Health and Mental Health, COVID-19 has caused more than 200,000 hospitalizations and 45,000 deaths in New York City to date. Black and Latino people have experienced the highest rates of illness, hospitalization, and death. The COVID-19 pandemic has highlighted numerous injustices for historically marginalized groups in the U.S. According to the WHO, long COVID is defined as the continuation or development of new symptoms 3 months after the initial infection, with these symptoms lasting for at least 2 months with no other explanation. Nearly 1 in 5 American adults who have had COVID-19 are still experiencing symptoms related to long COVID. The goals of the BRAVE program is number 1, to reduce racial and ethnic disparities in COVID-19 and influenza immunization by expanding vaccine coverage, confidence, and access. Number 2, to raise long COVID community awareness and how it may impact health and well-being. The region we are targeting, the Long Island City area, is identified as a zip code having quote-unquote significant racial and economic disparities in health outcomes. In order to expand vaccine access and raise long COVID community awareness, we conduct street and community outreach within the Long Island City, Queens region. Our outreach work takes place in or near busy intersections, transportation hubs, commercial corridors, and public spaces, and consists of, but is not limited to, distributing printed educational materials, talking to people about getting vaccinated and tested for COVID-19, as well as connecting people to nearby testing and vaccination sites. We widely disseminate information on COVID-19 vaccines. We plan and implement in-person engagement events weekly, and we lead a community conversation every week to deepen understanding of vaccine fears, concerns, and increase knowledge of local vaccination locations and availability. We engage and provide one-on-one navigation services to individuals weekly to support vaccinations and appointments. As a result of our outreach, we found that the Long Island City region is desperately in need of navigation services directing residents to receive the COVID-19 vaccine and other services, including but not limited to behavioral health services, employment services, educational services, chronic disease services, healthcare services, and food and nutrition services. Our community engagement is grant funded and is an essential component to supporting New York City's efforts to fight COVID-19. We're asking for a continuation of the BRAVE grant to allow for greater vaccine access and coverage in the Long Island City region. Thank you.
Thank you.
Good afternoon, council members. My name is Christine, and I am a lifelong Staten Island resident. A decade ago, I experienced a crisis that led me to the Institute for Community Living, or ICL. The first day I met my social worker, Sharon, she told me that she would stay with me as long as I needed. Sharon is still with me today. That is the kind of support people like me can count on from ICL. I hope you will support them in their budget request. But I am here to talk about something bigger, the need for us to destigmatize mental health challenges. Many of us struggle in silence. That was the case for me. For years I would cry at work and nobody would ask me if I was okay. We need to have simple conversations with each other, to understand one another, and to acknowledge that people go through difficult times. This is Mental Health Awareness Month. ICL recently released a video to destigmatize mental health. I am featured in that video talking about my struggles. I hope you will watch it, share it, and spread the word about having conversations about mental health. I have cards with me with a QR code to the video, and you can also find it on ICL's YouTube channel. Thank you very much for your time.
Thank you.
Thank you. Thank you.
Good afternoon. My name is Daniel Leiva, Director of the Faith-Based Initiative of the Latino Commission on AIDS, and I'm here speaking also on behalf of Guillermo Chacon and Karina Escamilla, who were called earlier. I'm here to appeal for the restoration of funding to our faith-based programs delivered by the National Black Leadership Commission on Health and the Latino Commission on AIDS in order to meet the growing needs of the most impacted communities. Both programs focus on an integrated health approach on HIV education, stressing the importance of prevention, stigma reduction, technical assistance, and access to care opportunities for New Yorkers congregating in communities of faith and their social networks. Our programs have over the years, provided tools to access health services with a culturally sensitive approach in both Spanish and English to a population that, for many reasons, not always access healthcare services in traditional settings. Some of these services are underutilized because the lack of bridges between members of communities of faith and other communities and traditional healthcare providers. We truly meet members of our Black and Latino communities where they are, congregating in their faith communities on weekends and evenings. The New York City Department of Health and Mental Hygiene has been a very important partner for both organizations in these efforts. We will continue partnering with the Department of Health for as long as our resources allow it. Communities of faith are essential to the fabric of our city. New York City Council historically has supported the engagement of religious leaders in shaping a more healthy New York City. We have developed a unique model of engagement, and we hope that the New York City Department of Health and Mental Hygiene will reconsider the decision to terminate our contracts. The staff of the Department of Health are incredibly dedicated to working with us, and we pledge to continue this relationship. Let us remember that according to the latest HIV surveillance report of 2022, in New York City, 1,622 people were newly diagnosed with HIV, those who actually were tested, 43% among Black and 40% among Latinos and Latinas. We have a lot to do to end the HIV epidemic in our city and our nation, and prevention must take a central role in this effort. Thank you.
Thank you.
If I could just say a couple things. I just wanted to commend all of you for being here and all the work that you do in the community. Especially, I know Access Health is a huge program that we need to keep funding. And Christine, I hope that you were doing well today, as well as in the future with all the help of ICL. I know that they're a great group. So thank you all for being here.
Thank you. Thank you.
I just want to say thank you to the same thing. I'm going to piggyback on that. Thank you for sharing and willing to testify. Because one of the things I would say, being a registered nurse for so many decades, I know mental health is real and is stigmatized in a lot of community, is to the level of being taboo. And thank you for amazing folks that are doing amazing work in our city to address the inequities in healthcare. And of course, a bigger I had a big fight for HIV and AIDS, and now being a nurse, I was part of a team starting it and make sure that people's needs being addressed, whatever the disease may be, as a healthcare professional. So thank you.
I want to, can I chair or?
Yes, go ahead.
I want to thank you all for your testimony. I also want to point out that this morning, at this morning's hearing, I asked for somebody from the Department of Health and Mental Hygiene to be here, and there is a staff member here. So I just want to let you know who's listening to your testimony as well. So thank you.
Thank you. Thank you.
Thank you all very much.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you.
Okay, now we have Brianna McKinney, Victoria Graves Cade, Jordan Rosenthal, Michael Fasai, Anthony Feliciano, Joel Ballin Schwan, Raul Rivera. Okay, you want to begin? Go ahead. Just make sure your mic's on.
Is it on now? Yep.
Good.
Great. Thank you, Chair Schulman, Lee, Narcisse, Brandon, and committee members for the opportunity to testify today. My name is Brianna McKinney, and I'm the Chief Advancement Officer at Project Guardianship. I want to start by thanking these committees and the City Council at large for supporting Project Guardianship and access to critical guardianship services for New Yorkers. For the past 20 years, Project Guardianship has served as a court-appointed guardian for adults who need a surrogate decision maker. We do this work because our state guardianship system was designed for those who have family members to care for them or money to pay for private care. This leaves out a substantial and growing segment of New Yorkers who are poor, aging alone, and experiencing a loss of capacity. The majority of these folks live here in the 5 boroughs. According to the Office of Court Administration, 14% of guardianship petitions are filed by hospitals and another 25% by nursing homes. These filings occur largely in cases where a patient cannot consent to services or arrange the financial components of a safe discharge and where there's a lack of familial support. According to a report by the American Bar Association, mental illness is the reason for guardianship appointments in approximately 20% of cases. At Project Guardianship, this percentage is much higher, with approximately 60% of our 200 clients having diagnosed mental illnesses such as schizophrenia, bipolar disorder, or post-traumatic stress. Project Guardianship has developed a reputation for taking on the court's most complex cases. Often when a client comes into our care, they are not only dealing with health and mental health issues, they're also navigating a web of social systems, such as housing, public benefits, the legal system, and more. Our teams work quickly to help our clients find stability while simultaneously building strong relationships so that we can act in alignment with their wishes and values. We do everything in our power to help our clients remain in their homes and communities and to avoid institutional care. Unfortunately, Project Guardianship, like many nonprofit guardians across New York, is at capacity and cannot take any more additional appointments without additional funding. This poses a serious problem for judges who have come to rely on nonprofit guardians as more and more private attorneys have stepped away from the practice. We recently heard that on any given day, New York City judges in the guardianship parts are unable to find guardians for approximately half of the cases where guardians are needed. So what will happen to these New Yorkers who are experiencing a loss of capacity, who do not have family or friends to look out for them, and who do not have the financial means to pay for private care? We applaud the City Council for its commitment to finding comprehensive ways to address our city's mental health crisis, and as budget negotiations continue, we urge you to set aside resources for nonprofit guardianship. Thank you.
Thank you.
Good afternoon. My name is Anthony Feliciano, and thank you for the opportunity. I am the Vice President for our advocacy at Housing Works. I want to say also we're a founding member of the End AIDS New York Community Coalition, and we see that the mayor's budget cuts are going to do a major threat and endanger sustainment and acceleration of our New York City's progress in ending our HIV, our overdose, and our hepatitis C epidemics. We have Black and Latinos account for 83% of HIV diagnoses, newly ones. Now, that's obviously unacceptable. but we can do something about that. One is we need to sustain levels of funding at $9.4 million for the council's Ending the Epidemic initiative. The other, we need to restore $5.7 million in funding cuts to critical ETE, Ending the Epidemic, and DSS contracts. Right now, we're threatening to decimate our undetectable antiviral adherence program and a bunch of other HIV programs that are necessary with this if we don't allow this cut to happen. Other programs facing elimination is our Play Short Networks 2.0 program. It is the backbone of New York City's HIV prevention efforts and many others. The other, what we like to look at is authorize and expand overdose prevention centers. Right now, we have a governor who says a lot about overdoses, who's had a nephew that has unfortunately had passed from an overdose, but we don't see any movement in moving these centers. We would like the council to be able to support and fund at least 5 so we can cover the boroughs. The other aspect of this is to eliminate hepatitis C. We're asking for the increase of $5.4 million from the $2.4 million allocated by the council for this. We also want to increase sexual health clinics. We have 2 closed for too long time, one in Crown Heights and one in Park Slope. And obviously, we talked about mental health. We have to prioritize care, not criminalization, of New Yorkers with mental health needs. And the way we do that is we end the street and subway streets of coercive involuntary removals, and we talk about community-based care and the end of NYPD's co-response with mental health professionals. Our health and hospitals share the most lion's share of psychiatric beds. And we support having more bedding, but we need to have more community-based mental health, culturally competent linguistically, and funding. And so we need to reverse some of these funding and bring it into those communities. Thank you.
Thank you.
Hello, my name is Joelle Balamchwan. I'm with the Supportive Housing Network of New York. Thank you for the opportunity to testify today. First, we would like to thank the Council for supporting the network's NYC 1515 reallocation proposal by signing on to the Dear Colleague letter circulated by Mental Health Chair Linda Lee. Thank you, Chair Lee. NYC 1515 is the primary mechanism for supportive housing development in the city, and it's failing to meet its target. This means that critical units are not being brought online that could house New Yorkers in need. Our proposal also seeks to expand NYC 1515 eligibility to include those exiting institutional settings and survivors of domestic violence. Next, we want to thank the Council and the Administration for the Human Services Sector COLA. The proposed 3-year, 3% wage increase will help these essential workers support themselves and their families as they continue to provide critical service to some of New Yorkers' most vulnerable residents. However, the city must ensure that the nonprofits that employ these workers are paid on time. Nonprofits are under significant financial strain due to the city's failure to reimburse them for contractually mandated services in a timely manner. Some providers are still awaiting payment for services provided in 2018 with millions of dollars in arrears. As proposed, the executive budget significant cuts to the Mayor's Office of Contract Services would exacerbate this already untenable situation. So we urge the Council and the Administration to restore funds to personnel and non-personnel services to avert further harm. Thank you also to the Council for including $6.4 million to expand the Justice-Involved Supportive Housing Program in your preliminary budget response. Please stand strong in final budget negotiations to ensure increased access to supportive housing for individuals leaving jail or prison. The network is also a proud member of Correct Crisis Intervention Today, CCIT NYC, a coalition advocating for a peer-led, non-police mental health crisis response system. The current pilot program, Be Heard, omits peers. We ask that the Council adopt best practices of CCIT NYC's model and focus on placing trained peers on Be Heard response teams, as well as fully restoring prior Be Heard cuts. With the recent tragic killing of Win Rosario, we must say enough is enough and fully invest in and build out a true peer-led mental health crisis response program in our city. Thank you so much.
Thank you.
Hi, thank you, and my name is Jordan Rosenthal. I just want to say thank you to everyone, all the chairs for sitting here and listening to all this testimony, and everyone in the audience, including the DOHMH person. And part of my testimony is really atypical for me. I'm known for going off script, and I actually surveyed our membership because a lot of people don't want to come to these hearings because they're so arduous. So my testimony today is really from the voices of those community members. When asked what types of mental health programming the city should invest in the next calendar year, our community called for more peers, non-police mental health crisis response, and neighborhood centers that are, and this is a direct quote, welcoming when compared to the faceless, intimidating mental health factory-style mills that seem to be more profit, aka Medicaid billable driven. I did not write that. Someone in our community did. All participants' answers focused on the impact of a genuine connection that can make for someone in a distressing situation. One response even cited Win Rosario and how he had called for 911 help himself and ended up dying in front of his own mother. Our community feels that the city doesn't care about them when mental health programming is cut. One participant noted that funding cuts are short-sighted and will cost the city more money in the long run. Instead, they want more investments in social services and supportive housing. When prompted about the connection between supportive housing and mental health, individuals called access to supportive housing life-changing. And one member said, "Supportive housing literally saved my life. Continuing programming and opportunities have made life bright. I am optimistic now." Another person discussed how they were able to actually succeed in a program because they had housing and what a difference that makes to one's mental health. Which brings me to the boring number things. So again, swapping social workers for peers on Be Heard. I wish I could give you a cost, but as we heard from DOHMH and groups earlier, it is a big mess. So if you guys could investigate, that would be great. Restoring PEG cuts, accelerating access to supportive housing, allocating the $6 million that was approved last year for 2025 for crisis respite centers, and continued investment in IMT teams. Thank you.
Thank you.
Thank you, Chairman Schulman, Narcisse, Brennan, and Lee, and other esteemed council members for the opportunity to testify. My name is Victoria Graves Cade, and I'm a peer educator at GMHC's HIV Prevention and Literacy for Older Adults program, or HLA as short. I'm here to ask you to restore funding for 3 contracts that will be cut because of the mayor's January PEGs. The Department of Health and Mental Services contracts are the Undetectables and HIV Treatment Adherence Program, funded at $515,000 per year, and HLA funded at $242,782 per year. The HRA contract is for our RISE Workforce Development Program, funded at $401,725 a year. The loss of these 3 contracts, which employ 13 GMHC staff, will total nearly $1.1 million. Last week, GMHC testified at the General Welfare Committee hearing in support of RISE, so my testimony focuses on DOH-MH contracts. Founded in 1982 as Gay Men's Health Crisis, the world's first HIV and AIDS services organization, GMHC provides comprehensive services to over 5,500 New Yorkers living with and affected by HIV and AIDS every year, and 45% of them are age 50 and over. When I talk about my work in HLA, I proudly share that I am an example of it. I am an African-American heterosexual woman, age 65, that has been living with HIV for 29 years. I am living proof that with education, connection to my community, and medical care, older New Yorkers can not only live long and healthy lives with HIV, but also prevent transmission by having undetectable viral loads. Our clients and community need peers to see, to fight HIV stigma and ageism. This is why HLA hires peers who provide information to older New Yorkers, regardless of HIV status, about HIV prevention, testing, safer sex practices, and talking to their doctor about sexual activity. According to the latest HIV surveillance data, 35% of all people in New York City living with HIV were age 50 and over, the largest of any demographic age range. In 2023, HLA served 743 participants through 34 activities, which included workshops, webinars on topics included HIV stigma, intimate partner violence in HIV, substance use, harm reduction and recovery, as well as capacity building trainings, partner engagement meetings. Our theme this year for our HIV conference Our HIV and Aging Conference on June 14th at NAMI is thriving as our whole selves, a celebration of aging well for people living with HIV. Conference attendees will include senior services providers and practitioners from throughout New York City. Let me add by saying, please stand with GMHC and all the clients in this need to serve, advocating for full restoration of these HLA, undetectable, and RISE contracts, and also to save lives, along with 13 GMHC staff jobs, including mine. Opportunity. Thank you.
Thank you all very much. Okay, now we have Scott Daly, Diane Titer, Ayanna Perkins, Erica Silberman, Alex Brass, Laura Jean Hawkins, Anna KRL, go ahead, Scott.
Good afternoon, Chair Brannan, members of the committee. My name is Scott Daly. I'm the Senior Director of the New York Junior Tennis and Learning, New York Junior Tennis League, commonly known as NYJTL. I want to thank the Council for its support over all the last number of years that they have given to NYJTL and the kids of the City of New York. We are here to ask for an increase in fiscal 25 budget for NYJTL. For 16 years, we have been receiving $800,000 from the council. We're asking for a $200,000 increase. Costs, as we all know, have risen dramatically. We are now challenged with the fact that despite all these costs, we want to prevent cutting the programs that we give to these children. And we also want to give a living wage to our staff. NYJTL is vital to the city. Increased funding to NYJTL is vital this year. You know, rather than giving you all the facts and figures and the data and the metrics, and we put it in the report for you, I am a firm believer that not everything can be measured. You can't measure the smile on a kid's face when you see them out there because of the city funding that we get from the council. We are grateful. We are all in all 5 boroughs throughout the city. We truly believe that kids must be allowed to be kids. We give the kids the opportunity to come out and try a game that they would otherwise never participate in. Needless to say, tennis and the physical fitness aspects of it are indisputable. We serve over 90,000 kids citywide each year. Let me repeat that, 90,000 kids. 80% are Black, Latino, or African American, Asian. 70% are 10 years old or younger. We were there for the kids during the pandemic. We opened up programming in August of 2020. We now need these kids to be able to be continued because of the council funding. We need you to increase the funding in the fiscal 25-year budget. With your support, we can continue to change the lives of thousands of kids and their families. Thank you very much for your time.
Thank you.
Thank you, Chair Narcisse and Chair Schulman. My name is Alex Brass. I'm a proud member of CCIT NYC Steering Committee, otherwise known as Correct Crisis Intervention Today, as well as Chief Dope Officer of my own organization, It Ain't Dope NYC. I identify as a peer in recovery. In January of 2022, I experienced a mental health crisis, police response, and forced hospitalization, which brought immense shame and depletion of my confidence, exacerbating my mental health and substance abuse issues, and has been a long road to recovery, almost resulting in me losing my life when I snorted $2 of fentanyl in my bathroom on August 17, 2023. Thankfully, a friend was in the other room who called 911. It took 2 hits of Narcan to revive me. Issues of mental health and substance use disorder must be viewed both individually and together, as co-occurring disorders is quite common, with substance abuse playing a major role in my psychotic breakdown and my police response and hospitalization further fueling my substance abuse. Regarding mental health crisis response, CCIT NYC has been advocating for changes within the Be Heard program and a move away from the police response model. This year, all we are requesting is a swap in peers instead of social workers and restoring peg cuts. The recent tragedy of Wynn Rosario highlights why we need change immediately. In regards to the overdose crisis, we lose 1 New Yorker every 3 hours. We must meet people where they are and eliminate stigma and shame so people do not feel like they need to use substances alone, like I did in a bathroom. The overdose prevention sites have saved over 1,700 lives since they have gone into effect. Our drug supply is so toxic that clean heroin in New York City now means it just has fentanyl and does not contain tranquilizer. We must put pressure on state government to expand OPCs to 5 programs, as the mayor's plans have indicated, as well as further fund and expand the amazing drug checking services that have been piloted in 5 syringe exchange programs. There's a bill to protect drug checking services that is currently stuck on the Assembly Committee and the state floor. The solutions appears in mental health crisis response and expansion of OPCs and drug checking services reduce stigma and shame and avoid unnecessary trauma and saves lives. Let's work together to expand and implement these solutions to protect our most vulnerable New Yorkers. Thank you.
Thank you. Good afternoon. My name is Anna Krill. I am a 2-time breast cancer survivor and the founder and president of Sharing and Caring. Thank you all for the Council's longstanding support of our work through the Cancer Services Initiative. With the city's finance in much better shape than expected in January, I am here to ask that you support our FY25 funding of request of $200,000. Given the current state of inflation and decision by the New York State Department of Health to no longer provide Article 6 matching funds to CBOs under the Cancer Services Initiative, it is becoming increasingly challenging for us to continue assisting those living and coping with cancer. Council's citywide funding is a vital part of our operating budget, allowing us to assist cancer survivors, including those currently in treatment, and in a significant and meaningful way. Our funding, as well as the funding of the Cancer Services Initiative, has never been increased. The need for services, however, has grown significantly each year, especially since the pandemic and as more and more young people are being diagnosed with cancer. Since 2020, the demand for our services, specifically counseling and emergent needs, has increased by 25% and shows no sign of slowing down. 30 years ago, Sharing and Caring was told that it would fail. With hard work, dedication, volunteers, and dedicated board members, we are still today here to advocate for all those who are diagnosed with cancer. We are a one-stop, grassroots, community-based organization which provides free bilingual supportive services to cancer survivors, their families, caregivers, and community members. Please help us to continue to assist cancer survivors and their families by supporting our funding request. Thank you. Thank you.
Good afternoon. My name is Laura Jean Hawkins, and I serve as the Advisory Board Chair of Sharing and Caring. I appear today as a woman who has been an ally for and an advocate on behalf of the cancer community. When I testified before you at the preliminary budget hearings, I shared my story and told you that I was waiting on my own biopsy results. I'm happy to update you. The results were benign, but I still have to be monitored, and there may be surgery in my future, but for right now, I'm okay. And I share that because that's one of the stories that Anna and her team at Sharing and Caring hear every day. It could be the community member waiting on test results like myself. It could be the newly diagnosed in need of counseling and support. It could mean someone living with cancer who needs emergency financial assistance, or the community member who needs accessible and culturally relevant and lingually accessible information about cancer and health and wellness. That's what Sharing and Caring does every day with the support of the New York City Council. My fellow board members and I are so grateful for the council's support under the Cancer Services Initiative. But as the board chair and their pro bono lobbyist, I know how hard it is to raise money for boots on the ground community-based organization. All the foundations and private grants out there, for the most part, are for cancer research, not for supportive services, yet supportive services is what is most in need. So that's why public money is so important. As Anna said, funding to the Cancer Services Initiative has not been increased since the initiative was created. We speak from our experience, but I'm sure all the groups funded under that initiative would echo our sentiments. More funding is needed. The need is out there in the community. There is an epidemic of young people, meaning 50 and under, getting diagnosed for cancer. So please continue your support on behalf of our ask of $200,000 and for increased funding of the initiative. Thank you.
Thank you.
Good evening, and thank you everyone for your stamina. My name is Diane Titer. I'm the Director of Prevention at Mount Sinai's Institute for Advanced Medicine, our sexual and reproductive health and HIV clinics. I'm here today to represent a broad coalition of community-based healthcare agencies funded by the New York City Department of Health via city tax levy under the PlaySure Network 2.0, which includes Exponents, Housing Works, Montefiore Medical Center, Mount Sinai Hospital, Planned Parenthood of Greater New York, and SUNY Downstate, among others. We're grateful for the opportunity to submit testimony. The PlaySure Network 2.0 represents a majority of the clinical agencies funded by DOH to ensure that all New Yorkers, especially those from communities disproportionately impacted by HIV and AIDS, have access to a comprehensive health package of client-centered, high-quality HIV prevention and sexual health services, including outreach, testing, PrEP, mental health, substance use treatment and counseling, and other supportive services and referrals. Several weeks ago, our agencies were each informed that our contracts would receive a 15% reduction, over $80,000 each, in funding starting July 1st. We're deeply concerned that these cuts will not only hamper the critical, time-sensitive progress to ending the epidemic in New York City, but could reverse many of the gains we've already achieved. The PlaySure Network 2.0 began at the tail end of the COVID-19 pandemic, when lockdowns and major stressors on the public health system resulted in a significant increase in STIs in New York City. As New York City and its healthcare providers are still working to recover from these pandemic effects, it's not the time to deprioritize HIV prevention and treatment, but to continue building and investing in our critical programs, working to increase community trust and to ensure continued progress. Our agencies were informed that the cuts were driven by the PEGs initiated by the Adams administration in the last few months. However, as the Adams administration has already rolled back cuts to other select city agencies like the Department of Sanitation, the Department of Education, and NYPD, we strongly urge City Council to recognize the critical role that DOH and our agencies all play in the health and well-being of New Yorkers. In particular, please fully fund the DOH and PlaySure Network 2.0 to ensure that New York City can end our epidemic. Thank you for your consideration and support.
Thank you.
Good afternoon, Chair Narcisse, Chair Schulman, and esteemed members of the Council. I'm Erica Silberman, Director of Engagement and Partnerships for Girls Right Now, a writing and mentoring organization for girls and gender-expansive youth. We want to share our gratitude and appreciation for the City Council's continuous prioritization of investments in young people, specifically girls and gender-expansive youth. We're here today to talk about STAR's citywide girls initiative, of which Girls Right Now is a founding member, and to make the case for necessary mental health funding to support the core operations of our organizations. Both Girls Right Now and the STARS Network serve those most impacted by the mental health crisis. We have all been on the front lines working with girls and gender-expansive young women of color for decades. An already challenging situation has been exacerbated by the pandemic, racial and religious unrest, economic challenges, immigration, and more. According to a recent study from the CDC, 57% of teen girls experience significant sadness and hopelessness. 30% report seriously considering suicide, and 26% of young women ages 20 to 24 are diagnosed with depression and or anxiety. For LGBTQIA+ young adults, 52% report poor mental health, 42% have seriously considered attempting suicide in the past year, and 22% of them have attempted suicide in the past year. While there are no easy solutions to combat these grim statistics, Girls Right Now and the leading nonprofits we work with in STARS provide a proven antidote. All of our models are rooted in social emotional learning and speak to the potent and accessible solutions that the STARS organizations provide through multidisciplinary approaches, writing, art, sports, leadership, and more, supporting girls and gender-expansive youth's growth and resilience, emotionally, academically, and physically, so that they can be strong, skilled, and successful leaders. With increased funding, we could extend our wraparound services to include more direct and deep support for mental health, be it through curriculum, community experiences, professional and medical guidance, training, and more. We respectfully urge the City Council to make deeper and broader investments in this community, and would like the Council to not only fully restore funding for STARS citywide Girls Initiative, but to also enhance it. Thank you very much.
Thank you.
Good afternoon, Chair Narcisse, Chair Shulman, and members of the committee. My name is Ayana Perkins. I'm a Programs Fellow at Girls Right Now. As Erica shared, Girls Right Now is New York's first and only writing and mentoring organization for girls and gender-expansive youth from systemically underserved communities. Approximately 90% are of color, 70% are immigrants and first generation, and 25% are LGBTQIA+. We match them with professional writers and digital media makers as their personal mentors while providing them with unique, creative, and professional extracurricular experiences. As part of the STARS Citywide Girls Initiative, I've witnessed the power of the work that Girls Right Now and our partner organizations do in building confidence and self-worth, fostering civic engagement, and introducing healthy mental and physical habits, and making girls and gender-expansive youth feel seen and heard. At Girls Right Now, we also developed the Whole Leader, that's academically at the intersection of arts and social justice, professionally across all industries, and personally in a healing-centered space. We do this through a unique trifecta of one-to-one mentoring, rigorous creative, critical, and digital curriculum, and a tight-knit community to bolster all. I'll share briefly the story of one of our mentees, Dolores Hayes, who came to Girls Right Now as a high school junior at the recommendation of her English teacher and has been part of our community ever since. She tells the story of her time with us and speaks of being hit with an unlimited source of inspiration and how she learned not only what it means to mature in your writing, but develop as a person as well. She joined our Career 360 program, which she says turned into another moment for me to grow. I learned how to collaborate and look for ways to fully step into a more mature, self-assured person. Dolores has engaged in candid, vulnerable conversations with the Girls Right Now staff about her heavy transition from school to the real world with undiagnosed neurodivergence, her recent diagnosis of depression and ADHD while participating in our Career 360 program, gaining the support system she didn't realize she needed through Girls Right Now, and struggles with her medication, and reflecting on how her present is changed by this diagnosis while clarifying her past experiences. Her prep with our Career 360 program has prepared her to step into her new role as editorial intern at Girls Right Now. Her response, I swear I feel like crying just trying to express my gratitude. So like Erica, as a proud founding partner of the STARS Citywide Girls Initiative, we urge the City Council respectfully to make deeper investments into this community, and we would like the Council to not only fully restore funding for the STARS Citywide Girls Initiative, but also to enhance it. Thank you.
Thank you, and thank you for sharing, and thank you for the amazing work you're doing. We know about breast cancer. I knew you were gonna get it. Yeah. Thank you, because really, it's really a problem. And thank you for sharing your personal story, and for the work that you're doing. Thank you. You know, coming not only from a council member, healthcare is very, very important. And if we can focus on preventive care, we see the age are getting younger and younger. Mental health is real, and we have to take the stigma out. And thank you. Chair Schulman?
Thank you. So thank you, everybody. I know sharing and caring, it's something very near and dear to me. As a breast cancer survivor, I know the important work that you guys do. Also, in terms of the mental health piece, I just want to say that when Rosario was my constituent, and I was very forceful in terms of advocating on his behalf and the fact that the system failed him. So we're going to try to do what we can to figure some pieces out around that to make sure that that doesn't happen again. So thank you very much, all.
Elizabeth Fischetti, Stacy Keith, Esther Lilianer. If I butcher your name when you come, you can correct it. And Chris Norwood, Johnny Belly, Michael Fagan. I guess that's it. We may begin.
Thank you. Good afternoon, Chair Narcisse, Chair Schulman, and members of the committee. My name is Janae Billy, and I'm honored to serve as the Senior Director of Strategic Partnerships and External Affairs at PowerPlay NYC. Today, I'm here in a dual capacity to advocate on behalf of STAR CGI, Sports Training and Role Models of Success Citywide Girls Initiative, as well as PowerPlay. PowerPlay NYC, now in its 26th year, is dedicated to empowering 1,100 youth across all 5 boroughs of New York City. Our organization propels girls beyond their circumstances, providing access to experiences, strong female role models, and a blueprint for opportunities. We firmly believe that access to comprehensive mental health services is crucial for the well-being of girls and gender-expansive youth in NYC, where statistics show that approximately 1 in 5 individuals experience mental health challenges, and early intervention can significantly improve outcomes and quality of life. More importantly, PowerPlay serves as the lead agency for STAR CGI, a coalition of 10 NYC nonprofits. Together, we support the healthy development of over 6,000 girls and gender-expansive youth of color annually, and over 500,000 over the life of our grant. STAR CGI focuses on developing life and leadership skills through various programs such as after-school sports, academic enrichment, STEM, college preparation, and arts initiatives. In light of current challenges, STAR CGI is deeply committed to advancing the mental health and empowerment needs of our city's youth. We have witnessed a significant escalation in mental health needs, especially among young people of color, due to the recent tumultuous events. Recognizing this critical gap, STAR CGI has prioritized equipping young youth with strategies for social and emotional well-being while empowering them to speak out on societal issues. However, the sustainability of these vital programs is at risk without adequate funding. Our City Council funding of $1.4 million in FY24 has been instrumental in ensuring the accessibility of our initiative to those in need. I implore you to be steadfast advocates for STARS and support the restoration of our funding, and respectfully request that you consider an increase in funding if feasible within the budget. Thank you for allowing me to testify.
Thank you. Next. Thank you.
It's a buddy system here. Good afternoon. I'm Stacy Keith, a resident of Bay Ridge, Brooklyn, and proudly working in HIV prevention services in New York City since 2004. I currently work in Washington Heights with a team providing HIV care, treatment, prevention services to end AIDS, reduce stigma, and increase equitable access to health care for all New Yorkers. Our sexual health clinics provide thousands of New Yorkers every year with access to HIV, STI, hepatitis testing, treatment, vaccines, PEP, PrEP, Mpox, also addressing emotional health food insecurities, insurance needs, and education. We cannot have a funding reduction for any ending the HIV epidemic services. Council members, I urge you to stand strong and keep the commitment to end AIDS and restore all of this critical funding.
Thank you. I thought you came together. I was waiting to see how you start, and she just started it. I'm expecting you to start, but after I say, okay, you decided to make it. Oh, I see. All right, sir.
Good afternoon. Thank you, Chairs Narcisse and Schulman. I'm Michael Fagan, Chief of External and Government Affairs for Ryan Health. I'm advocating for an increase in city tax levy funding for New York City's 138 school-based health centers, including the 103 school-based health centers which currently do not receive operational funding from the city. Ryan Health is a mission-driven, federally qualified health center with 17 locations throughout Manhattan. 7 of those locations are school-based health centers. In them, in 2023, we saw nearly 2,400 students, resulting in over 7,200 encounters with them. The vast majority of them are low-income, and approximately 80% are young people of color. We do not charge children or their families for our services, and we treat any student who comes to us regardless of immigration or insurance status. The care that we deliver in the schools gets and keeps kids healthy so that they can stay in school and learn. Each of our centers is staffed by a nurse practitioner and licensed practical nurse, as well as a licensed clinical social worker. Having the physical and mental health located in the same center has been critical to getting students connected to mental health services, since the need for them are often discovered during a medical visit. For example, a 15-year-old student came into the center at the beginning of the school year for pain due to menstruation cramps. As a new patient, the nurse practitioner conducted annual mental health and health risk screenings. Those screenings revealed that she was living with depression and suicidal ideation that otherwise were unknown. The medical staff referred her to the social worker, and that student has been receiving weekly therapy from our provider. If our school-based health center had not been in this school, it raises serious doubts about whether this young person would have received the care that she needed and deserved. We operate our school-based health centers at a loss. In 2023, we lost $2.2 million from operations. As one of my colleagues in FQHC noted earlier, we are asking for $100,000 per school and $100 per pupil for all school-based health centers, including the 103 that currently do not receive operational support from the city. It's critical for us to be able to receive that funding to stabilize the financial health of our school-based health centers and grow services. Thank you for this opportunity, and I'd welcome anyone to come and visit one of our school-based health centers.
I sure will.
Very good.
Thank you for the work you're doing. Thank you, and I appreciate your time. Thank you so much. The next panel is Mera Ghosh, Myro Abbas Kauf, and Sultan Boka. If I say the name wrong, you just can't pronounce it properly for me. Thank you. Good afternoon. Put the mic on.
Okay, there we go. My name is Medha Ghosh, and I'm the Senior Health Policy Coordinator at CACF, the Coalition for Asian American Children and Families. Thank you so much to the chairs of each committee hosting this hearing. Founded in 1986, CACF is the nation's only pan-Asian children and families advocacy organization and leads the fight for improved and equitable policies, systems, funding, and services to support those in need. At CACF, we believe in an equitable healthcare system for all marginalized communities, which includes our Asian American Pacific Islander AAPI community, must be both culturally responsive and linguistically accessible. The AAPI population has the highest rate of linguistic isolation of any group here in New York City, as 46% have limited English proficiency, or LEP. Moreover, more than 2 in 3 AAPI seniors in New York City are LEP, and almost half of all immigrants in NYC are LEP. In response to this, CACF's campaign, Found in Language Access, aims to ensure that New Yorkers have equitable access to linguistically and culturally responsive healthcare services. Throughout our campaign, we have found that many LEP patients still report facing difficulties like being unable to find an interpreter that speaks their dialect or being unable to fill out paperwork because a translated version in their language does not exist. This can have detrimental consequences to their health and well-being. More than half of adverse events that occurred to LEP patients in U.S. hospitals were likely the result of communication errors, and nearly half of these events involved some form of physical harm. This is why it's imperative for the City Council to include $4 million in the FY 2025 budget for the Access Health NYC initiative, which fills an information gap and provides critical outreach and education to hard-to-reach populations across the city who are experiencing barriers to healthcare access and coverage. We also urge the City Council to expand student debt and loan forgiveness for healthcare workers so that more members of our communities can enter the workforce and provide the linguistically accessible and culturally responsive care we need. CACF believes safety is the presence of wellness and not just the absence of crime. As anti-Asian violence continues to persist in many forms, it is crucial for our community to have proper access to holistic, non-carceral mental health services. We would like to specifically uplift the social-emotional needs of AAPI young people in our public school system. Many stories have been collected from AAPI students as well as parents and CBO staff interacting with students through CACF's Youth Leadership Program, the Asian American Student Advocacy Project. These stories indicate that schools are neglecting to properly address AAPI student mental health needs across the city. We also ask the City Council to fully fund social workers in schools so that our students can access proper community-centered mental health care. We also urge the City Council to include $5 million for the mental health continuum. Thank you very much for your time.
Thank you.
Good afternoon. My name is Maral Abbas, and I'm the Health Partnerships Coordinator at the Coalition for Asian American Children and Families, or CACF. I'm here today to urge the Council to include $4 million for Access Health New York City in the fiscal year 2025 budget. With this addition, Access Health can initiate new community organizations and services to meet the growing needs of our most vulnerable communities. I'd like to thank the chairs hosting this meeting and for your extraordinary commitment to making sure New Yorkers can access the health services they need and for supporting Access Health New York City for over 9 years. Access Health New York City is a citywide initiative that supports 37 community-based organizations across all 5 boroughs of New York City and enables community organizations to provide education, outreach, referrals, and assistance to hard-to-reach populations around accessing vital health care. Access Health is led by 4 key agencies that train, evaluate, and provide guidance to awardees, and CACF is one of the leads. CACF, as mentioned, is one of the nation's only Pan-Asian children and families advocacy organizations. And every day we work with our 90-plus member organizations, youth and parent leaders, and community allies to push for systemic changes and vital resources to support New Yorkers that struggle the most. Access Health awardee organizations provide necessary language accessibility and culturally responsive resources and programs, and through regular evaluations conducted by CACF and the New York Immigration Coalition, awardees have identified pertinent issues that plague their communities. For example, over half of awardees report greater need for translation services amongst their clients, and overwhelmingly most have requested assistance with health insurance navigation. Recently, awardees were critical to the city's response to the COVID-19 pandemic at a time when the initiative received no increases in funding. Almost all organizations reported expending more resources than they had received from Access Health on staffing vital health outreach programs. Access Health organizations are vastly underfunded for the important work that they do. Over multiple years, Access Health New York City has provided critical services which are regularly delivered through local community members and on-the-ground institutions. These include cultural centers, food pantries, community fairs, mosques, churches, etc. And given this accessibility, reach, and delivery, these centers and their timely services contribute to instilling trust between awardees and their community members. And this trust is vital in the utilization of necessary resources for a population with limited healthcare accessibility, utilization, and literacy. Through their position, awardees uniquely recognize the needs and strengths of their individual communities. Therefore, investing in Access Health and their awardees is necessary to equitably and effectively reach said communities. More recently, through our fiscal year 2024 evaluation, we found that in the last year, over half of awardees report reaching 2,000 plus individuals, that they largely serve immigrant communities, women, and youth, and that 3/4 of our Access Health awardees already provide health outreach, education, and referral services to those seeking asylum in New York City. And current asylum seekers are very diverse, hailing from across the globe. And this is especially important because a lot of the API communities that we service are almost 80% immigrant and, as mentioned, face high levels of linguistic isolation. Enhancing Access Health New York City to $4 million ensures that the city can better target challenging health needs through trusted community-based support. This initiative provides an opportunity for New York City to effectively invest in equitably addressing the growing health needs of New York's most vulnerable populations. We therefore ask for an expansion of funding for Access Health to $4 million. Thank you very much for your time.
Thank you. And thank you so much. Thank you for being here to testify.
Thank you.
Now on Zoom, we have Dr. Nick. Oh, you had Michael. Sorry, my apology. First is Michael Zengun.
Your time is starting.
Go ahead, we're listening.
Hi, good afternoon. My name is Dr. Michael Zingman. I'm the Secretary Treasurer for CIR and a Child and Adolescent Psychiatry Fellow at Bellevue, NYU. In my almost 4 years at H&H as a psychiatrist, I've had the privilege to care for New Yorkers from all walks of life. And while it's a privilege, it's also a front row seat to the ways New Yorkers are being failed and slipping through the cracks as they cannot get access to life-saving services. I'm grateful to the Council for your advocacy for not only deeper investment in H&H, but also for real investment in supportive housing and social housing, both which are critical to my patients' health. Housing is healthcare, and we cannot expect to see improvements in health outcomes if we do not address the housing crisis in this city and understand that stable housing is central to all of our health. As a psychiatrist, I must also take this moment during Mental Health Awareness Month to advocate for the 2,300 H&H residents that have not seen a pay rise since March of 2020. Resident physicians experience burnout and depression at a rate 3 to 4 times higher than the general population. Suicide is the leading cause of death for male physicians and the second leading cause of death for female physicians. We are facing a physicians shortage nationally, and instead of our city caring for those of us who have dedicated our lives to caring for others, we're forced to work excessive hours for low pay to fill the staffing gaps in our hospitals. I know the Council understands the urgency of the city agreeing to a fair contract, as many of you joined with over 60 state and city electeds in a letter to the mayor supporting us. We've also been grateful to have the support of our colleagues in labor, including NISNA, DC 37, and UFT. We just need the mayor to listen to you and our labor brothers and sisters to finally agree to a fair contract. Thanks.
Thank you. The next is Dr. Nick Frazette.
Your time is starting.
Hi, good afternoon. I appreciate the opportunity to testify before the council. My name is Nicholas Frazzetti. I'm a PGY1 resident at Bellevue Hospital. Although I'm in my first year of residency, my history at Bellevue actually goes back almost 6 years now, as I was fortunate enough to complete my medical school training at Bellevue Hospital. I can recall back to the 2020, 2021, to the early days of the pandemic, where my mentors, my senior residents, were on the front lines facing an unknown, terrifying disease, and regularly sacrificing themselves, putting themselves on the line for the city of New York and for New Yorkers who would enter H&H hospitals. They were appropriately lauded at the time as healthcare heroes. But now, as Dr. Zingman mentioned, and as I'll build upon, residents in H&H hospitals have been working on an expired contract for 2 years and have not seen a raise since 2021, the height of that pandemic. The contract that the City Hall and Mayor Adams are offering right now is simply insufficient to meet the needs of residents. It will leave us as the lowest paid residents in New York City, even compared to our peers at private safety net hospitals. It really cheapens and hollows out the words healthcare hero when Mayor Adams is unable to quite literally put his money where his mouth is. And it's disheartening to me as someone who's been here for 6 years, and I reflect on the next 6 years of Bellevue and how we're going to be able to recruit future physicians to staff these halls when they see that this is the way that the city treats its H&H resident physicians. I would also point out that the pattern bargaining that the city applies to every other union, it's difficult to apply the same math to resident physicians. And while I respect our labor colleagues in other unions, residents, we work on salary regularly 60 or 80 hours a week where we don't qualify for overtime pay as salary employees. Because our training period is so short, we rarely are able to vest in the city pension. And yet the city continues to come to our bargaining sessions using these pattern
Your time is
maths that they
expired.
apply
Thank
to
you.
other bargaining units that simply don't apply to our unit. Thank you.
Thank you. Nia Notage.
Your time is starting.
Hi. I am speaking to you today as a member of ACT UP New York because the DOH public health clinics are in crisis. The Jamaica and Riverside COVID Express clinics were closed in the past 2 weeks, and the Morrisania clinic was closed 2 months ago, all without prior notice. The city's final COVID PCR clinic in Crown Heights is set to close by June. The reason that the clinic staff have been given for their closing is lack of attendance, but DOH has not advertised these clinics nor put out information on the importance of knowing your COVID status in years. But COVID continues to spread. This last month was the end of the JN1 variant surge, which brought the second highest COVID wastewater numbers since the pandemic started in 2020. This gap in education and connection to services is a total public health failure, and many long COVID clinics won't take patients that don't have a positive PCR as proof of infection. The city's free COVID rapid test program in libraries was also cut this year. We're still in an HIV epidemic. New Yorkers are still contracting HIV/AIDS, and we need consistent access to resources of counseling, maintenance, and prevention. Mpox cases have begun to rise again in NYC, and yet the city's STI clinics are overflowing. Patients have to wait all day and sometimes don't get seen. They're also only open from 8:30 to 3:30 weekdays, meaning that school-age teens and people who work a 9 to 5 have no chance of catching them. These clinics are overwhelmed with patients, while some sites like the Crown Heights and Riverside sexual health clinics have remained empty due to lack of funding for staff for years. Medication abortion pills aren't offered at all clinics, making them completely unavailable in certain boroughs. We need funding for permanent free STI, COVID, and abortion services in this city with multiple sites in each borough and weekend service, fully staffed. These are the only clinics that people can go to for free without insurance. Summer is coming, and STI numbers, undesired pregnancy, and COVID will only continue to rise, especially for those who need these services most and can't test for them or get treated. Thank you.
Thank you. Arlene Cruz.
Your time is starting.
Hi, my name is Luisa, and I'm actually going to be presenting on behalf of Arlene. She was unable to make it today. So thank you so much. Give me a second. My name is Luisa Cuautle, and I'm a health campaigns associate at Make the Road New York. Make the Road has served New York's immigrant and working class families for over 25 years and has a membership of 20,000 people. We connect about 9,000 people per year to health services as a part of our wraparound services for 30,000 low-income and immigrant New Yorkers per year. We ask the council to use every available tool to reverse budget cuts to DOHMH and New York City Health and Hospitals that would harm vital services for the thousands of working class and immigrant New Yorkers we serve. Any cuts to health and hospitals could impact healthcare access for our community members, most whom are ineligible for health insurance, thus reducing the number of available care facilities for them. Our Make the Road services impacted by the cuts include SNAP and health insurance benefit outreach, enrollment and navigation through community health worker services, TGNCIQ health access services. Make the Road relies on the funding initiatives named below to provide these services to immigrant communities in New York City. We request the council support in maintaining or expanding the following programs to help us meet the urgent needs in FY25. Increase overall funding for the MCAP initiative to $2.3 million with an increase of $76,218 for Make the Road. We provide culturally competent assistance to the lowest income uninsured New Yorkers on how to enroll and use health care coverage. This increase would strengthen MCAP capacity in Brooklyn through our proven provider. Increase overall funding for Access Health Initiative to $4 million and renew $110,000 to Make the Road for peer-to-peer outreach and public education on healthcare access and coverage, particularly for the and underinsured for all immigration statuses who the city otherwise struggles to reach. renew funding for $75,000 to make the road under the Ending the Epidemic Initiative to support prevention, education, and outreach
Your
for
time
HIV.
has expired. Thank you.
Thank you.
Thank you. Next is Natalie Antoriano.
Your time is starting.
Good evening. Good evening. My name is Natalie Antoriano. I'm the Director of Policy and Advocacy at Care for the Homeless, or CFH. I'd like to thank the distinguished City Council committee chairs and members and staff for holding today's exec budget hearing and for your continued support in making the healthcare system responsive to the needs of the most vulnerable. CFH is an organization that provides healthcare and shelter services to people experiencing homelessness. We operate 25 FQHCs in all 5 boroughs, and the specific population that we serve is people experiencing homelessness or unstable housing in New York City. We also operate 4 shelters, 2 women's shelters, 1 men's shelter in East New York, and then a safe haven across the street from Lincoln Hospital in the Bronx. In 2023, we served over 10,000 unique clients. About 40% of those were uninsured. I'm here today to talk about the importance of supporting the health-focused initiatives and to urge the City Council to include $4 million for Access Health NYC in the FY25 budget. My colleagues have all shared information about the importance of the Access Health Initiative, which enables community-based organizations like Care for the Homeless to provide a variety of services with the goal of increasing healthcare access. At CFH, the Access Health Initiative allows us the opportunity to provide health insurance navigation services. Our eligibility and enrollment specialists help educate and enroll consumers into health insurance programs, as well as create linkages to our primary care and behavioral health services. In FY23, which is the last full funding cycle, we assisted over 2,000 individuals with health insurance inquiries, enrolled over 500 individuals in a health insurance plan, educated 1,500 folks on available behavioral health services, and linked 127 to behavioral health providers. And this funding cycle, we're well on our way to surpass those numbers. We also received discretionary funding from Ending the Epidemic, mental health services for vulnerable populations, and HIV/AIDS faith-based initiatives, which fund our outreach services and has allowed us to further scale our the number of people that we engage in healthcare access. The outreach is conducted in the locations that we're in, so in shelters, soup kitchens, drop-in centers, safe havens, and in partnership with a lot of neighboring community organizations. The outreach team also facilitates access to health education.
Thank you for your testimony. Your time has expired.
Last year, we served about 4,400 individuals and connected about 1,300 to comprehensive medical services. So just to wrap it up, it's really important for us to be able to have access to these services or to these funds that come from a lot of the initiatives of City Council, and specifically from Access Health, asking for $4 million for that initiative specifically. Thanks so much for your time.
Thank you for your time. The next is Juan Penson.
Your time will begin.
Thank you, Chair Narcisse and Chair Lee and Schulman and Brennan. My name is Juan Pinzon. I'm the Director of Government Relations at the Community Service Society, and I'm testifying in support of the Managed Care Consumer Assistance Program, MACAP. MACAP helps New York City residents navigate our incredibly complex healthcare system. We do it through a free helpline and 11 community-based organizations that provide in-person services all across the city. This is an initiative that is an invaluable resource for people who struggle accessing care because either they don't understand how their insurance works, or maybe because of financial barriers, or simply because their health insurance denies the care that they need. We do this actually in a very cost-effective way. With less than $1 million, we're able to help thousands of people every year. Since 2020, we have assisted approximately 14,000 clients, saving them $800,000 in healthcare-related costs in the process. But clearly, we could do a lot more with additional funding, especially now that so many people are losing their Medicaid coverage following the end of the federal continuous coverage policy. In fact, in New York, 1.4 million people enrolled in Medicaid have lost their insurance in the past year. 45% of those who lost coverage did so because of administrative burdens and not because they were ineligible for the program. Because of this end of this policy, our program has seen a 72% increase in cases where people enroll in public health insurance, which is actually 50% of all of our clients needed assistance renewing their coverage or troubleshooting related problems. Fortunately, instead of expanding services during this critical time, our CBO network has actually shrunken. In FY24, we lost funding. We went from $1 million to approximately $953,000, resulting in the reduction of our network from 12 to 11 CBOs.
Thank you for your
Ideally, we would
testimony. Your
like to
time
see
has expired.
funding for MACAP increasing to $2.5 million. If this is unfeasible, we would like the council to, at a minimum, to restore the funding that we lost in F21 or strengthen the capacity of two community-based organizations, Make the Road New York and Queens JCC Community Council. Make the Road already talk about their allocation requests. For Queens JCC, they are not presently in our network, but a $64,000 allocation would allow them to join the initiative and connect their communities in Queens to healthcare resources. And finally, I just want to say that we are also CSS is also part of the Access Health NYC initiative, and we also support a $4 million allocation for Access Health in FY25. Thank you so much.
Can you repeat the statistic, the number of how many people lost their insurance that had it?
Yeah, this is according to the Kaiser Family Foundation. They have data that they update regularly, and for the last data that they provide, apparently 1.4 million New Yorkers lost their Medicaid.
That had the Medicaid and lost the Medicaid.
Correct. Some of them, I'm thinking that they were probably able to reinstate their coverage after they met with, like a navigator. But that's a huge number. And what happens is that when
that's huge. That's what I'm asking.
Yeah, and when that happens, people experience gaps in coverage. They end up with medical bills. So it's very unfortunate. And
Thank you.
This program would really help a lot of those people.
Thank you.
You're welcome.
Next is Paul Hennessy.
You may begin.
I am calling to urge NYC Council to support INT 033-2024. New Yorkers deserve free rapid tests and PPE. Let's lead the country in offering protection from viruses, smoke, and pollution, and 95 respirators and clean air should be free and available throughout New York. We've got COVID, TB, measles, and other airborne illnesses circulating, and now we've got H5N1 on the way. It's only a matter of time before it's here, so let's get ahead of it and protect New York. To all the council members who have admitted today about how they fought hard against HIV and AIDS, please educate yourselves on the similarities between COVID and HIV. COVID destroys T cells and damages the immune system, which leads to opportunistic infections and even cancer. Some previous in-person panelists mentioned vaccinations, but vaccinations do not prevent transmission or long-term effects. We need airborne protection, isolation guidelines, and continued masking, especially in public settings. We need expanded PCR tests and COVID clinics. We need to continue to focus on prevention. Every infection can lead to long-term illness. There were previous speakers in person who also spoke about education campaigns and vaccination, but they fell short and failed to mention the importance of clean air and masking. Over-reliance on the vaccine has left us with long-term effects. In fact, 3 years ago today, the CDC and Biden admitted that vaccinated people could safely stop wearing masks. But since then, over 750,000 people have died from COVID in the US, including many vaccinated people. Over 25 million now have long COVID. So yes, we need to keep masking. We also need clean air implementation in all indoor settings and public transit. Illinois is about to pass a clean air for healthy, equitable schools bill. So let's also do that for New York institutions such as schools, museums, venues, restaurants, and the subway system. Thank you.
Thank you. Next is Ash Howard.
You may begin.
Hi. I am Ash Howard, and I'm here asking for you to support Bill INT 0332-2024, a bill introduced by Councilmember Narcisse that will provide rapid tests, masks, and other personal protective equipment to New Yorkers. COVID is still a very real and serious issue affecting millions of New Yorkers, with at least hundreds of thousands coping with long COVID, along with several other airborne illnesses impacting health. Vaccines are a great safety measure, but they are not enough. We need layered protection, something that masking and the ability to test gives us. As a disabled individual with an immunocompromised mother that's starting chemo soon, it'll make our lives so much easier if everyone had easy access to these items. And I know we're not the only family that needs this bill to be passed. It would help the school attendance problem and aid in lessening the burden on healthcare workers. So many people would utilize these resources if they were made available to them. It benefit all New Yorkers to have more ways to be safe. I sincerely thank you for your time.
Thank you so much. Brennan Michael.
You may begin.
Brennan Michael Gucci. Are you on? Pallavi Subedi.
You may begin.
Hi, good evening. I'm so sorry. Good evening. My name is Pallavi Sabedi, and I am a health navigator at Adhikar. Adhikar, meaning Rights in Nepali, is a women-led community and worker center that provides direct services to the Nepali-speaking community and organizes low-income workers and impacted community members to promote social justice and human rights. At Adhikar, we define the Nepali-speaking community as descendants of Nepal, Bhutan, India, Burma, and Tibet that speak Nepali. We are often referred to as our community's 911 and 311 line, and I'm here today to urge the council to include $4 million budget for Access Health NYC in the fiscal year 2025 budget. I'd like to thank the Health Committee Chair, Lynn Coleman, and members of the Health Committee and all other chairs for their extraordinary commitment to making sure New Yorkers can access the health services they need and for supporting Access Health NYC for over 9 years. It is a citywide initiative that enables community organizations across NYC to provide education, outreach, and assistance to all New Yorkers about how to access healthcare and coverage. It fills an information gap and provides critical outreach and education to hard-to-reach populations across NYC who are experiencing barriers to healthcare access and coverage, such as those who are uninsured, who are undocumented, and have limited English proficiencies, that have disabilities, are LGBTQ+, and who are unhoused. Since 2005, Adhikar has been providing direct services to the Nepali-speaking community with an estimated 6,000 members and 15,000 Nepali-speaking community members every year on issues from worker rights, immigration rights, healthcare access, and language justice. Adhikar was able to hire its first culturally and linguistically competent health navigator in 2014, and till date, we have been able to support over 5,000 Nepali-speaking community members in getting their healthcare coverage. In 2020, we were in the epicenter of the first wave of the pandemic. Thousands of community members reached out to Adhikar seeking support, and to meet their urgent demands, we quickly transitioned our operations remotely and ran a robust COVID-19 community response that supported more than 10,000.
Thank you for your testimony. Your time has expired.
Summing it up, I would say that enhancing Access Health New York City can bring additional support for emerging health concerns and connect vulnerable communities such as asylum seekers to critical health information and referrals, and will ensure the city can better target challenging health needs through trusted community-based support like ours. Thank you.
Thank you. The next is Ashley Santiago Conrad.
You may begin.
Good evening.
Good evening. Good evening. We can hear you.
Sorry.
Go
Yeah.
on.
Good evening, Chair Narcisse, and good evening, Chair Schulman, and the committee members. Thank you so much for allowing me to testify today. My name is Ashley Santiago, and I'm testifying on behalf of Freedom Agenda as a community organizer and a member of the Campaigns to Close Rikers and a native New Yorker. For the past 31 years, I have watched neglected communities in this city plead for the resources we need to thrive. Yet our city continues to overly invest in systems of punishment like the Department of Correction instead of systems of healing and true rehabilitation. My 21-year-old nephew, Michael, who has been diagnosed with developmental disabilities, autism, and disruptive mood dysregulation disorder, sat on Rikers Island for 2.5 years in dire need of mental health care and healing. Instead of getting that care and treatment that could have addressed the root causes of his behavior and real mental health crisis that my nephew often experienced, they threw my nephew on Rikers Island for 2.5 years, where Correctional officers often label my nephew's mental health crises as tantrums because they are not trained to respond to his clinical needs. There are thousands of New Yorkers on Rikers right now who share the same experience. At a cost of over $500,000 to keep someone on Rikers for a year, New York City spent $1 million to keep Michael at Rikers. That's more money than the city ever invested in his well-being or my family. But despite all that money spent, he got no substantial rehabilitation. Coming from a low-income Latina neighborhood in Queens, it created a lot of barriers for adequate treatment. And without adequate treatment, his symptoms progressed and became severe, which led to interactions with law enforcement. But I know would have helped my nephew, community and healing, not Rikers. He needed intensive quality treatment. Instead, he got 2.5 years of torture before he was even convicted. If my family were rich and well-resourced, we would have been able to pay for the quality treatment and education that
Thank
he
you for your
needed.
testimony. Your time has expired.
Just to wrap up, in the written testimony that I will submit, there's a full budget analysis, but something that I would urge the council to really support in this 2025 executive budget is a separate line item for justice impacted supportive housing. Mental health cannot thrive if folks do not have a home to go through. As someone who is diagnosed with anxiety and depression, routine is very important. Additionally, $2.9 million to enable 5 of the 22 newly funded state assertive community treatment teams to operate as forensic fact teams. And additionally, ensure adequate funding to fully implement local law 119-2023 by establishing at least 5 new clubhouses. Thank you so much for your time. Thank you.
Understood. Thank you. Danny Lim.
You may begin.
Thank you, Chairs Brannon, Narcisse, Shulman, and Lee, and members of the committee for the council's longstanding support of New York Edge. With the city's finances in much better shape than expected in January, we asked the council increase our funding in FY25 budget. We are seeking $1.2 million under the council's after-school enrichment initiative, an increase of $200,000 over last year. This will be our first increase in 16 years. We are also seeking $250,000 under the council's social and emotional supports for students initiative. SEL is integrated into every element of our programming. Increased funding is vitally needed. Unlike contracts with DYCD and other agencies, council discretionary contracts are not eligible for full increases. This is making it increasingly difficult for New York Edge to attract and maintain quality staff and to continue to offer the wide array of programs that we are known for. We are the largest provider of free school-based after-school and summer programming in New York City, serving almost 30,000 students in over 100 schools in 37 of the 51 council districts of the 5 boroughs. Our mission is to help bridge the opportunity gap among students in underinvested communities. Our free summer programs will begin in early July, providing over 10,000 young New Yorkers with a summer camp experience on par with the best private paid camps in the city, improving health and wellness, developing social skills, and preventing summer learning loss. We are dedicated to improving both physical and nutritional literacy among New York's Edge participants through the implementation of a wide variety of sports, wellness, and fitness programs. Our programs encourage children to play more, have fun, and adopt healthy eating habits. New York Edge, its students and families are extremely grateful for the council's 32 years of support and partnership. We're now looking to you to meet the needs of the next generation of young people by supporting our FY25 funding requests. Thank you.
Thank you so much for your testimony. The next is James Du.
You may begin.
Or Dill. James. That's what I thought.
I'm Jim Dill, Executive Director of Housing and Services, Inc. We are permanent supportive housing serving 715 households in Manhattan and the Bronx and have funding from 2 DOH&H contracts. We are members of the Supportive Housing Network and support all the network's advocacy points for this hearing. First, we express our thanks to the Council for both, including provisions for reallocation of NYC 1515 resources in the preliminary budget response, and for instituting a COLA for over the next 3 years for the human services sector. The reallocation will vastly help the bold and absolutely necessary 1515 initiative to meet its ambitious targets. We are also very grateful for the COLA that will provide encouragement to our dedicated but chronically underpaid essential workers. We do express alarm about about what we understand is the mayor's executive budget's proposed 30% plus cut to HPD's special needs housing special capital funding. While we applaud the mayor's ambitious goals to increase affordable housing, the proposed cuts will only delay and prohibit the production of urgently needed special needs housing. HPD funding was the centerpiece of our latest development project brought online in 2022 with a DOHMH service contract. We are currently struggling with the development of a new project facing significantly higher construction and interest costs. We understand that there is an up to 3-year backlog in the HPD development pipeline that could make our new project unviable. To meet the affordable and special needs housing crisis, it is imperative that HPD's capital funding and staffing be increased and not cut. We will submit written testimony and thank you for your time today. And we are especially thankful for the COLA and for the reallocation.
Thank you for your time. Danielle Gerard.
You may begin.
Thank you, Chair Narcisse and other chairs and the committee members. I'm Danielle Gerard, a senior staff attorney at Children's Rights, which has been a national advocate for youth in state systems for over 30 years. We are a member of the Jails Action Coalition and advocate on behalf of young adults on Rikers. Providing home and community-based mental and behavioral health services is more important now than ever. Every day, most New Yorkers see the failure of our government systems to take care of our neighbors who are in desperate need of mental health care, supportive housing, and affordable housing. Every day, most of us do not see the failure of our criminal legal system, which continues to send people suffering from mental health conditions to the humanitarian disaster that is Rikers Island. Right now, 55% of people on Rikers have been diagnosed with a mental health condition and over 1,000 a serious mental illness. Young adults and adults on Rikers need treatment, not jail. Instead, New York City's taxpayers are funding the criminalization of mental health. The administration's proposed budget fails to adequately fund essential community resources that could keep young adults and others out of the criminal legal system in the first place. The city's recent budget cuts, among other short-sighted policies, make programming and mental health care all but unavailable on Rikers. The more than $500,000 it costs to incarcerate someone for a year on Rikers can and must be used instead to fund programs that are proven to result in better health and well-being for young people and adults alike, well before, during, and after incarceration, such as community-based mental health services, supportive housing, and truly affordable housing. The budget in its current state does not properly allocate funding toward any of the goals Children's Rights and other advocates have outlined in this and other committee hearings. We look to you and Speaker Adams to negotiate a fair, just, and reasonable budget that serves all New Yorkers, including young adults
Thank you for your
and adults
testimony.
on
Your time has
Rikers
expired.
and others living with mental health conditions. Thank you for the opportunity to testify. I refer you to our written testimony for details about each of these points. Thanks again.
And thank you for your testimony. Thank you for your time. Brendan Michael Gucci, are you on? Brendan? Right. Now, I'm going to call the names of those folks that's supposed to be online. If you hear your name, so please raise your hand or tap on it so we can see that you're still here. Brennan Michael, Isaiah Santos, Mary Soran, Myra Batchelor, Nora Takir, Opal Bailey, Sarah Bolden. If you can hear your name, please raise your hand on your key. Santos? Isaiah Santos? Raise your hand.
Yes.
Okay. You may, yeah. Isaiah Santos is on.
Begin.
Okay. Esteemed Council, I am honored to be here today representing the JCCA. My name is Isaiah Santos and I'm 17 years old. I had a pleasure of being at Second Chances. the Make It Work program. I was a program member in October of last year, and I'm delighted to continue my connection with the agency. In fact, I am honored to become an advocate and a vocal supporter of this program and its impact on the youth in our community. Firsthand, I witnessed how a group of strangers became a room of mutually beneficial and resourceful individuals. I heard about career goals and dream goals. I got to learn week after week how to prepare myself for the job world, and what skills would make me a standout candidate. I learned accountability, responsibility, time management, and professionalism. The best part about this learning experience was that it was held in a fun and approachable and in an approachable environment. Second Chances is a truly inclusive space with people who really care about us. I always felt that I could bring in my true self and concerns and be heard and seen. Even though at times we were given a lot of work, the payoff was always worth it. I grew in confidence, self-awareness, and community building. I am grateful for the additional investment in my future I received, and I'm so happy to get the chance to speak of my appreciation and gratitude for this program and opportunity. This program supports us and builds us up, opening doors for new futures. Thank you for your time.
Thank you, Mr. Santos, and I am so happy that you came to testify. You made my day, and you're gonna make New York City a better city for getting involved and engaged. Thank you. One more time, I'm gonna call the names. If you are on, please raise your hand. Brendan Michael, Mary Sohan, Myra Batchelder, Nora Taked, Opal Bailey, Sarah Bolden. Okay. Okay. All right. So, if you don't raise your hands, that means you're not here. You're not here to testify. You may also email. They're back. Sorry. So now, Mary Sohan. Mary.
Hi, everybody. Sorry about that. Okay. Hi. Thank you.
Now I should know. It's people that are working in the hospital.
Yeah, I am. Okay,
All right,
so
go on.
hi, everybody. My name is Dr. Mary Sohan. I'm a first-year emergency medicine resident at Harlem and Metropolitan Hospitals. I'm a first-generation American. I'm of Guyanese heritage. I was born here in New York City, and I was raised in northern New Jersey. I graduated from NYU. I did my pre-medical classes at Hunter College, and I went to med school at ToroCom in Harlem. Medicine was the second career for me, and so for me and many of my fellow medical residents, I've come out of school with a massive amount of student debt. I'm proud to serve New Yorkers, especially in Harlem, where I learned to become a doctor. And I know it's incredibly hard right now for all New Yorkers, and I see my patients struggling as I also see my fellow residents struggling. As residents, we not only work extraordinarily long hours, but we do incredibly physically, mentally, and emotionally demanding work. This is only made more difficult by our low salaries and the extensive time we've been forced to fight for fair pay. Over more than 9 months of negotiations and almost 2.5 years without a contract, we are still fighting for a fair contract. We aren't asking for much. We are just asking that our salaries stay in line with those of residents and our private safety net hospitals. Residents and the work that we do in this city is an important part of our public health infrastructure and our social safety net. The administration seems to have forgotten this or to simply not care, and I urge the council to continue to fight for us to get a fair contract so that residents like me can afford our basic necessities and can feel the respect that we deserve, but also, and truly importantly, to ensure that we are able to continue to attract doctors like me who come from and deeply care about the communities that we serve. Thank you so much for the time to speak to you guys. We just really hope that you continue to support our fight. Thank you.
Thank you for your work. Appreciate it. Next is Myra Batchelder.
You may begin.
Hi, thank you. My name is Myra Batchelder, and I lead COVID Advocacy Initiative in COVID Advocacy New York.
We are still in the midst of the COVID pandemic. We are still losing people in the US every week to COVID. Millions of people are still struggling with long COVID and other serious health issues brought on by COVID. As New York City Council discusses the budget, I urge the city to support COVID prevention, testing, and treatment, and support for people living with long COVID and other serious health issues brought on by COVID. One important step to take, New York City must provide funding for free, high quality N95 and KN95 masks and COVID tests for the public. Everyone should have access to the tools needed to protect themselves and their families and others from COVID. Many New Yorkers can't afford to purchase high quality masks and tests. In 2022, approximately 23% of New York City residents were unable to afford basic necessities like housing and food. And your ability to protect yourself and your family from getting COVID and to know whether you have COVID should not depend on your bank account. I urge New York City Council to provide funding and pass Bill INT 0332-2024 that will provide free masks, other PPE, and rapid tests to New Yorkers through the mail. Thank you, Chairperson Narcisse, for introducing this important bill, and thank you to Chairperson Schulman and all the other council members who have co-sponsored. At COVID Advocacy New York, New Yorkers have already sent in over 3,751 letters to the New York City Council in support of this bill. Masks and rapid tests should be distributed through the mail so that everyone can access them, including those at higher risk who are avoiding indoor public spaces. And people need to have access to these tools. New York City already provides free condoms and other health tools and should provide free high quality masks and rapid tests as well. Free masks are also important to help protect people from other airborne viruses as well as from bad air quality from wildfire smoke and other impacts, and people should have access to these tools ahead of time. In addition, free high quality mass and rapid tests should be provided to community groups and at public locations across the city. And free COVID PCR tests should also be made available at multiple sites. And these should not be ended. In addition, New York City Council must do everything it can to require masks and other COVID
Thank you for your
prevention
testimony.
efforts
Your
in all
time has
healthcare
expired.
settings. Ending the mask requirement in healthcare settings has led to many more unsafe medical settings, and people are postponing needed care. No one should have to risk their life and health to access healthcare. I urge New York City to take action on this. Thank you very much for your time.
Thank you for your time. Nora, is that Nora? Nora Tide.
You may begin.
Oh, hello. Hi. Dear council members, my name is Nora Tea. As a member of Second Chances with GCCA, I am pleased to be youth who is receiving wonderful life skills from my opportunity to be a youth advocate. This has helped me expand upon my interest in being a role model for other youth. The experiences at Second Chances has given me valued life skills I can utilize in my future career of becoming a lawyer. I've been given the chance to incorporate and expand upon my skills to benefit me in the future. Second Chances has allowed me to support the needs I want as a young adult. Furthermore, I have an outlet to a safe space to be myself and not feel judged. I felt I could learn and obtain knowledge for my growth in becoming a strong adult. At first, I did not want to come to the agency, even though other helping hands in the agency have helped me navigate through many trials and tribulations I have had to face by myself. However, without this program, I would not have gained the knowledge I use to this very day. Second Chances has allowed me to interact with other youth, provide connections, as well as support youths in the same position as me. I am really appreciative of the services provided by the GCCA and opportunities it has given me to prepare for the workforce while already working as an advocate for greater youth development in my country or community. Thank you.
Thank you. I'm happy to see young folks testifying. Thank you. I appreciate you. Next is Opal Bailey.
That's me. Okay.
We can't hear you.
Yes, good afternoon, Chairman Schul, Chair Lee, and member of the Health and Mental Health Committee. Thank you for calling this hearing and inviting JCCA and our young people to testify. My name is Opal Bailey, and I've been a therapist at JCCA for 6 years with experience in child welfare. Thank you for the ongoing support of our City Council Court Initiative Youth Mental Health Initiative, known at JCCA as Second Chances. Second Chance provides opportunities for young people who are court involved and provides preventive measures for youth in the community who are dealing with truancy, suspension, having fights in the community, and substance abuse. Second Chances does an initial assessment, and then we provide short-term therapy for 6 months. The counseling is individualized to the young people needs based on the initial assessment, and it can address issues such as trauma, grief, court conflict, and inappropriate sexual behavior. For those who need more long-term help, we provide referral to long-term care at JCCA, Article 31 Mental Health Clinic, JCCA Health Homes, and other community providers. Since 2017, youth the ages of 17 to 12, of 12 to 17 come to Second Chances to be part of a positive peer group while receiving a range of mental health, educational, and vocational support. Services are offered to youth who have already entered the system, as well as youth who are at risk, thereby helping young people at stages to avoid the juvenile justice system entirely. Second Chances also has a work readiness program called Make It Work, which successfully prepares youth to enter the workforce and prepares them much needed stipend. Graduates of the program return to talk specifically about this program and the money management coaching. Make It Work is extremely successful, often having 60 applicants for only 15 open slots per cycle. We provide
Thank you for your testimony. Your time has expired.
Get referrals from a variety of sources such as probation, ACS, schools, hospitals, and other nonprofit agencies. Thank you for taking the time to hear from us and the young people of Second Chances program.
Thank you for your testimony. Sarah Bolden. Bolden? Sarah. Sarah?
Yes. Hello. Good evening. My name is Sarah Bolden, and I'm the Managing Director of Leadership and New School Development at Student Leadership Network. Thank you for hearing my testimony today about the Young Women's Leadership Schools, 6 secondary schools in the 5 New York City boroughs, serving girls and gender-expansive youth. Like so many public schools across the city and country since the pandemic, our schools are facing profound challenges related to student mental health and wellness. These challenges show up as chronic absenteeism, academic underperformance, anxiety, depression, disconnection from school, and sometimes even violence on campus. There is more need for student mental health support than we can offer, which puts undue strain on our hardworking administration and faculty, which in turn impacts their mental well-being. Our schools rely on high-quality partnerships and programs to fill in some of the gaps that our in-school team does not have the capacity, training, or licensure to provide. We lost a longtime mental health partner last year that cost $150,000 annually, but we do have partners lined up to support our schools next year. For example, Love Mentoring, My Robin, School Consent Project, FemCho, Challenge Day, and also some programs focusing on physical health to add more of those essential opportunities that our students cannot typically access, such as Hidden Gems Archery and Mindful Miles. We are committed to bringing these resources to the schools, and financial support to make them possible would be critical to our schools and our students' success and well-being. Thank you so much for hearing my testimony this afternoon.
Thank you. Since we have no one online that want to testify, there's no one here in person, if you're here, you can approach the desk and see our sergeant. But since I see none, you may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. First, before I go, I have to say thank you to Velda Yagnik, financial analyst, Florentin Cabaret, unit head, Elizabeth Hoffman, assistant director, Chima Obichari, deputy director, Aisha Wright, deputy director, Jonathan Rosenberg, managing director, Michael, I've been sitting there and I messed it up, push it up. So Michael, thank you for keeping me on point. And to that, all the sergeant at arms that keep it going, thank you so much. Thank you, and meeting adjourned.